Welcome everyone to this FOGSI POGS International Virtual Conference hosted by Pune Obstetrics and Gynaecological Society. The theme of the conference is Just Tumors, Benign to Malignant, with special focus on Gynaecological Oncology. The conference is in association with AOFOG, ICOG, AGOI, ISO, and endorsed by SAFOG, ISMPO, AMOGS, ISPSM, PMS, making it a congress with national character and global participation. In these trying times, we wish to give you a wonderful experience that could be unique and would leave you enriched with knowledge. May it be keynote addresses by experts from all over the globe, their interactive exhibitions or e-posters, we have it all. Enjoy an array of keynote addresses by the likes of Dr. Alpesh Gandhi, our FOGSI President, Dr. Kazunuri Ochiai, AOFOG President, Dr. Robert Coleman, IGCS President, Dr. James Bentley, IFCPC President, Dr. Sudeep Gupta, ISMPO President-elect, and Dr. Shankar Narayanan, a pioneer in preventive oncology. There are 4 workshops, 8 panel discussions, and numerous lectures in our conference, which will be conducted simultaneously in 5 virtual halls over 3 days. We have received an overwhelming response of over 5,000 delegates, 22 international faculty, 260 national faculty, 120 oral papers, and 225 e-posters. Team POGS 2020 has worked relentlessly to ensure that you enjoy this scientific bonanza in the comfort of your home. My special thanks to Dr. Alpesh Gandhi, our FOGSI President, and Dr. Jaideep Tank, Secretary General FOGSI, and the office bearers of FOGSI for giving us this opportunity. And finally, I would like to thank our academic partners Zydus, Sun, MCure, Zuventus, Corona, Periwinkle, and Acumentis Pharma, without whose support this would not have been possible. So come, enjoy this unique experience at this conference that is like every other and yet unlike any other. It has been a pleasure. Thank you.
Okay, Nikhil, over to you.
All right, all of you, thank you so much for joining in and logging in to Just Tumors. To get started, I now request Dr. Harshad Parasnit, who's the President POGS, to kindly give the welcome note.
Thank you, Nikhil. Welcome to all the delegates for the second day of our conference, and we are going to be having two separate halls and this is hall number 1. And in this session, we start off with landmark trials. I welcome you all on behalf of Pune Obstetrics and Gynaecological Society and on behalf of FOGSI for this wonderful session. We have a jam-packed program right from 2 o'clock till 9 o'clock. Don't go anywhere, just stay tuned in. And more important than that, we have excellent faculty who is not only on the national level but also international faculty who would be joining in. Actually, we have the likes of Dr. Anna Fogarty who will be there in this session also. I will now hand over the mic and the proceedings to Nikhil to go ahead and invite all the faculty. One more thing before I hand over to him is that yesterday we had 4 halls which were running simultaneously and which had a fantastic attendance of more than 2,700 live to 2,800 people live. We have crossed more than 6,000 registrations. Now this figures are too large, looking at the fact that this is a super specialty conference, and I can see from all the members of AGOI who have been associated with the process of actually establishing gynecologic oncology in India. I'm very sure that it will bring a lot of smiles to their face, because yes, we are slowly and steadily actually establishing it as a subspecialty even in India. So back over to Nikhil. Please go ahead and start today's proceedings.
Thank you so much, sir. As we all know, today we've got first 3 talks in the first 30 minutes, followed by a panel discussion. And we have our first speaker, Dr. Kanika Batra Modi, and she's going to be presenting on desktop trial. Over to Dr. Kanika.
Just a word about
Thank
Dr.
you.
Kanika. Just a word about Dr. Kanika Batra Modi. She is a consultant gynecologist at Max Institute of Cancer Care. And I thought I had delegated her to speak on desktop trial, and no better person than her, because just a year ago in September last year, she had gone to Clinical SN Mitte, where she worked with Dr. Du Bois, and so who is the primary worker for the desktop trial. So over to you, Dr. Kanika.
Thank you, Dr. Manas. I hope I'm audible.
Yes, very, very clear.
Thank you. So
share your screen, please.
I have started to share it. Is it not visible?
Yeah, everything.
It's visible now? Yeah. So a very good afternoon, everyone. I'll be talking about the desktop 3 trial, which is a randomized...
Dr. Kanika, sorry to interrupt. Just you clear your background, so it is blur is coming on your face. So,
Madam, you could remove the virtual background, because since it's not a plain background, your face is not visible.
Oh, I see. I'm so sorry. I'll just do that. Just do that.
Thank you.
Dr. Kanika, it is perfect now.
Just unmute yourself, ma'am.
Audible, visible now? All well? Shall I start?
All well.
Thanks. So a very good afternoon, everyone. I'll be talking about the desktop 3 trial, which is a randomized controlled phase 3 study evaluating the impact of secondary cytoreductive surgery in recurrent ovarian cancer. Final analysis, which was presented this year at ASCO. So a bit of the background of all the desktop trials. So as we know that ovarian cancers, about 22% of them, they relapse within 6 months. And surgery and chemotherapy are the cornerstones in the management of ovarian cancer. However, the role of secondary cytoreductive surgery for recurrent ovarian cancer has so far not been fully defined. So the AGO desktop 1, desktop is descriptive evaluation of preoperative selection criteria for operability in recurrent ovarian cancer. So the AGO desktop 1 was basically an exploratory study, which was a retrospective analysis of the hospital records, and they came up with an AGO score which consisted of a good PS, complete cytoreductive resection during the first line therapy, and an ascites of less than 500 ml. So all these were the criteria that were defined. Then in the AGO desktop 2 criteria, these criteria were validated, and a platinum-free survival interval of more than 6 months, which is a platinum-sensitive recurrent ovarian cancer. And it confirmed the predictive value. So about 516 patients were screened, and this was a prospective multicentric trial. And of the 129 patients who had the positive score in whom the surgery was done, 76% had complete resection rate. So the validity of the score was established in this desktop 2 trial, and there was a 95% probability that complete resection would be done in the positive AGO score patients. So just talking about the other phase 3 surgical trials in recurrent ovarian cancer, it started with the EOR-TC and GOG-213 trials, which unfortunately closed and were aborted. So desktop 3 is practically the first randomized control trial, which opened in 2009, and the primary endpoint was overall survival, and the standardized patient criteria was developed on the basis of the desktop score and followed by randomization between surgery versus no surgery. There are other trials also, the SOC1 and the SOCCER trial. So talking about the design of the AGO desktop 3 trial, So they were essentially patients with first relapse, platinum sensitive patients with an AGO score positive, and 80 centers in 12 countries. And the recruitment was done between 2010 to 2015, and 407 patients were evaluated. So 408 patients, they were randomized between cytoreductive surgery versus an immediate platinum-based combination chemotherapy. So the first endpoint of this trial was overall survival, and there was a planned interim analysis which was presented at ASCO 2017, which showed significant PFS benefits for surgery. And the database was closed on 2020. So the sample size was 356 patients with a median follow-up period of 36 months, and the interim analysis was done at 105 events or death, and they targeted a p-value of less than 0.001. So talking about the patient characteristics between the two groups, the ones which underwent surgery and the ones which did not undergo surgery. So as we can see, the median age, the initial FICO state, most of them were in 3B4, high-grade serous histology. Almost all of them had received prior platinum, and similar amount had received prior taxanes, and a platinum-free interval of more than 12 months was present in over 75%. And the median progression-free survival was 18.7 months and 21.1 months. So no changes in between the two groups. Homogeneity was maintained. Then talking about these two groups again. So post-randomization chemotherapy, both the groups, they received platinum-containing chemotherapy. Similar and no changes in between the two groups between bevacizumab use and PARP inhibitor use. So we can see that it's maintained a homogeneity between the two sets. So talking about the surgery arm after this, the duration of surgery was pretty standard, and we can see that the complete macroscopic resection rate was 75%, which was pretty good. And there were standard, morbidity, mortality rates that were seen in the surgical arm. Now, talking about the outcomes of this trial, so between the surgery versus no surgery arm, we can see that there is a difference of median PFS of about 5.6 months with a significant p-value. And now comparing the arms, the ones which underwent no surgery, but the ones which underwent surgery but with residual tumor, and surgery with complete resection. So if we compare the ones which underwent complete surgical resection, they had a gain of PFS of 7.2 months, which came out to be significant. And surgery but with residual tumors fared worse in comparison to the ones which did not undergo surgery. Now comparing the overall survival between these groups, we can see that there is a gain of 7.7 months between the ones which underwent surgery versus the ones that did not undergo surgery. And that was also statistically at a p-value of 0.02. Now, if we compare this subset in which there is complete resection versus the ones in which there is residual disease. So in the subset which underwent complete resection, there is a gain in overall survival of 33 months versus the ones which had residual tumor. And if we compare this subset, the ones that underwent surgery with complete resection to the ones which underwent no surgery at all, there was a gain in overall survival of 15.9 months. So to conclude, Desktop 3 is the first prospective randomized trial showing an overall survival benefit of debulking surgery in recurrent ovarian cancer. Cytoreductive surgery for patients with a platinum-free interval of more than 6 months and selected by the AGO score significantly prolonged both overall and progression-free survival. The overall survival benefit was highest and exclusively seen in this cohort with complete resection, indicating the importance of thorough selection process of both the right patient and the center. So I'll just come up with this treatment algorithm that has been shared by Professor Dubois, and how he says, that the patients who come with relapse should be treated. So patients with first relapse and a treatment-free interval of more than 6 months, an AGO score which consists of a good PS, POGS 0, a situs less than 500 ml, and an initial complete resection, and the patient's desired comorbidities, imaging suggestive of a resectable disease and a good tumor biology. It needs to be at the right center with a good capacity and competence of the surgeons. Then an AGO score positive at the right center, you offer the cytoreductive surgery, and in 75% of the cases, a complete resection is possible. Follow it up with a platinum-based chemotherapy, and depending upon the further BRCA status, PARP inhibitor maintenance therapy. And in case the score is negative or other criteria are not fulfilled, you go ahead with chemotherapy right away. So I thank you all for your patient hearing.
Yeah, thank you, Dr. Kanika. So we are not having any questions because we are going to discuss each of these trials at a later half of the session, and that would be done by the panelist. But you made it quite clear about the trial. Our next speaker is Lieutenant Colonel Benign Roy. He is a gynecologist and is in the Department of Obstetrics and Gynaecology, presently at the Armed Forces Medical College of Pune. A brilliant surgeon and with a good lot of experience, who has served in the Army Hospital Research at Delhi, a premier institution.
Thank you, sir.
Vidhan, over to you, please.
Thank you, sir.
Vidhan will be speaking on Scorpion trial.
Is it okay right now?
Yes, Vidhan.
Yeah. Greetings from Armed Forces Medical College. Today I'm going to speak about the Scorpion trial. It is about a randomized trial of primary debulking surgery versus neoadjuvant chemotherapy for advanced epithelial ovarian cancer. It was published by the International Journal of Gynaecological Cancer in October 2020. So a little bit of background knowledge. The current understanding of us about the subject put forward by URTC and the CORUS trial was that the NSET is non-inferior to PDS for both progression-free survival as well as the overall survival. To sum it up, what they said that they have got different efficacy in the level of by the PDS and NSET, but all cases with high abdominal tumor load have similar prognosis and are independent from the presence of distant metastatic disease. So this is what is the background, but we understand that, that there is some limitations in these studies in the form of various distribution of the patients, as well as the low cytoreduction rate in the PDS arm, as well as the low accrual per center. So what Scorpion understood the limitations and tried to overcome these limitations of this previous trial. And what the Scorpion did is they set up two primary endpoints. Firstly, the superiority of the NSET, superiority of the NSET versus the in the interval debulking surgery versus the primary debulking surgery in terms of the perioperative care as well as the progression-free survival. This Scorpion had a secondary endpoint also in the form of overall survival and the quality of life. So with this, the study design was an open-label, non-inferiority randomized phase 3 trial on the epithelial ovarian cancer, fallopian tube cancer, and the primary peritoneal cancer. It was in a single institutional study with a high patient accrual, and with the computer-generated randomization was done into 1:1 ratio in both the arms. And a minimal follow-up of 3 years was planned after the treatment. So in the trial methodology, the patients were selected between the age group of 18 to 75 years in the presumed FIGO stage 3 and 4 or 4 with a ECOG of 0 to 2, and they were chemotherapy naive and adequate the biochemical parameters. And the trial excluded those who had got a history of cancer in the last 5 years or a history of pregnancy or breastfeeding. So the essential criteria for this randomization was, before the randomization, was that it should be a proven histological diagnosis on frozen section with a laparoscopic Fagotes predictive score of 8 to 12. So only the absence of mesenteric retraction was taken into account, and in both the arms there was a randomization of 1:1. So the arm PDS, the primary debulking surgery, was in the arm A, and the NSCT is in the arm B. So the primary debulking surgery was the standard treatment arm with the aim of complete resections, and herein the secondary cytoreductive surgery was not allowed when the gross residual tumor of more than 1 centimeter were there, and 6 cycles of paclitaxel were executed. In the arm B, that is the experimental arm or the NSCT arm, 3 cycles of NSCT was given before the PDS, and those with progressive disease were not allowed to go into the interval debulking surgery, right? So this progression was assessed by the RECIST criteria or the GCIG criteria. So finally, what we could see that the study, which was conducted between October 2011 and May 2016, they have enrolled initially 171 patients, and finally there were 28 rescissions of the deductions of these patients because of various reasons, and finally there were 71 in arm A and 72 in arm B. Now, the baseline factors, if you can see here, it's an amazing trial. You can see the age, ECOG criteria, the grading, the FIGO staging, the mean PI score were almost distributed equally between the two arms. So, and the chemotherapy was also equally given. It was a median chemotherapy cycle of 6 cycles in both the arms, and paclitaxel was the commonest given. And the administration of bevacizumab was done when it was given the license in, I think, in the Italy in 2014, and therein the bevacizumab was equally distributed, was equally used in both the arms as a maintenance therapy. Now, important point which I want to highlight as a presenter is that the p-value was significantly seen in 8 surgical outcomes, namely the rates of complete resection, the size of the residual disease, and the following things. Now, to me, this slide is very important. As you can see, the gross residual, the R0 resection was quite done in a lot of cases. In the PDS arm, you can see as much as 47, and totally, if you can see it, it will be around 92% in the PDS arm, the total optimal cytoreductions, as well as in the good amount of optimal cytoreduction in the arm B. Now, if you come below, if you see that there were 13 cases wherein no cytoreduction was done in the NSCT arm, it amounts to 14.9%. Now, you can see in both in this trial, there are a lot of upper abdominal procedures which was being executed, and it is seen that the operative time is almost 7.5 hours in the PDS arm, while it is around 4.2 hours in the NSCT arm. And you can see the mean hospital stay and all are quite, they are all statistically significant between the two arms. So the objective of perioperative, looking into the perioperative aspect, was well taken into account. Now, coming to the type and extent of the surgery, you see that a lot of diaphragmatic resections was done. I've highlighted these points, and you can see that around 96% of diaphragmatic procedures were done in the PDS arm. You can see that liver resections, quite a large number, 23%, bowel resections. But what I wanted to drive you at is that a lot of colostomy patients were done in the PDS arm. It is 52.4% compared to only 9% in case of NSCT arm. Now, if you see the pleural effusion from lung complications, it is quite high in case of the PDS arm. The real laparotomy, however, is not so significant. The pleural effusion is in fact more than the embolizations of the dehiscence, right? And you can see the mortality grade 5 complications. You can see the mortality is around 1.7 in early and to 12.9. So total mortality is around 7. Now, what I want to drive you at this point is the result efficacy. Although it was not too much statistically powered to look into that, but the median overall survival was higher, is almost comparable in both the arms. The complete site reductions I have already dealt with. This is the Kaplan-Meier trial. Now, coming to the discussion part, it says that the interval debulking surgery has got lower post-operative complications, and however, NSCT failed to show any progression-free survival advantage. Although they are similar in efficacy, but this study was underpowered to look into that. The pleural effusion, as I have covered, it is quite high in case of arm A, and there is this I have covered up. And but the point to note is that there is increase in the cytoreduction rates, raises the survival even in patients with high disease burden. Now, overall, this trial showed a 43 months prolonged median overall survival compared to the other studies. Right now, it also discussed about the insignificance of the complete cytoreduction, the abdominal tumor dissemination, and the residual tumor in the overall PFS and OS. But it rules out the A stage and the performance status in the PFS and the OS. Now, there is an important phenomena regarding this, the Venn phenomena here we can see in this trial, that the RO and the R1 cytoreduction has got superimposable behaviors. Also, the aggressive behavior of the tumor and the disease is also to be taken into account. Now, we see that in the Scorpion trial, the complete dissection was high, and we also find that in NSCT there was some progressive disease. So it also gives us a idea that there is urgent need for the molecular signatures for the study of the resistance to chemotherapy. Now, there were limitations in the form of underpowered, these not highly powered. The exclusion of the PARP inhibitor is a limiting factor, but the strength, weakness, and the scope of the study is that if you can add this data of this trial with the other data, there will be more statistical power to the objectives. Now, the strength is a single center strength, but it is the weakness is that it is difficult to generalize this data. So, to conclude, I find that the PDS and NSCT is a superimposable behavioral outcomes, but different in toxicity level, toxicity outcomes in the patients with high tumor load. The complete site reduction is effective irrespective of its timing, and the main prognostic factor at any surgery which has been given by this trial is that it is either the PDS or the IDS, it is the residual tumor which is the main prognostic factor. So this is the conclusion of this trial, and I think the highlights of these trials are there. A lot of things are to be discussed, but I'll leave it to my moderator to discuss further things. Thank you, Dr. Anna, for being with us. Thank you.
Thank you so much, sir. We have our next speaker, Dr. Manas. Your mic is on mute.
I said thank you, Dr. Bidhan, for that last slide. We're welcoming Dr. Anna also to the session. And thanks for completing it on time. And you've given all the details relevant for the Scorpion trial. Our next speaker today is Dr. Rashmi Rekha Bora. She's a young budding gynaecologist and consultant at the Fortis Memorial Research Institute at Gurugram. She's trained at Rajiv Gandhi Cancer Institute. Welcome, Dr. Rashmi. Dr. Rashmi will
much,
speak on Lion trial. Over to you.
Yes, sir. Thank you so much.
Dr. Manas, Dr. Rashmi is at Fortis Memorial Gurgaon.
Yes, I said that.
Okay. Okay.
Dr. Rashmi,
can you share your PPT?
Yes, I'm just sharing my PPT. Yeah, am I audible?
Yes.
Yes, ma'am.
Yes. Good afternoon, everybody.
Madam, put it full screen, ma'am.
Yes, just 1 second.
Okay. Yeah, it is there, ma'am. Go ahead. Yeah.
Okay, is this okay?
Yes, yes.
Good afternoon, everybody. A very warm good afternoon to everybody from Fortis Memorial Research Institute, Gurugram. I will be today speaking on the randomized trial of lymphadenectomy in patients with advanced ovarian cancer. That is the Lion trial. by P. Harter et al. But rough background is, we know that lymph node metastasis in ovarian cancer is very common. 44 to 53% of all FIGO stages have involvement of lymph nodes. These are some of the trials which were done and has also shown. Now, before the LION trial was there were a lot of retrospective studies which had shown potential benefit in systemic pelvic and para-aortic lymphadenectomy in ovarian cancer. But there were some biases in these studies, so we will not go into detail of those. There is one prospective randomized trial which we all know by Panisi et al., which was done in 2005, which had shown that there was some benefit in the progression-free survival with patients of ovarian cancer who underwent lymphadenectomy, but however, there was no overall survival benefit. Now I will straight away come to the LION trial. It was a randomized controlled multi-center trial, which was an interventional study, and there was no masking. It was an open label study. Now, the basic objectives were to assess the efficacy of the systematic lymph node dissection, and there were some secondary objectives which were to study the safety of systematic pelvic para-aortic lymphadenectomy. The trial was unique that it studied the quality of life and also the number of resected lymph nodes compared to the previous trials. Now, some of the inclusion criteria of this trial were that they took ovarian cancers who were of stages 2 to 4, but stage 4 included those cancers which were those tumors which were resectable, be it in the abdominal wall, liver, spleen. Now, intra-op, they had to achieve a macroscopic complete resection. Patients fell under the age of 18 to 75 years with a good performance score. Now, there were a lot of exclusion criteria like non-epithelial ovarian malignancies were not taken. Intra-op, if they found bulky nodes, they were excluded from the study. Recurrent ovarian cancers, if patients had prior chemotherapy, or if they would have had lymph, all these were excluded from the study. Now, the trial design of the study, there was a pre-surgical criteria, then eligibility criteria, macroscopic all, and then according to that, they would be asked whether to go ahead with the lymphadenectomy or not to go ahead. And these were the stratification factors in the covariate adaptive randomization. That was the trial center, patient age, and the performance status was taken. And to the renal veins. Now, this is a diagram showing the lymphadenectomy area that was covered in the lymph node dissection group. Now, these are the statistical analysis that was used. It was a well-powered study, and the overall survival and the progression-free survival, they were shown by the Kaplan-Meier and Cox regression models were used. Now, these were some of the histological types that underwent the surgery. These are some of the baseline characteristics which I have shown, the age, performance status, and the no lymphadenectomy groups. Now, the surgical procedures in both the groups included bilateral salpingo-oophorectomy, hysterectomy, omentectomy, peritonectomies, which in both the groups approached almost 90%. There hepatectomy in order to achieve a complete resection. Now, that has been shown. In the lymphadenectomy group was 65 months, and the no lymphadenectomy group was 69.2, which was not significant. Even the median PFS, as we can see, were similar. The intraoperative outcomes, if we see in the lymphadenectomy group, definitely the time that they took for surgery was longer than the no lymphadenectomy group. The blood loss, the transfusion rates of blood and plasma were more in the lymphadenectomy group. The readmissions to the intermediate or the intensive care unit, as we can see, were more in the lymphadenectomy group. The morbidity that was seen in the lymphadenectomy group was comparatively slightly higher than the no lymphadenectomy group. The patients who had infections, who needed antibiotics for their treatment were higher. Repeat laparotomies were common in the lymphadenectomy group, and the mortality was definitely slightly higher in the lymphadenectomy group as compared to the no lymphadenectomy group. So if we compare, yes, definitely the morbidity and mortality was higher in the lymphadenectomy group. Now, both the groups, as per protocol, received primary systemic therapy. Now, these are the survival graphs of overall survival, which did not show any significance, and the progression-free survival in both the arms did not show any significance. Now, the best thing about this trial was they also studied the quality of life. Now, in this, both the groups, as we can see, the global health status was not significant. Both the groups had the same quality of life. As compared to pain, was same in both the groups. Abdominal GI symptoms was same in both the groups. Peripheral neuropathy was slightly higher in the lymphadenectomy group, but it was not significant. The score levels were less than 10. So at the end of 6 months post-chemotherapy, both the arms were same. And if we see the physical function, slightly less, but they were not significant again. Now, the reasons for the relaparotomy that happened in the lymphadenectomy group were mostly because of the commonest was bowel leak or fistula formation. Others were hemorrhage, secondary wound healing, ileus infection. Now, if we come to see, we can see that patients, of course, this trial has been compared with the previous trial, which was done by Penisi. But this trial had overcome those faults which was there in the previous trial. And this trial had shown that ovarian cancer, when macroscopically completely resected, did not have any benefit of systemic lymphadenopathy. In fact, it added to the burden and some harm to the patients as compared to the morbidity. And it was not associated with better outcomes and higher incidence of post-operative complications. Now, the strengths of the LINE trial was definitely that it was a large prospective randomized trial, a multi-center trial. It was a surgeon and center proficiency requirements were there before performing this lymphadenectomy and before entering into the trial. And I think this is one of a trial which has given level 1 evidence as to whether to do lymphadenectomy in advanced ovarian cancer, which I think has changed the practice of most of the gynae-onco surgeons regarding whether to do lymphadenectomy or not in advanced ovarian cancer. The limitations of this trial was that there was a high morbidity and mortality in the lymphadenectomy group. So with this, I thank you, and over to you, sir. Hello.
Thank you, Dr. Rashmi.
Thank you, sir.
And that was a very good synopsis of the LION trial. So we have discussed, we have had speakers telling us about 3 landmark trials which have made an effect on change of practice.
Nikhil, hello.
Yeah. So it's now time
formally, can you invite Dr. Manas?
Dr. Manas, it's now time for the panel discussion. As you are the moderator, I kindly request you to take the proceedings further and also invite our panelists to please switch on the camera.
Yeah, I have.
And also unmute themselves. We have Dr. Anna Fogati from Italy. We've got Dr. Rama Joshi from Delhi. We've got Dr. Abraham from Vellore. We've got Dr. Anupama from Kochi. Dr. Jaideep from Kolkata, and Dr. Tony Hose from Kolkata as well. We welcome the panelists.
Yeah.
And I request Dr. Manas to please take the panel discussion further. Thank you.
Yeah, thank you. So, so we start a session on this landmark trials. You just heard our young speakers who have spoken on desktop trials, Scorpion trial, and
Dr.
Lion
Manas,
trial.
can you put it full screen, sir?
Yeah,
It's perfect. Go ahead, sir.
So I welcome our panelist, Dr. Anna Fagotti. She is here with us today. And Dr. Anna Fagotti is the director of UOC. I mean, she gave me a homework to find out what UOC means. It means Complex Operative Unit Ovarian Carcinoma, and she's the director there at the University of Polyclinic Foundation at the Catholic University of Sacred Heart, Rome, Italy. Welcome, Dr. Anna.
Thank you.
I welcome Dr. Am I right about the UOC?
Yes, correct. It's like a division.
Welcome, Dr. Rama Joshi, who is our second panelist. Dr. Rama is Director and Head, Department of Gynaecological Oncology and Robotic Surgery, Fortis Memorial Research Institute, Gurugram, India. Welcome, ma'am. Dr. Abraham Pidakil is our third panelist. He's a professor and head, Department of Gynaecological Oncology in the famed Christian Medical College, Vellore.
Manas, just a small correction. I have handed over the headship to Dr. Anita. So,
okay.
But I'm still in that unit.
Dr. Jaideep Bhaumik, he's a senior consultant and head, Division of Gynaecological Oncology, Tata Medical Center, Kolkata, India. Dr. Jaideep, welcome to the panel. Next panelist is Dr. Anupama Rajan Babu. She's professor and head, Department of Gynaecological Oncology at Amrita Institute of Medical Sciences, Kochi, India. Dr. Anupama, welcome.
Thank you, sir.
And our sixth panelist is Colonel Tony Jose of the Armed Forces. He's senior advisor and consultant in gynaecological oncology at the Command Hospital, Kolkata, India. So, without further, delay, we go and talk about the desktop trial. So, the desktop trial, to just summarize in Dr. Dubois' words, is the first prospectively randomized trial showing an overall benefit, overall survival benefit of debulking surgery in recurrent ovarian cancer. The overall survival benefit was highest and exclusively seen in the cohort with complete resection, indicating the importance of thorough selection process of both the right patient at the right center. And this is the comment he has made in this year, May 31st, 2020. So, Dr. Abraham, the trial actually started with making of the criterias. And could you comment on this conclusion of the trial? I put some things in bold, like what he has mentioned as complete resection, which we always know that it is complete resection which matters in ovarian cancer. He has mentioned thorough selection process, and he has mentioned right center. So what is your comment on his conclusion?
I think being a randomized controlled trial, the design being the apex of the hierarchy of study designs, we take it very seriously. And so we need to see whether the study has been done well. And I don't think there's any reason to doubt it. So the conclusion, I think, is basically what they're saying is the patient selection has to be based on the AGO as being a positive score. That is a ECOG status of 0, ascites less than 500 ml, and at the first surgery, there should have been 0 residual. So this is an ideal situation. So the correct selection of patients. The right center meaning, the surgeon has to be, surgical team has to be well trained to do a complete resection, because the advantage is seen only in those who had complete resection. So if there's no point operating if you cannot remove all the tumor.
So how in your center you assess the amount of ascites, since it's a very important criteria?
Well, clinically is, of course, we start with the clinical examination and then imaging will give you an idea.
Okay, so you get the volume from the imaging,
yes,
ultrasound. And tell me the implications of this.
Three-dimensional imaging also we do. So all these patients would have at least a CT abdomen, pelvis, maybe thorax, and the recurrent situation, we may even think of a PET CT.
So tell me the implications which is had in your practice or in your center with this trial.
Well, it has, we have, even before the results were published, we were doing secondary and tertiary cytoreductions. I think the patient selection also means correct histology. For example, low-grade tumors, definitely we would go back and, or pseudomyxoma. These are some of the histology which is very important. And of course, we are, after the trial, we are even more careful that we don't, operate unnecessarily, and that we are sure that we can remove all the tumor.
So many of the simultaneous trials, they have been also done with the medical oncologists and Dr. Anupama. So when medical oncologists bring out a paper like this, they would say that their chemotherapy has got similar results as this. So have you come across those kind of papers, and how would you fare this desktop trial as against the medical oncologist's view?
Definitely, sir, because the desktop is never discussed alone. When you discuss desktop, you always discuss it with GOG 213. So where they showed that surgery did not have any advantage over secondary cytoreduction, did not have advantage over chemotherapy for relapsed patient. So in our scenario, when we looked at this and when we discussed both this desktop and the GOG 213 in our practice, the chemotherapy given for the patients in the GOG 213 trial, which include majority of them included bevacizumab, which is still not included in for the patients in India. So our chemotherapy is more or less similar to the patients who are had chemo in the desktop trial. So I think the patient profile and the chemo profile is similar to the desktop trial in our patient population. And our medical oncologists also agree with this. And any recurrent ovarian cancer before taking up for surgery, we discuss in the tumor board. And as shown by Kanika in the trial, it is not just the AGO criteria. There are some additional criteria which includes the patient's willingness to accept the surgery. And there are certain locations of disease which might not be resectable. So all these criteria, the patient wishes, and in our country, the financial status of the patient also is taken into consideration, and that is discussed in tumor board, and then we decide whether this patient goes for a secondary cytoreduction or not.
Dr. Anna, so lately ESGO has introduced a certification system of the hospitals in Europe who would be able to do these kind of advanced surgeries. A small comment on that?
Yes, so I agree with all the comments up to now. And I want to highlight that the selection of the right center should be done based on the number of cases treated and the type of surgeries done in this special group of cases of patients. And so we with ESGO are running some certifications regarding accredited centers for ovarian cancer and for training of the young fellows. So I think this is a way at least to recognize some as able to do surgery. I want also to make two comments regarding the previous ones, because I think that what you said is both true. We also discuss all cases considering both data from desktop and GOG 213.
and absolutely agree. I want to highlight that the selection criteria considered within the desktop trial are somehow all. I mean, today we can include patients selected by PET CT scan or selected by, for example, staging laparoscopy when you think that patients can be resected, but then they have diffused carcinomatosis, which is not seen by CT scan or PET CT scan.
Yes.
And we may also think to include some patients who had neoadjuvant chemotherapy and then interval debulking surgery. So there is still one part of patients that could be included in this secondary cytoreductive surgery, but we don't know if it is effective or not. The last point regarding medical oncology is that we have some data that show, especially for PARP inhibitors, both at first line and at time of recurrence, that it seems they are more effective when we have no residual disease after surgery. So maybe we can combine the best effects from surgery and chemotherapy in order to achieve the best results in terms of survival.
Thank you, Dr. Anna. So since we have a time restriction, so we will go on to the discussion about the next trial. So this is your own trial, Dr. Anna. So the conclusion given by you is neoadjuvant chemotherapy and primary debulking surgery have the same efficacy when used at their maximal possibilities, but the toxicity profile is different. So I want you to tell us that what exactly you mean by their maximal possibilities.
Thank you. Thank you very much for this question, because I think it's needed to clarify. Now, the point is that when we designed the study, we were thinking that neoadjuvant chemotherapy was superior to primary debulking surgery in this specific setting of patients who have a high tumor load and who are very similar to stage 4 disease, where the sub-analysis of the ORTC trial and then the meta-analysis together with the CHORUS trial have shown that neoadjuvant chemotherapy is superior to PDS in these patients in terms of survival. So we wanted to demonstrate that this was true for all patients with high tumor load. But what we found is actually that it's not true. And we think the reason is that through high aggressive surgery, we were able to increase the median progression-free survival of patients receiving primary debulking surgery. So we had a high level for neoadjuvant chemotherapy, but we were able to increase the median progression-free survival from the group A, the PDS arm, thanks to the high rate of complete or optimal resection with respect to the oldest trial. This is when I say the maximal possibilities, this is what I mean. On one side, the surgery, aggressive surgery, and the other side, they use in this case in about 40% of the patients of bevacizumab. The toxicity profile is different. This is clear. I have received one question during the one chat that was, why do I say that is similar if we have such a high rate of postoperative mortality in the PDS arm? And the explanation is that for me, patients who cannot achieve interval debulking surgery because they are having progression of disease under neoadjuvant chemotherapy is like death. So if I say that this is on one side, these patients are going to die for surgery, the same rate of patients are going to progress under neoadjuvant chemotherapy. And this is similar to me. This is why I say similar toxicity profile.
So when you say toxicity profile, you mean toxicity profile of the chemotherapy and not the complications of surgery? No, Do you put the word complications of surgery also in the as a toxicity?
Yes, of course. Yes.
Okay. So Colonel Tony Jose, we would like to know about your experience and change in the practice as regards Scorpion trial. So you've been endless debates since Dennis Chi and the Yale group about NSCT and interval cytoreduction and the primary cytoreduction, and it has continued. And so what is your take on this in your high volume center here?
Yeah. So over the years, especially during our training, we were told that the standard of care is primary debulking surgery, and NSCT is possibly a second best option, whatever be the stage of disease. So many a times we would end up in a situation where maximum surgical effort, though attempted, could not result in an R0 resection. And we are all aware of what the experience of everyone is. Now, with the result of this trial and the 3 trials prior to this, the EORTC and the Chorus trial and the Japanese group trial, the possibility of NACT in a very advanced disease was considered at par with primary debulking surgery. Now, this trial, though it was primarily designed as a superiority trial to study the toxicity profile, as has been brought out, the co-primary endpoint was added later. And that is possibly the reason it is mentioned in the trial that survival difference of a few months possibly could not be assessed because the trial was underpowered. Notwithstanding all that, this trial has definitely changed practice. Number one, the selection of cases. Now we are very, very selective in taking up cases for primary debulking surgery. And prior to assigning a case for primary debulking, an extensive evaluation is done, radiological evaluation with the best modalities to assess the resectability of the disease. We definitely take into consideration the performance status of the patient. Now, extensive use of laparoscopy. So we somehow initially was shy in using laparoscopy for diagnostic evaluation or for getting a histological diagnosis. So nowadays, I think use of a laparoscope for assessing the tumor load as well as for getting a good chunk of tissue for histological diagnosis is the norm. In addition, whenever we go in for primary cytoreductive surgery, knowing that the primary endpoint, the most important prognostic factor is the residual disease, we go in with maximal cytoreductive effort. Now, on the other hand, once we assign a patient to neoadjuvant chemotherapy, use of bevacizumab, I think, has actually improved the prognosis. We have got enough evidence for that. So most of the patients do receive bevacizumab in addition to the conventional chemotherapy. And again, even after NACT, the surgery involves maximum cytoreductive effort and achievement of R0 being the final aim.
Sometime in 2007, 2008, I have had a chance to meet Dr. Ignace Workott. And that time he used to do a lot of radical surgery in ovarian cancer. He told that, 6 to 7 hours would be an average for doing a case. And the same Dr. Ignace Workott brought out the first paper in which he commented about neoadjuvant chemotherapy as or similar results. And one comment which he has made in one of his papers is, it does not matter about the timing of surgery. What matters is when you do the surgery, you leave the least amount of disease. So your comment on that comment, Dr. Anna.
Yeah, I completely agree.
Because you must have met Dr. Ignace many more times, than me.
Yeah, but absolutely, I agree. even though I think that the length of surgery is important even by itself. I mean, it's like a prognostic factor itself. It means that you are skilled, you have the support of your anesthesiologist, and how large and how big is the disease. So, I mean, they are very strictly correlated. However, the residual tumor is the most important prognostic factor up to now. And we don't know anything about molecular prognostic factors that I think will be the future for us to select properly patients for the right treatment. I mean, I don't say surgery well versus chemotherapy or target therapies. I think everything is useful to treat a patient. We just have to find the key, which is different from one patient to the other.
Thank you, Dr. Anna. So with this, we would go on to the discussion on the next trial. So the LION trial, which is the latest, and the conclusion which has been given is systematic pelvic and para-aortic lymphadenectomy in patients with advanced ovarian cancer who had undergone intra-abdominal macroscopically complete resection and had normal lymph nodes both before and during surgery, was not associated with longer overall progression-free survival. No lymphadenectomy was associated with higher incidence of post-operative complications. So what I wanted to know is what exactly is this interpretation of had normal lymph nodes both before and during surgery? Dr. Rama, if you'd like to comment on this. Dr. Rama, please check your audio if it's on mute.
I think it's a very, very important trial and very landmark trial, in fact. And while I was going through this trial, the same question had really, come to my mind also, though they had shown that all those patients who had the lymph nodes as normal before, prior to that of the surgery, as well as during surgery, at the time when the surgeon was assessing it with that of the retroperitoneal incision, right from that of the pelvic to that of the para-aortic nodes up to the renal vessels. When these nodes were not found suspicious by the surgeon, then the case was included into this particular trial of the randomization, whether this patient is going to go for the retroperitoneal lymph node dissection or no retroperitoneal lymph node dissection. I think they have not given any criteria by which they have assessed the retroperitoneal nodes prior to that of the surgery as far as the information goes, whatever my information regarding this article. Neither they have commented on how the surgeon had really assessed the intraperitoneal, during surgery also, that with the retroperitoneal approach, was it only the size of the node, or was the surgeon felt that the nodes are suspicious? Maybe sometimes the size is smaller than the centimeter, but we might feel a tiny hard nodes also, that is also taken as suspicion. So was this matter left to the surgeons on table? That is one thing. But I assume that these patients must not have had enlarged or suspicious nodes on imaging during while taking these patients into, or including the patients into this trial, as well as on table also there were no suspicious nodes as far as the criteria are concerned, but those criteria could have been defined in this particular trial. This is what I feel.
Dr. Anna, was your center a part of this trial?
Yes, we participated. Yeah.
Yeah. So how? So you could give this, this query that how was this assessment done, because the surgeons were all different.
Yeah, true. So preoperatively by CT scan, sure. And intraoperatively by size. But what you say, of course, each surgeon is different. I mean, we always resect those nodes who may be smaller than 1 centimeter, but hard at the feeling, but I'm not sure that the others made the same. I don't know.
Okay. So, Dr. Bhowmik, we would like to know, your experience regarding lymphadenectomy in ovarian cancer, and has this trial brought about a change in the practice in your center? Dr. Jaydeep?
Can you hear me now? Yeah.
Yes, yes. Yeah.
So, of course, it has made a huge change in the way we practice. Previously, all our patients, of course, we are a high volume center doing a lot of ovarian cancer surgery, more than 150 cases a year. And routinely all patients, no matter whether they were primary debulking surgery or interval debulking surgery, we would do a systematic pelvic and para-aortic lymph node dissection. Now, this, of course, that added to an hour and a half of extra surgical time. Of course, we are a teaching center, so we have to teach our students to do the operations. But of course, after this study, we have stopped using routine resection of all patients. If they had enlarged lymph nodes in a primary setting, if we have enlarged lymph nodes on a CT scan, we would go for lymph node dissection. If during IDS setting, interval debulking setting, if we had known enlarged lymph nodes in the pre-chemotherapy scan, then also we'll go for para-aortic and pelvic lymph node dissection. And again, every time we do the surgery, we will open up the spaces, palpate the nodes, because size is not always a criteria. We palpate the nodes, and it is the gut feeling of the surgeon that yes, you think the lymph nodes could be involved, you remove this. I take this opportunity to mention a small study we did at our medical center that was more than 6 years ago. Of course, nothing to do with the overall survival or the progression-free survival, but we found an important prognosticator in the lymph node metastasis. So in the small study, about 50 odd patients we took, and who all had interval debulking surgery. And on the scan, all these patients had normal looking lymph nodes. But as a routine protocol, we were doing lymph node dissection. And in those, about 42 patients had either of the lymph nodes positive. So almost 70–80% of the patients had a positive lymph node even after neoadjuvant chemotherapy. And not surprisingly, those patients who had positive lymph node had tumor recurrence within the first 1 year of it. 88% of the patients recurred within 1 year of their treatment. Those
sorry to interrupt, but sir, we are running out of time. I request our moderator, Dr. Manas, sir, if you could sum it up to.
Yeah, but I will, but there were just a few comments by some particular questions to Dr. Anna I have to ask. So just give us some time, a little bit. So
so much.
So Dr. Rama, just in very short, have you stopped doing lymphadenectomy?
We earlier, yes.
Following the LAN trial?
Earlier, following the LAN trial, there is some change in our practice. Actually, all those patients who had the enlarged or the suspicious nodes or on PET-CT positive nodes, even when the nodes are not palpable on table, we always go for the lymphadenectomy. But if these patients did not have any enlarged nodes and on PET-CT, these nodes were not lighted up prior to in the pre-operative assessment, and on table, these nodes are not enlarged and we are not able to palpate the para-aortic nodes, then we don't do the lymphadenectomy. Definitely, it has made an impact so that the duration of the surgery could be reduced by, you must say, an hour. And the post-lymphadenectomy, whatever the morbidity, increased morbidity, especially of the lymphocysts, I would say, and also the paresis of the bowel, this basically There is a difference when we are not doing the retroperitoneal lymph node resection. The perioperative morbidity is definitely less in these comparative patients, but majority of these patients have very extensive surgeries, and like that of the peritoniectomy, the diaphragmatic resections, the rectosigmoid resection, anastomosis, and maybe the bowel resections. So actually, overall, what I also feel, and I agree with this trial, actually, the results, that when these nodes are not suspicious prior to on imaging and also intraoperatively, then this is the subset where we should really change our practice of not doing the lymph node dissection.
Okay. So Dr. Anna, are you following the Lions trial by letter and spirit?
The Lance trial, yes, we are going to
following it by letter and spirit.
By what?
Absolutely following it. Absolutely yes. Following it. Lions trial in your center now?
Yes, yes, of course. Yes, we are not going to do any kind of lymphadenectomy, neither at time of PDS nor at time of interval debulking surgery if they are not detectable either by CT scan or intraoperatively.
So I have to ask you quickly about short comments. The organizers are telling us about time. So short comment on your Fagotti score. How did you evolve it?
You know, we are now running an app, so you are very welcome to join this app together with Ramirez in order to explain how it works based on the latest result. And I don't know if I have time enough, so just say that first check for peritoneal carcinomatosis and mesenteric retraction at the level of the superior mesenteric artery, if possible, and then go through all the variables that have been indicated in the entire score. So the diaphragm and bowel and upper left quadrant and so on. I don't want to be too long because I know we are in a hurry.
Okay.
So.
Okay, so we would, all of us are practicing, and that's one thing which has come up. Yeah, so anything, a score of 8 or more, non-resectable.
Yeah.
So what's your take on HIPEC in secondary cytoreductive surgery? You're doing a HIPEC in secondary cytoreductive surgery, or it's a trial going on?
No, the trial has been closed. It was closed around 1 year ago, and now we are waiting for the survival results before giving you some information. Anyway, a very similar trial has been published this year in ASCO from the Memorial Sloan Kettering, where they showed there was no impact, significant impact of IPEC at time of secondary reductive surgery in platinum-sensitive recurrent ovarian cancer patients.
I'm really sorry, so now we will have to stop this session because
okay. Let me just round it up. Dr. Nikhil, I'll round it up.
Yes, please, sir. Please
stop it. Yeah. So thank you. Thank you all, all the panelists here and the speakers who have made this particular session a landmark session. And so once again, thank you, Dr. Anna, for joining us, Dr. Rama, Dr. Abraham, Dr. Bhaumek, Dr. Anupama, and Bidhan, Kanika, and Rashmi Bora.
Thank you so much, sir. Thank you, panelists.
Thank you all.
I would now like to
thank you to the organizers.
I would like to quickly move to our next session, which is the Valva session. And I request our chairpersons, Dr. Jitendra Pariyar, who's joining us all the way from Nepal, Dr. Anand Bhalera from Pune, and Dr. Meena Patwekar from Pune to please switch on your cameras, unmute themselves. And in the meanwhile, I also request our first speaker, Dr. James Bentley, to also please start his screen sharing. Dr. James Bentley is the president, IFCPC from Canada. Thank you so much, sir, for joining in and also being a part of this conference, even though it's a different time zone at your end.
Hello. Hello.
Yes, sir, we can hear you.
Dr. Bhalera here. Now I request Dr. Jay to please start his lecture on management of pre-malignant vulvar lesions.
Good morning, everybody. Could you see my slides properly?
Yes, sir.
Yes, sir.
Okay, so I'm just, I think I'm okay there. And so good morning, everybody. I'm Jim Bentley. I'm a gynecological oncologist from Canada. I'm actually the past president of the International Federation of Colposcopy and Cervical Pathology. I'm going to talk to you today about management of vulvar.
Dr. Bentley, put it full screen, sir. Slideshow mode.
Yeah, okay. I'm just going to, yeah, I thought that was a problem. I'm going to end the show. Sorry, a second. I just took off a second. That's better there.
It's perfect, okay? Perfect, yeah.
So we're going to talk about management of premalignant vulvar lesions. A big topic in 20 minutes. I have no disclosures. Going to talk about the classification of some premalignant vulvar lesions, what is new, some epidemiology, how to recognize, and then more importantly, the management of some of these conditions. VIN classifications and vulvar premalignant classifications have undergone many changes over the years. Initially, we have the VIN classifications dating back to 1989, and many authorities still use VIN, many pathologists still use VIN, but this has been changed over the years, and in 2004, the International Society of Vulvovaginal Diseases created the terminology of just VIN and dropped VIN1. This was Mario Sideri's version, and they introduced a differentiated VIN, which was lichen sclerosus associated. Over the last 8 to 9 years, we've changed this a little bit further, and there was the introduction of the last terminology by Teresa Dara, and that looks at HPV-associated vulva lower genital tract dysplasias, and really just put them into L-SIL and H-SIL. There's a lot of controversy about introducing L-SILs back in again, because that might lead to overtreatment of low-grade changes which are not premalignant. And there was no mention of differentiated VIN. So the WHO in 2014 included the differentiated VIN and that low-grade changes and high-grade changes, and also included the other changes you can see here. The most recent iteration of change of terminology was the ISVVD's attempt to put all of this together in 2015, and they had the low-grade changes of the vulva and high-grade changes in the differentiated VIN. So differentiated VIN is a very important feature and needs to be recognized, and we need to recognize the importance of HPV in precancerous and cancers of the vulva. Singh and Gilkes, in a most recent review of pathology, sort of tabled it as such, and we have the HPV-associated vulvar cancers that occur in the 4th to 6th decade of life. They have associated risk of high-risk HPV, and their precursors are HSIL, with the biomarker expression of P16, and have a favorable outcome, much as we seem to be knowing from head and neck cancers that the HPV-associated cancers have a favorable outcome. The HPV-independent cancers occur later, are associated with chronic inflammation, and their precursors include DVIN and new categories that have been mentioned here, DEVIL and VAAD, and I'll just go into those in a second. The DEVIL is a differentiated exophytic vulvar intraepithelial lesion, and the VAAD is vulvar acanthosis with altered differentiation. These are less favorable in their outcome and less sensitive to any radiotherapy if they get a cancer. So to assess that, whether it's HPV as it's associated, you can do DNA in situ hybridization, which may detect incidental findings, P16 immunostaining, which will assess about 70% of the cases. If more than 70% of the cells express this, they are HPV associated. And P53 staining may be helpful in identifying the HPV independent vulvar cancers, and that is just a suggestion at this point in time. So their thoughts are that the VAAD is a precursor for verrucous carcinoma, but also can cause some low-grade vulvar cancers, and devil can be associated with high-grade vulvar cancers and the low-grade cancers. These are actually cancers, not precancers, and the DVIN causes high-grade cancers, and certainly that is all of our experience, because the DVIN is associated with cancers that are more difficult to treat. We know that VIN is increasing in incidence over the years, and the increase has mainly been in younger women, but particularly in countries where the patient population is aging rapidly, we are seeing ever increasing numbers of differentiated VIN in our referral practices. So VIN1, if you're using that terminology, is HPV only, is not neoplastic. VIN2 to 3, high-grade changes of the vulva, can regress. Untreated progresses to cancer and variable rates occur. If treated, there is a risk of subsequent malignancy of 2 to 5%, and risk of invasion at the time of treatment noted to be about 18 to 20% in different studies, and these numbers vary over the years. VIN can be symptomatic. It can cause pruritus, soreness, pain with intercourse, lumps, and can be asymptomatic in up to 20 or more % of cases. There are obvious associations with cervical intraepithelial neoplasia, perianal intraepithelial neoplasia, and where HIV is prevalent, obviously immunosuppression with HIV is a significant problem. We see lots of different features macroscopically, the colors, normal, white, aceto white, red, brown, or other. You can see vessel changes, particularly in the atrophic vulva. And the surface configuration can be flat, can be raised, can be micropapillary, can be condylomatous, can be villiform, etc. We're going to make a diagnosis by taking a close look at the vulva. Most of us would use a colposcope to do vulvoscopy. It's useful in selecting sites for biopsy. Acetic acid is controversial and doesn't really help that much. It can enhance some lesions, particularly on an atrophic vulva, but it can also make clinically unimportant HPV obvious. And in the past, prior to my career, people used toluidine blue, and I don't use that clinically myself. Obviously, when we need to take a biopsy to confirm things, use local anesthetic, xylocaine, or perhaps Emla cream. Take a punch biopsy either with a Keys punch, or occasionally with exophytic lesions, you can use a cervical biopsy forceps. Use silver nitrate for hemostasis, or apply Moncel solution plus or minus a suture. So just an illustration of some of the things we see. This would be a slightly irregular white lesion with some brown areas in it. This is all the same patient. It was on the inner and outer aspects of the labia minora, quite extensive across the whole posterior fourchette area, and some brown patches and irregular surfaces. This was suspicious in my mind when I actually saw it, and she did have a microscopically invasive cancer less than 1 millimeter in size. You can see raised condylomatous type lesions, like in this lady. You can see white lesions that have an irregular surface in this lady that is going across the introitus, coming down towards the anal area. And in this picture here, there is a wide area of red VIN that's got and some white plaques within it, with actually an associated cancer in the middle of this area of VIN. This patient was referred to me, and the gynecologist said, you have to see her, she's got a cancer. But all the biopsies he took came back as pre-invasive because he was taking biopsies from the outside of the lesion and not the central, more suspicious area. So what is the management? We have options for surgery. We have options for laser and medical options. I'm going to briefly go through these. Traditional surgery included use of skinning vulvectomy, excising the whole area. This is leaving some of the labia minora at the anterior area, anterior front. Traditional skinning vulvectomy included a grafting of the areas afterwards. This is more extensive surgery, caused problems with sexual dysfunction, and had recurrence rates that were still quite high, and recurrences were noted in the grafted areas. Sometimes you can use big excisions in association with a laser to improve the outcome. Wide local excisions, which is the commonest surgical modality used, excise the skin with 5 mm margins laterally and deep, just to go underneath the hair-bearing tissues. You can obviously preserve the clitoris and perform superficial excisions of lesions on the prepuce. And if you do that, hopefully you'll get regeneration of the epithelium and no loss of sensation. So it is said that if you get free margins with wide local excision, you will have a 90% success rate. If involved margins, the success rate goes down to about 50%. However, if you excise the tissues and you've got positive margins, there is no recommendation to re-excise the area. You can see here, those lesions were excised and just waiting for reapproximation, and this is reapproximation. Generally speaking, if I'm reapproximating things, I'm going to use interrupted sutures, leave the tails of the sutures long, avoid too much activity in the first period, good post-op hygiene, and anticipate that if it's a posterior lesion, the wound is going to break down 20 to 30% of the time, or perhaps even more, and you're going to have to let it heal by secondary intention if wound breakdown occurs. This lesion here that requires a slightly different technique because you've got the lesion that's extending over into the introitus, and you might want to immobilize the vagina. So in this situation, you can inject underneath with some marcaine or xylocaine with adrenaline to help with hemostasis, and then excise with 5 mm margins, excise the whole area. It always looks a lot bigger when you've excised it, and see here you've got close margins on the perianal tissue, you've got the vaginal margins here, and to bring those two together is a challenge. And so it's helpful if you put a finger in the rectum and separate off the vaginal mucosa from the posterior area there, get some mobilization, and allow you to pull down the vagina to cover over that area, which is similar to a flap you would do in the skin, and cover the defect with the vaginal mucosa. You can also do VY flaps. This was a lady that had multiple recurrences of initially HPV-associated disease. She had a vulvar cancer, she got a radiation, and had recurrences here centrally. And we did a VY flap, excising the central area and advancing on the subcutaneous tissues, a triangle of tissue, bring it together in the midline, and giving you some tissue for the perineal body there. And it did scar down to very small tissue, but it gave some skin in that area to help with healing. Differentiated VIN is a bigger challenge. It's very difficult to know where the margins are. This was an I think she's 83 or 84-year-old lady who had widespread lichen sclerosis associated differentiated VIN that was symptomatic. And you can discuss at length about what is the right thing to do with these patients. I elected to, after considerable thought, elected to take her to the operating room and to mobilize, to resect all of this area here, and to use rhomboid flaps to cover the area. So we, in the operating room, marked out the tissues for the resection and excised the tissues, and then brought this in. This is the immediate intraoperative appearance, and this is the postoperative appearance about 3 months, or probably might be 6 weeks to 3 months later, and you can see how she's got good healing in that area. Showing you the challenges of this, a year or 2 years later, she did end up with a recurrence of a DVIN again, and it's quite widespread in its recurrence, but you can do extensive surgery and patients will tolerate it well. If you go into laser tissues, a lot of people liked laser in the past. You need to have a laser, which is very expensive. It I usually use super pulse, and usually ablate rather than excise. And you need to go down to the third plane, which can be tricky to get down here to ensure that you've treated this properly. This is a lady that had quite extensive disease in the perianal area, going up here, and we lasered this. Took a very long time to do it, and that actually all was treated adequately with lasering of that area. And she had to stay in hospital for a little bit of time afterwards because it was uncomfortable. There is people who've got some experience with using photodynamic therapy. I have no experience with this. Various small reports over the years, and the most recent one I could find had 15 patients with a complete response rate at 1 year, but they're using LED lasers after applying 5-amino levulinic acid. Most commonly, a lot of us use imiquimod as a therapeutic agent in VIN and vulvar disease, and this is an immune response modulator that affects toll-like receptors and has been used extensively in VIN. The most important paper was a randomized trial that had 52 patients in it, and was published in the New England Journal in 2008 from Van Setters in the Netherlands. And they did see, they used it twice a week for up to 16 weeks, and the primary outcome was greater than 25% response rate. And as you can see here, they got an 81% response rate, with a complete response rate in about 35% of patients, and a significant response in other patients. So you need to have liver biopsies. Use it. I use it twice a week for 8 weeks. See the patient again. If it's doing well, they're tolerating it well, I encourage them to do it for another 8 weeks, and use it for about 1 to 2 weeks after the patient doesn't have a lesion, and re-review again, and excise for persistent disease, because in the trial they did have microinvasive disease in those patients that didn't respond. Just to note, you can get burning with excessive imiquimod use, and this patient couldn't void and had extensive ulceration on the inner aspect of the labia from using imiquimod. So just be careful and back off if patients are having symptoms, and use it less frequently. There is in Europe the drug called cidofovir, which is a antiviral agent. Has similar response rates and is applied 3 times a week for 12 weeks. In a randomized trial, it was equivalent. I've not used it myself as it's not available in Canada. The risk factors for recurrence of VIN includes age over 50, immunosuppression, and associated multifocal disease. Despite all treatments, about 25% of people will have recurrences, and these can be late recurrences. This group suggested prolonged follow-up. I must admit, I see my patients for about 18 months after treatment, and if they're okay, I would discharge them back to their primary care physician, because otherwise we would just have too many patients in the clinic. So a suggested algorithm from one of these papers, this is from my French paper, differentiated VIN on biopsies, excise either with a knife, or they would use a leap sometimes, and with high-grade changes, vulvar HSIL, topical imiquimod as their primary therapy. And I must admit, I do this in a lot of cases unless I'm really concerned about malignancy, or it's a very small lesion that I can just excise in the clinic. If they have success, they success. If it fails, surgery, and if surgery is not an option because of the positioning, laser, and some people would use CUSA as an option as well. Just very briefly, if I may, to go over Paget's. Paget's is red erythematous, looks almost like eczematoid skin changes with this typical, has been described as an icing cake change on the vulva, but it's diffuse margins and has associated classical pathological features with the Paget cells, with large nuclei and prominent nucleolus, which occur in clusters. It's rare in our practice in a referral center in Canada. When I last looked at our database, we'd had 23 cases in 20 years. The average age was 72, most people presenting with itching, burning, and irritation, and they often have multifocal lesions. The association with cancer has been reported as up to 54%. I must admit, I think this is an overestimate. There is an association with invasive Paget's at the time, and there are some patients that will have breast, bladder, urothelial cancers. And some of the patients with invasive Paget's will have, can have METs, obviously, and the same rules for excising lymph nodes of 1 millimeter depth of invasion apply. Ideally, if you're going to excise it, you need to use big margins and you need to go fairly deep because of the risk of invasion. And if you can get 2 centimeter margins, that is what is the recommended margin to use. There is increasing use of imicramod. There's been 25 retrospective case reports using up to 3 times a week to daily for up to 5 to 26 weeks. And with this, there were 64 women, 88% had a response and 67% had a complete response. So it does respond to imicramod. So I think if it's not for initial therapy, definitely for recurrent therapy, certainly better than mutilating surgery. And if he makes things smaller, that is very significant and allows you to do surgery on a smaller lesion, that is ideal. So if you're suspicious of Paget's, do a biopsy. If you don't see it, if you're a general gynecologist and you don't see it very often, consider referral. If there's invasion or associated mass, refer. Consider colonoscopy, getting a CT scan of the abdomen, pelvis, and urinalysis to make sure there's nothing going on in any of the lower genital tract or any other associated malignancies. And also mammography should be used as well. And the treatment ranges anything from expectant management to surgical management and imicramod. I must admit, I've had patients where there's supposed to have been a lesion, and by the time I see them, it's no longer present. And I think this waxes and wanes depending on the immune status of the patient, and this is probably why imicramod has a role, because it allows it to the patient's normal immune status to actually get rid of these lesions. So I know that was a rapid run through of vulvar disease, but pre-malignant vulvar disease requires careful evaluation. You need to use biopsies liberally to actually sort out what is going on. Some people would call this vulva mapping. And increasing evidence that topical therapies, particularly imicramod, are effective and do allow you to be less mutilating and have a better cosmetic response, less cosmetic effect when you excise. And surgical excision is still the mainstay of treatment. Thank you very much. And just to note and to invite you to the IFCPC World Congress, which was supposed to have been held in October, but we had to delay it. And it will be a virtual Congress from the 1st to the 5th of July in 2021. More information will be coming on the website shortly. And for those of you who are interested, the local groups in India are partaking in the cervical cancer prevention project and colposcopy training via IARC and IFCPC. And this is the Prayas health groups who are doing this across India. And if you want more information, please check the email and go to the IFCPC website. Thank you very much.
Thank you so much, sir, for keeping it on time as well.
Hello.
Yes, sir.
Yes, thank you, Dr. Bentley, for your excellent presentation. Your slides were excellent, very self-explanatory, and a very good take-home message was given by your lecture. Thanks a lot once more.
Thank you.
Is there Jitendra and Minal, my co-chairpersons?
Namaste from Nepal.
Yes.
Yes, sir. Okay, Dr. Sushil Kumar from Qatar.
Can you stop the screen sharing, please?
Yes, sir. Just start. We have our next speaker, Dr. Sushil Kumar Girisar from Qatar.
Nikhil, Dr. Pariyar, if he wants to make any comment, let him have a comment.
Yeah. Once again, thank you, Professor James. It was a very elaborate presentation on a very rare topic. So you've covered up everything from classification to the cause and even treatment modality. And of course, apart from surgery, we should not forget that there are medical management for these pre-invasive conditions, and they should be dealt properly. Thank you for the wonderful message.
Thank you.
Nikhil, we can go to the next session, next lecture.
Can we have Dr. S.K. Giri sir now to please present and switch on his camera?
Hello.
Yes.
Dr.
Hello.
Giri, you can start.
Yeah.
Could you please switch on your screen sharing?
I've already switched on it.
We can see it, sir.
You're not able to see it?
Yeah,
Yes, we can see, sir. Go ahead, please.
So we can start.
Okay.
Please go ahead.
So this is the management of good afternoon, everybody. So thank you, Dr. Harshad. This is the management of early invasive cancer cervix. This is I know the most important management is surgery, and these are all the cancer vulva. And so treatment of cancer vulva is a standard treatment is was radical vulvectomy, that is stressing way with en bloc ground dissections. Now there is a lot of paradigm shift in the management of vulva. So the issue of concern was that high rate of severity of wound complications, psychosexual effect of radical removal of the vulval tissue, urinary and fecal incontinence, vaginal contracture was there in that particular case, particular surgery type of surgery. Over treatment of early regions was there, and under treatment of more advanced disease was the common concern. So this was the radical twisting way of surgery. From evolutions has come during last 2 to 3 decades. Number of significant advances have been made in the management of vulval carcinoma. There is a paradigm shift from more radical to more conservatives, and without compromise of survival and without markedly decrease psychological and physiological morbidity. But these treatment should be individualized, and there is a vulval conservation of patients with unifocal disease, otherwise normal vagina. So we can do limited surgery in a CA vulva now. So this evolution has started like this, from radical vulvectomy to en bloc dissections to this en bloc removal. And this is a radical vulvectomy with triple incision. This is what we call is triple incision over here. And then modified radical vulvectomy with QAT. This is the place where we can do modified radical vulvectomy with a omission of lymphadenectomy was there, and anterior posterior hemivulvectomy. This is the anterior hemivulvectomy. This is the posterior hemivulvectomy, and this is the right hemivulvectomy. These are all the modified radical vulvectomy. Is only the this is the change. This is the more paradigm shift from the more radical to less radical and more conservative. So there is another one development is the sentinel lymph node mapping to eliminate immunofemoral lymphadenectomy can be omitted. Omissions of ground dissections in patients with T1 or 1A tumor with less than millimeter stromal invasions. Omission of contralateral ground dissection in patients with lateral or 1B lesions or negative ipsilateral nodes. Use of triple incision instead of en bloc dissection to prevent wound complications. Using radical local decisions with 1 to 2 centimeter margin. Now the margin is it is a lot of questions are there. Instead of complete vulvectomy, large negative margins is not required in surgery alone. Now it is this last guideline of British Gynaecological Society. Should be at least 2 millimeter. Less than 2 millimeter, there is chances of more of recurrence is there. Sparing the saphenous vein in attempt to prevent lymphedema. This is again big questions. There are many things against and in favor of sparing the saphenous vein. Elimination of routine pelvic lymphadenectomy is now not done. and adjuvant radiotherapy to reduce groin recurrences in case with multiple positive groin node. So on analysis of 2008, it was a Cochrane data analysis 2008. There was no difference in local recurrence rate between radical local excisions and radical valvectomy. Recurrence of tumor in the groin is similar between ipsilateral groin node dissection and bilateral groin dissection in women with well lateralized lesions. So now question comes here, and what is laterality? The lateral lesion is a definition of laterality is a tumor lying between the line drawn horizontally across the urethra. This is the line. This is the across the urethra. One line is there, and one line is drawing across the falsity, and this is called the lateral lesion. This is one can measure it, but or else, in other words, the lesion situated more than 2 centimeters from the clitoris, urethra, and posterior falsity is the lateral lesions. From this is the clitoris. From clitoris and this falsity, this should be at least 2 centimeters away. The lateral lesion is defined as one in which wide excisions, if you do wide excision with at least 1 centimeter beyond the visible tumor edge, would not impinge upon a midline structure. So this is again one definition of lateral lesions. This is midline structure are clitoris, urethra, vagina, perineal body, and anus. So now coming to really management of surgical management of vulval carcinoma. One is sentinel node mapping. This is one. Second term is vaginal phase of treatment. This is management of primary lesions and reconstruction of large defect. And inguinal phase of treatment is the omitting lymphadenectomy or unilateral lymphadenectomy, bilateral lymphadenectomy, and avoiding pelvic lymphadenectomy. There is points in favor of not going for pelvic lymphadenectomy, even if the lymph nodes, inguinal lymph nodes are positive. So sentinel node may replace routine inguinofemoral lymphadenectomy. This study has been validated in breast cancer and cutaneous melanoma. Multicentric observer study of sentinel node biopsy patient with negative sentinel nodes. The groin recurrence rate is low, survival is excellent, and morbidity is minimal. Negative sentinel node, no further surgery is necessary. Positive or no sentinel, if on sentinel node biopsy mapping there is no sentinel node is detected in, this is called the method failure, or if there is a positive, so we have to go for both bilateral groin node dissections. So eligibility, everybody knows about it. This is a primary squamous cell carcinoma. Lesion should be less than 4 centimeters in maximum dimensions, and microscopically is a unifocal cancer, and no clinical or radiological evidence of suspected lymph nodes metastasis. No known safety issues for use of patent blue dye and technetium 99. Informed patients consent and acceptable close follow-up, recommended 2 monthly in the first year once you have done SRNB. So it is a standard of care, and after that the groin, this is groin B2, groiness B2 study has showed that the patient with a negative sentinel node, it is safe to omit full lymphadenectomy. And there is another one study which goes that if it is less than or equal to 2 millimeter micrometastasis is found, only active will help. There is no need of adjuvant, no need of doing surgery for the inguinal node. But if more than 2 millimeter metastasis is found in the C requires surgery, and if it is more than 1 metastasis or there is extranodal extensions, so require radiotherapy. So these are all the points. So this is not the ideal case for sentinel node, but this is for the only demonstration purpose. We did the first case, and we can see after this is the only blue dye was given, and once it is infiltrated within 10 minutes or so, once we can find out this is the blue nodes are being found in the inguinal region, and this can be sent for histopathology, and or this is frozen section, and if it comes negative, one can think of, but in the particular case we cannot, because the lesion is quite big. So these are all this is the sentinel node, this is the diagram, this is the algorithm. If the clinically negative groin node is there, the stage 1A disease, no lymphadenectomy is required in stage 1 disease, and if it is a stage 2, stage 1B or stage 2, you can think of going for sentinel node dissections. If node is found detected, if detected and it is negative, no further lymphadenectomy is required. But if detected and positive, if not detected, most probably we have to go for immunotherapy and unilateral if the lesion is, if the primary lesion is less than 2 centimeter, lateral or lateralized lesions or squamous histology. And it can be when it is positive nodes are found intraoperatively, central lesions, we can go for the bilateral lymphadenectomy. So valval phase treatment is the modified radical valvectomy. It generally refers to radical removal of the portion of the vulva containing tumor, aimed to obtain 2 centimeter skin margin, sparing normal vulval tissue. It prevents the sexual dysfunctions and sense of disfigurement is not there. And one can go for clitoris sparing vulvectomy also. And triple incision technique is popularized by Hacker to reduce morbidity. The chief concern is possibility of increased risk of local recurrences. Later, an increased risk of secondary primary vulval cancer was also is risk. This is the vulval phase. It can be done. It is individualized. Mostly done if early stage. It can be done in the if less than equal to 2 centimeter or stage 1A disease. This is wide local excision without groin dissections, and 1 to 2 centimeter margin is there to go inferior layer of urogenital diaphragm. If invasion is more than 1 millimeter, this is one can think of going for the groin dissections. If it is 1B, 1 or stage 3, the 1 to 2 centimeter margin is required. Then, so reconstruction of vaginal defect is another problem, because problem arises in presence of large cancers, lesions over the perineal body or mons pubis or prior surgery or radiations when there is a large defect. Defect can be covered by primary closures, skin grafting, use of flaps, allow healing by secondary incision, secondary intention. It takes around 6 to 8 weeks. It can heal. So, but it gives a lot of problem to the mental problem to the patient. So it can be closed by primary closure, or it can go to different flaps. Different flaps are there. Flaps may be fasciocutaneous, myocutaneous, or other flaps, and VY flaps, as Dr. Bentley showed you, the flaps are there. It can be myocutaneous flap are there. So this is common flap. This is the easy flap, which I prefer mostly. Is the lotus petal flap, which depends upon the terminal branch of the internal peritoneal vessels. So it requires isolation of preservation of deep perforators. The width of the flap should be at least equal to the width of this is the width of the flap should be equal to the width of the defect. It's a robust, simple to perform, and cosmetically extremely acceptable. So this is a flap. This is a surgery of the small vulval lesions. We did the gynaecological with adrenaline is infiltrated to prevent oozing, and at least 2 centimeter margin is taken care of. So, but here we should go deep into the inferior layer of urogenital diaphragm. That is the most important part of radical valvectomy, then simple valvectomy, which don't have to go for the deep into the urogenital diaphragm. Here you can see the glistening structure. You will find out within just a second. There will be a glistening structure here, which will give you this is the urogenital diaphragm. And the other side we can do, we may not go all this. This is the clitoris is being removed because the involvement of clitoris was there, and this you can go very close to the urethra. You can also dissect the urethra if it is involved, and this is the pudendal vessels is being removed, ligated, and now we get the big area, big gap is there, which big gap can easily be covered either primary, but on doing primary closure will cause a lot of scarring and lot of the interstitial will narrow. So what we give is we lotus petal flap. This the flap looks like a petal of a lotus flower, and we can just you this is the apex of the flap. It goes, and now this area is close to this V separate area. This closed here, and this apex is close to that apex of the wound over here. Now this is the final outcome of this surgery of this lotus petal flap. So now there is a lot of cosmetics is involved in this flap, and you can see the final result out of this star is there. So these are all these different type of lotus petal flap which we do. And the groin phase is a linear incision made along the medial foot of line drawn between the anterior superior iliac spine and the pubic tubercle, about 1 centimeter above and parallel to the groin. The incision is carried through the subcutaneous tissue to the superficial fossa. Decision should be deep to the superficial fossa. It prevents skin necrosis. We can do legious incision is also, I prefer the legious incision, and there is a changing concept. This is the, as I told earlier, this is in a stage 1A disease, we do not go for lymphadenectomy, and it can be done in all stage 2 to stage 3 diseases. It can be unilateral if it is less than 4 centimeter and lateralized lesions, and lesion involving the anterior labia majora or the central lesions, bilateral incision should be done. So when GND is indicated, the superficial and inguinal nodes as well as the deep femoral nodes are to be removed. Only superficial nodes will not suffice, and pelvic node incision is avoided even if it is involved, because it does not have much of, we can take care of with this adjuvant therapy if required. Preservation of long saphenous veins may reduce both groin wound and subsequent lower limb problems. There are only one of the 3 femoral lymph nodes. They are always situated medial to the femoral vein in the opening of the fossa ovalis. No need of dissecting and exposing femoral artery and nerve. Sartorius muscle transplantation may be of benefit in preventing subsequent femoral vessel damage, particularly thin patients and in those in whom adjuvant ground radiation therapy is anticipated. And I had a patient of this femoral artery blowout. That's why from then I thought of giving this sartorius muscle transplantation. I have given few cases. Then after that I have abandoned this. So this is this shows the incision is there. Then we can go. We should go deep to the fossa camper. So that will save skin necrosis will be less. Now just you can see this fossa is the fossa camper, and beyond you should go to that deep to that. That's why there will be no skin necrosis out of that. And these are the nodes which are being removed. We can do with our cautery. We can do monopolar, unipolar, but sometimes I feel I'm happy with my scissor. And here I'm trying to. This is a. Now this is the saphenous vein is being this is saphenous gate. Saphenous vein is being preserved here. I try to preserve the saphenous vein, and then I'll go to this is the deep inguinal or inguinofemoral node, and this is the femoral artery. Okay. Now for the demonstration, I have tried to show the femoral nerve which is not required to be dissected at all. Then I have tried to just demonstrate how this sartorius muscle transposition is being done. It is not at all always required. It is required only mostly in thin patients when you suspect, when you apprehend that there is chance of femoral artery blowout, and this is how this is the and this now these are all these structures, and these are all this surgery after that. And in our data, we have done good number of cases, but it's 4-5 years old data. We have done this local radical excision 43 patients, and out of which no lymph node positive was in 18 patients out of 56 cases, 63 patients, and node negative was 38. Margin was positive in 4 patients, and we did lotus petal flap of around 12 patients, bilateral unilateral 12, bilateral 19, and sartorial transplantation was 5 cases during that time. After that, we have almost abandoned this. Ram flap, rectus myoclonus flap was 1 case. Adjuvant therapy is not taken with in 50% cases they didn't require, out of which around 44% they required radiotherapy, and out of 4% they required concurrent chemoradiation. A recurrence was, yes, there was local recurrence of 10. We could take care of this by surgery. Lymph node recurrence was 12, or 12%. Local recurrence was 3, and with different metastasis, one case had different metastasis. So now coming to the management summary. Stage 1A, radical local excisions and ground decision is omitted. Stage 1B to stage 1-3. Stage 3, radical valvectomy with GND, either unilateral or bilateral, is the treatment of choice. Sentinel node mapping is as indicated, as I have told earlier. Radiotherapy to groin and lower pelvis, if more than 2 nodes, root occult metastasis are there, microscopic involvement is there, or extracapsular spread is there. Radiotherapy to tumor bed, when there is LVSI, positive margins, high grade tumors, we can think of giving radiotherapy to the tumor bed. Stage 4A, concurrent chemoradiation followed by surgical resection in 6 weeks. The treatment should start within 6 weeks. And stage 4B is the palliative care. All cases suspected vulval cancer should have the diagnosis confirmed with a biopsy, and the biopsy should be incisional, not excisional, and reviewed by the specialist multidisciplinary team prior to medical treatment. Diagnostic biopsy is suspected vulval cancer should be representative of incisional biopsy, avoiding removal of the whole lesions. Wide radical local excisions with the primary tumor with a minimal 15 mm disease-free tissue is often sufficient. Now it has come down to less than that. There is no much of stress on the margin status. Groin node surgery should be undertaken through separate incisions, triple incisions, to reduce morbidity. The incidence of skin disease recurrence in early stage disease is very low. Groin incisions should be deep to the superficial fascia to prevent skin necrosis. Sentinel node biopsy should be offered to all women with squamous carcinoma of the vulva. Unifocal tumors of less than 4 cm maximum diameter, where there is no clinical suspicion of lymph node involvement, patients can be safely managed with removal of the identified sentinel lymph nodes. In lateral tumors, only ipsilateral groin surgery needs initially to be performed. Contralateral lymphadenectomy may be required if ipsilateral nodes are positive. Superficial groin node dissection alone should not be performed, as it is associated with high risk of groin node recurrence. Preservation of long saphenous vein may reduce both groin node and subsequent lower limb problems. Surgery is the cornerstone of therapy for the groin nodes in women with vulval cancer. Individual women who cannot be optimized to enable surgery can be treated with primary radiotherapy. Practice surgery involvement may be required for large defects and when radiotherapy has been used. The vulva is a challenging area for wound healing, and fecal and urinary diversion is required. Groin node dissection should be omitted in stage 1 diseases. Vulval melanoma need to be jointly managed with appropriate melanoma MDT. Primary and recurrent vulval cancer does not respond to chemotherapy, but responses are variable and toxicity may be a problem in population of patients. Future development of targeted therapy with drugs such as elontimine through mutation testing may lead to improvement in the vulval cancer treatment toxicity benefit ratio and provides effective systemic treatment even in the more infirm patients. Thank you very much for patient listening. Thank you.
Hello. Hello, Dr. Sushil Kumar, thanks a lot.
Thank you. Thank you.
Excellent presentation. Very sweet but very informative, and surgical skills exhibited were very, very wonderful. Dr. Jitendra, would you like to make any comment? Dr. Minal?
Once again, congratulations, Dr. Giri. Wonderful presentation and beautiful videos. And your message was very clear. Vulval cancer surgery has been modified over the time in the interest of good quality of life to the patient. So we should not forget other modalities like radiation therapy, adjuvant, and for larger lesion, probably neoadjuvant chemotherapy can be tried, which what would be your opinion, Dr. Giri? Any thought about neoadjuvant chemotherapy for large lesions?
Usually some trials are there, randomized control trials are there. In neoadjuvant chemoradiation therapy can be tried in a large tumors which is involved to the anal margins, urethra, and which might have needed the colostomy, all these things. So the treatment of choice, we can give neoadjuvant chemoradiotherapy followed by surgery. And we have done good number of cases. We have got a good number of cases and with this same thing. And yes, they do give a better result.
Thank you. Thank you once again.
Thank you.
Dr. Meenal.
Hello, Nikhil.
Hello.
Hello. Dr. Benign is there?
Nikhil, can you hear me?
Yes, sir, I can hear you. And I think it's now time for right. First of all, I would like to thank
Before you wind up, Nikhil, before you wind up, I would like to thank Dr. James Bentley for actually honoring our invitation and actually giving an excellent talk. Thank you, Dr. James, for being there for us. I know it's a very odd time at your place, though it's an evening.
Thank you very much. Yeah. 5 in the morning.
Good morning for you. Thank you.
Okay, thank you. Harsha, thanks a lot for keeping such an excellent presentation and excellent topic. And lecturers as well. And I'd like to thank and give all the best to the remaining conference.
Thank you.
Remaining conference. Thank you very much.
All right, it's now time for the quiz. All right, so we have a special quiz. That's right, we've got a live quiz. And the best part is the best answers and the fastest answers are going to be getting the prizes at the valedictory session.
Wow.
So, yes, so what we need to do is keep your fingers ready. And what you need to do is we're going to have some questions which are going to be displayed. The question is going to be displayed not more than for 20 seconds each. So get ready for your answers. Darshan, are we ready? Can we have the first question displayed, please? Each question is going to be displayed for only 20 seconds. Darshan? The quiz, you can get started with the quiz. You can all click on the live quiz. Can you see a live quiz icon?
Nikhil, it will be on the portal, live portal, so people can click on that. Okay.
Okay.
Here will display the same slide. Okay.
All right. Please do that. So click on the live quiz icon which is there. So can you please show us the slides, Nirav? We are going to show the slides, right? To answer the questions, you need to click on the top right live quiz icon. I hope all the attendees are able to see that. Once you click on it, you'll be able to see the question and also choose one of the options. I believe we were showing a small screenshot of the quiz, right?
Yes, Nikhil, perfect. Yes.
So this is just a screenshot, and he's just sharing the screen. This is how it's going to be.
No problem.
We would also like to thank Dr. Madan Roy for this entire session of quiz. Thank you so much, sir, for all the efforts that you have put in.
Thank you. Thank you.
Nikhil, just be strict with the time so that we start with the next session.
I think Darshan and Nirav, most of the doctors are able to see the questions because we can see a good response. So
Vidhan sir, we cannot see the question screen, sir.
because see, we have only more 30 seconds remaining.
Okay.
And then the attendees can then go on to the attendees link and click on the live quiz button to answer the question.
Yes, the questions are going on there on the portal.
Correct.
Yeah, yes.
So in the meanwhile, since we are all live, can we now move to the next session?
Yes.
Yes, sir.
Go ahead.
Thank you so much. So I would like to invite our chairpersons for the next session, that is the ovary session. I request Dr. Anita Singh from Patna to please come live. She's already there. We have Dr. Arun Nayak from Mumbai, and we've also got Dr. Jasnul Fardos from Bangladesh.
Jannatul Firdaus.
Janatul Fardos from Bangladesh. We also have a speaker, Dr. Rama Joshi, present with us. She's joining us all the way from Delhi. Can I request Dr. Rama Joshi ma'am to please switch on your screen sharing?
I request Anita Singh madam to please introduce our speaker, Dr. Rama Joshi madam.
Thank you, Dr. Ashwini. Good afternoon, everybody. And I thank Dr. Harshad Parasnis and his team for this invitation as a chairperson for the important session on ovary. And first speaker is Dr. Rama Joshi, and she is an excellent orator and accomplished gynaecological surgeon. I know her very well personally, and she's at present director and head of the Department of Gynaecology and Robotic Surgery at Fortis Memorial Research Institute, Gurgaon. So we are going to listen from her the fertility sparing surgery in ovarian malignancy. So Dr. Rama, I think you are there. Hello to you, and you can start presenting your.
Nikhil, hello. Dr. Rama is there in the earlier panel, but still we can't see Madam over here. Madam already logged out a few minutes back, like.
I think she just logged out.
Okay. Yeah, she not joined again. She thought that like she joined later on, but she's still not joined.
So can we have a next speaker? I can see Professor
we can start with the next talk.
Yes, Sari Kapan madam is there, yes.
Okay, then we can go with Professor Sari Kaplan Vilaylak. She is Professor of Obstetrics and Gynae, and she is also Deputy Dean for Academics and Culture, Ramti Bodhi Hospital, Mahidol University, Bangkok and Thailand. Welcome, madam, to India for such an wonderful event of ours. And you are going to talk on borderline ovarian tumors. We are eager to listen from you. So you please start presenting.
Good afternoon, everybody. Thank you, Professor Singh, Anita Singh, for the kind.
Before you start presenting, madam, I would also like
I'll share the screen.
Yeah, before you start giving your talk, I would also like to inform everybody that she is also the Oncology Committee Chairperson for SAFA, and she's also in the Oncology Committee of FIGO. So welcome, Dr. Sari Kapan.
Can you see my sharing screen?
No, we can see your share screen, but not the slides, ma'am. Yeah, put it full screen, ma'am. Yeah, perfect. Good to go, ma'am. Yeah.
Before she starts talking, I think I just want to put in a word that she is the Oncology Committee Chairperson for SAFA, and she is also the part of the FIGO Oncology Committee. Welcome, Dr. Sari Kapan, for accepting our invitation and being part of our deliberations.
Thank you very much. First of all, I would like to thank Dr. Parasnis and the organizing committee for inviting me to give a talk on the borderline ovarian tumor, what we must know. Since the theme of this conference is just tumor, benign to malignant, what's in between benign and malignant is borderline, and what's in between non-invasive and invasive is microinvasive. I'll cover the history and epidemiology, pathology, prognostic factors, diagnosis, treatment, and future direction. This entity of ovarian tumor began since almost 100 years ago. As you can see, the name has been changed from semi-malignant disease, low malignant potential, and to borderline ovarian tumor. The incidence is 10 to 20% of all epithelial ovarian malignancy, and 20% diagnosed at the age of less than 40 years old, which is pretty young though. 50% of the pathology is mucinous tumor, while 44% serous tumors, and the rest are endometrioid, clear cell tumors, respectively. Data from Ramatipadi Hospital, where I work, Ramatipadi Cancer Registry, as you can see, borderline tumor contribute 7% of all cancer and borderline ovarian tumor. The median age of diagnosis for borderline ovarian tumor is 40 years, which is pretty young. The risk factors are primary infertility, nulliparity, and the protective factors are using oral contraceptive, pregnancies, and breastfeeding. Even though, tubal ligation reduce overall risk of ovarian cancer and serous ovarian cancer, but there is no significant association to borderline ovarian tumor. The pathology, WHO classification tumor just this year divided the borderline ovarian tumor into serous type, mucinous, endometrioid, clear cell, seromucinous, and Brenner borderline tumor, respectively. As you can see here, in serous cystadenoma, there is one layer of tubal epithelium in comparison with the tufting and cell detachment in serous borderline tumor. 1/3 of case are bilateral, and 35% has frequent extra ovarian spread or peritoneal implant. Micropapillary serous borderline tumor characterized by the presence of finger-like epithelial rich papillae and more aggressive clinical course and more incidence of extra ovarian disease. Microinvasion in serous borderline tumor, it is characterized by small epithelial cell group within the stroma less than 5 millimeter in depth, according to WHO criteria 2014. The microinvasion in serous borderline tumor is more common in pregnancy. Coexist with other features which are extra ovarian implants, micropapillary architecture, lymph node involvement, and shorter progression-free survival, less feasible for fertility-sparing surgery. Analysis of the effect of microinvasion on the rate of invasive recurrence and disease-related death is especially difficult because of potential confounding factors. This is the photo of serous borderline tumor with microinvasion. It's look pretty aggressive though. Let's proceed to mucinous borderline tumor. 85% of mucinous borderline tumor nearly always unilateral, and it's intestinal subtype. 15% are endocervical subtype. It might be bilateral and associated with endometriosis or mixed borderline tumor. It has infrequent extra ovarian spread, but 2% positive disease at appendix. So in mucinous borderline tumor, appendectomy should be done. Microinvasion in mucinous borderline tumor it is not microinvasive. It is characterized by, it's pretty like serous tumor. Microinvasive carcinoma in mucinous borderline tumor, cases with microinvasive foci displaying high-grade nuclear atypia should be designated microinvasive carcinoma. This is the new entity of mucinous borderline tumor to pursue. The prognostic factor the prognostic factor of borderline tumor are fecal stage and histological type. As for recurrent rate is concerned, seromucinous tumor is the worst, followed by serous tumor, and then mucinous tumor respectively. Young age at diagnosis has better prognosis, while invasive implants, abnormal baseline of CA125, and micropapillary pattern are high-risk features. The diagnosis: borderline ovarian tumor is mostly asymptomatic. 75% of symptomatic patients presented with only one symptoms include which either abdominal pain or discomfort, bowel irregularity, and persisting fatigue or weight loss. Preoperative diagnosis, CA125, no significant difference in CA125 among benign, borderline tumor with invasive implantation. For CA19-9, not significantly different levels between borderline tumor and ovarian cancer. And HE4 is pretty much the same. So therefore, tumor marker doesn't seem to be helpful in preoperative diagnosis of borderline ovarian tumor. Now let us move to the imaging study. From a meta-analysis in 2017, as you can see, the pelvic ultrasound, the pool sensitivity is 77%, and the pool specificity is 83%. Regarding MRI, the pool sensitivity is 85%, and the pool specificity is 74%. So we can see that MRI is more sensitive than ultrasound in diagnosing borderline ovarian tumor. Which one is the borderline ovarian tumor? Yes, it's the B. As for gross examination or gross finding, probably intraoperative, the serous borderline tumor, usually the mass of the cyst is not that large, with fine, friable, and exuberant papillary excrescence, while mucinous borderline tumor is usually bigger, often larger than a foot, 30 centimeter, unilateral, multiple closely packed mucin-filled cystic locus. The fluorescence section can discriminate benign versus borderline or invasive cancer. The pool sensitivity is 97%, pool specificity is 90%, and discriminate between benign plus borderline versus invasive cancer, the pool sensitivity is 90% and pool specificity is almost 100%. The first section diagnosis of borderline ovarian tumor, we have 10 to 21% of final diagnosis that would turn out to be invasive cancer. The diagnosis accuracy of frozen section analysis of borderline ovarian tumor from a meta-analysis in 2018. As you can see, the pool accuracy is 80% with the sensitivity of 83 and positive predictive value of 81%, which is pretty good. Under diagnosis of 20%, over diagnosis of 10%. Factors associated with the misdiagnosis of borderline ovarian tumor is mucinous histology. So we have to keep in mind of this mucinous borderline ovarian tumor. The treatment, the surgery could be open or laparoscopy, depends on individual factors. If considered fertility sparing for unilateral ovarian involvement, ovarian cystectomy versus unilateral salpingo-oophorectomy, or for bilateral ovarian involvement, bilateral ovarian cystectomies, or unilateral salpingo-oophorectomy plus ovarian cystectomy. But if not considered fertility, so hysterectomy with BSO should be followed. The recommended surgical staging would include evacuation of ascites or cytological watching, omentectomy, multiple peritoneal biopsy, careful palpation and inspection of the entire peritoneal cavity and retroperitoneum in the abdomen, and resection of any abnormal areas or lymphadenopathy. The lymph node sampling is not part of the standard procedure in borderline tumor. Since lymph node involvement is rare in borderline tumor, especially in mucinous borderline tumor, lymph node positivity is not associated with recurrence or survival. The prediction of microscopic tumor by surgeon evaluation for contralateral ovary, the sensitivity is 88%, the specificity is 90%, and prediction for peritoneal involvement, the sensitivity is 70%, specificity is 93%, which are good, but surgeon evaluation of prediction for uterine surface lesion or omentum involvement, the surgeon prediction is not a good predictor at all. In patients with skipped omentectomy, the recurrence is significantly higher. Therefore, omentectomy is the most crucial procedure. In case of missing omentectomy, this question of reoperation should be followed. NCCN guideline just this year of ovarian borderline tumor or ovarian tumor of low malignant potential, if the surgery is complete surgery, surgical staging, and no invasive implantation, so just observe. But if with invasive implants, so adjuvant treatment should be undergo either chemotherapy or a chemotherapy. And if with prior incomplete surgical resection, the patient should undergo imaging study. And if residual disease is suspected, so adjuvant treatment either resurgery or chemotherapy, or just observed in selected patients should be undergone. And if by imaging no residual disease, so a patient can be observed with caution. Radical versus fertility sparing surgery group, there are similar recurrence rate and similar disease-free survival. So fertility sparing surgery in selected case of borderline tumor, there's no association with disease recurrence, no association with an increased risk of relapse in young patients with advanced disease at all. The fertility after treatment of borderline tumor, as you can see, 54% had spontaneous pregnancies. 34% of that were advanced stage. The role of ovulation drugs is under debate. Therefore, it should proceed with cautions and permitted in only women with early stage. Microinvasion in borderline tumor has early relapse after treatment. No different in overall incidence of relapse, disease-free survival, or overall survival. Fertility sparing surgery could be done with strict follow-up. Management should be as for a serious borderline tumor with an invasive lesion. As you can see from the table here, the relapse after treatment of microinvasive and no microinvasive borderline tumor are not significantly different. The survival of borderline tumor is excellent. For early stage 1-2, it's almost 100%. And for advanced stage 3-4, the survival is around 90%. The follow-up should be long-term and lifelong because of the possibility of delay recurrence. After conservative treatment, crucial close follow-up should be undergone. The follow-up protocol include pelvic examination, per rectum, transvaginal sonography, CA-125, every 3 months for 2 years, and then every 6 months for 3 years, and every 1 year thereafter. The future direction. Future direction on epidemiology include identification for risk factor for invasive implants, microinvasion and microinvasive carcinoma, recurrences, and death, as well as identification of predisposing heritable factors. Future direction on clinical management. Firstly, improving methods for preoperative and intraoperative diagnosis of borderline tumor, role of minimally invasive surgery, determination of risk associated with conservative treatment. Future direction on pathology and molecular biology, molecular studies to assess the relationship between serous borderline tumor and cancer, biology of microinvasion and microinvasive carcinoma entities of borderline tumor. In conclusion, firstly, borderline ovarian tumor is a specific entity with its unique natural cause. Secondly, management of borderline ovarian tumor is not the same as epithelial ovarian cancer. And last but not least, various aspects upon borderline ovarian tumor are yet to be explored. Thank you for your kind attention.
Thank you so much, ma'am. Without taking too much of time, I would immediately like to call our first speaker, Dr. Rama Joshi, who had logged off, but now she's back. Thank you so much. Can we have Dr. Rama Joshi, ma'am, to please start your screen sharing, ma'am?
Okay,
Good evening, everyone.
Dr. Rama, you have already been introduced in your absence.
Oh, I'm so sorry, actually, because of one or the other reason, I just logged off. But I'm back with it. I'm really sorry for this inconvenience caused to you all.
Ma'am, start this slide share, which is on the bottom.
I think I've already shared.
Yes, we can see it, but you'll have to just put it in the presentation mode.
Yes, I'm just putting it.
Yes, there it is.
Yes.
You can go ahead, ma'am. Thank you.
Good evening, all. And at the outset, I would like to thank organizers, especially Harshad, for giving me this opportunity. Fertility sparing surgery in gynecological cancers. We all know that once the woman suffers with that of the gynecological cancers, it matters with the age of the women. Younger the women, of course, we are concerned about their quality of life. And as we can see that SEER data that shows that in about 6.5% of the cases of the uterine cancers and 12% of the ovarian cancers and 36.5% of the cases of the cervical cancers, the women are younger than that of the 45 years. So once these young women, they come to us for the management of the gynecological cancers, where we all know that the radical surgery is the standard of care. And of course, the woman loses the uterus in majority of these cancers. And we are concerned about their fertility as well as the quality of life issues. So it becomes a challenge in front of all of us that when we are offering these patients the fertility preservation, first of all, can we offer them the fertility preservation? How can we select these patients for the fertility preservation? And on the other hand, we are concerned about the oncological outcome. And when we are extending the fertility preserving surgery, then we are concerned about the reproductive outcome also. So patient selection is very, very important once we are talking about, say, the cervical cancer. In cervical cancer, can we offer the fertility preservation? Yes, we can. We can offer the fertility preservation to the younger women who are in the stage of, say, stage 1A1, 1A2, and 1B1 disease based on the FIGO 2018. That is, the size of the tumor is less than 2 centimeters. This is very, very important. Though we are looking into even the depth of invasion, which should be, usually it should be less than 10 millimeters. And also we are concerned about the histology, what we are dealing with at the time of taking the at the time of selecting these patients. These can either be of the squamous cell carcinoma, adenosquamous carcinoma, or adenocarcinoma, but we have to be very, very selective. Adenocarcinoma should not involve the endocervical canal, and the lesion should be visible onto the exocervix so that the margins can be very well defined of that lesion. And also these patients should not have the evidence of the lymph node metastasis. That's how basically we are selecting these patients. MRI plays a very, very important role in all these patients in order to determine the local spread of the disease from in the cervix itself. So once it is 1A1 disease, then of course the fertility sparing surgery that will involve the cone biopsy, which is very simple. Cone biopsy is involved even the diagnosis of the 1A1 disease. But whenever we are dealing with the young patients with the proper workup, we take up these patients under the colposcopic guided cone biopsy so that we are taking proper margins from the lesion, if whatever we are identifying under the colposcope. And then finally, we subject it for that of the histology. If these patients have the negative margins, and usually the margin we take as 3 millimeters, or then of course we can very well follow them up and give them the fertility preservation by just follow up. But when these margins are positive, of course, we have to consider either the repeat conization, or we have to go for the radical trachelectomy or the trachelectomy in these patients, depending upon whether you find the LVSI positive or not. Once the LVSI is positive, we also have to consider the either pelvic lymphadenectomy. Of course, the chances of the nodal metastasis in 1A1 is 0.8%, less than 1%. But still, just to document, we require to go for minimum the sentinel node mapping that has already replaced the pelvic lymphadenectomy in these particular very early cervical cancer patients. So that's how you define the lesion. What you see here, you go for the proper conization, of course, under the colposcopic evaluation or guidance. And then, of course, you define the cone very nicely at what and submit it for the histopathology so that you can know where the margins are close and how you have to go for the reconization. That also one can determine. Concern about the oncological outcome in these patients, I think it was compared with that of the hysterectomy. And this is the 5-year survival rate is very similar to that of the cervical conization, especially in 1A1 disease. So we are very oncologically safe in these patients. Once the disease is 1A2 or 1B1 disease, we are considering the sparing, fertility sparing surgery. Then it is the radical trachelectomy and the pelvic lymph node dissection, which is recommended. We can replace the pelvic lymph node dissection with that of the sentinel node mapping. That's how these sentinel nodes can be mapped. Here you can see that this is the this is the robotic surgery where we can use the ICG and we can actually map the sentinel node. We can send it even for that of the frozen evaluation. And if it is negative, then we can take this patient up, or we can go for the 2-step procedure. The other, in the open surgery, what we can take up is the sentinel lymph node just by using the blue dye. The radical trachelectomy, of course, Dr. Dargent actually has is the pioneer in establishing the vaginal radical trachelectomy. And he had taken it as that of the 2-step procedure. In the radical trachelectomy, this is what I was fortunate to work with Dr. Dargent, and this is what is his institute. And he has taken it as that of the 2-step. He used to do laparoscopic pelvic lymphadenectomy, subjected for that of the final and histological analysis. When these nodes used to be negative, then he used to go for the radical trachelectomy in these patients. And that's how we can define the oncological outcome in these patients once we know that the lymph nodes are negative. That is a concern, especially in stage 1B1 disease, where the likely nodal chances that varies from about, say, 8 to 10% of the cases. Of course, it depends on the grade also. So the concern is the reproductive outcome whenever we are going for the radical trachelectomy. What is the reproductive outcome in these patients? And here we can see that it is very, very encouraging that so many patients, the live birth is 67%, but there is a concern about the first and the second trimester loss. This is mainly because of the reduction in the length of the cervix. There is 5 millimeter of the postio-vaginalis, which is being left. Of course, the cerclage is being applied at the time of the procedure of the radical trachelectomy. So the concerns are the first and the second trimester loss, but the data are very, very encouraging for the live birth rate that is about 67% of these patients. The concern was more in those patients where the radical trachelectomy was performed and the lesion was more than 2 centimeters, these patients had really a very increased recurrence rates. So far as the oncological outcome was concerned, the oncological outcome was also quite encouraging. And this is what was compared with that of the abdominal radical trachelectomy versus radical hysterectomy. As we all are concerned that how we can decide whether we can do this procedure in the younger patients without compromising the oncological outcome. And these encouraging results basically have given us the confidence of going ahead with these procedures. Of course, it varies from centers to centers who are performing these procedures of the radical trachelectomy in cervical cancer. So surgical and oncological outcomes of the abdominal radical hysterectomy as well as the trachelectomy have been quite similar, and the overall 5-year survival rates have also been found to be similar. This is what the survival rates in these cases, that these patients were followed up for even more than 5 years, and these are the 10 years results in these particular patients. So we are concerned about when the disease size is more than 2 centimeters and the patient wants the fertility, we are having only the ongoing trial, that is the fertility sparing surgery in Contessa trial, which is looking into the radical trachelectomy following the neoadjuvant chemotherapy in these patients. Another actually gynecological cancer, though it is comparatively much less in the younger age group, but it is the endometrial cancer. We are all facing this problem of the younger patients coming to us with the endometrial cancer patients. These are 5% of them. As you can see, the endometrial cancer patients coming to us in the younger age group. So here we have to select these patients very well before we go for the treatment for, you can say, giving them the fertility preserving option, because we have to define what is the size of the lesion, what is the grade of the lesion, how much is the myometrial invasion. So the patients, those who are having grade 1 lesion without any myometrial invasion on the imaging for which we have to go for the MRI, then we select these patients for the fertility preserving surgery. Any other high-risk histological subtype, we should not advise the fertility conserving surgery in these patients. And what is important is the endometrial pathology before going for the conception and also after the treatment, actually after the embryonic implantation has been developed. Later on at the end, when the patient has already delivered, then also we have to know what is the histology. So hormonal treatment is offered to these patients as a part of the conservative strategy. And it is important that till the patient conceives, of course, we have to have the endometrial sampling every 3 to 6 months. And the progestin usually is chosen. It can be given oral or it can be given in the levonorgestrel IUD. These are the 2 ways by which the progesterone can be delivered. The median time to regression is generally expected to be about 4 to 6 months in these patients. And the oncological outcome is here, these patients have about, say, the higher rate of the recurrence, and these patients are likely to progress. So we have to monitor these patients very closely. And once there is any progression, of course, we have to decide the definitive treatment for these patients. It has also been seen that the levonorgestrel IUD was found to achieve comparatively higher response rate in comparison to that of the oral progestin. But the hysteroscopic resection of this tumor in combination with the progestin therapy had a very limited evidence. So oncological and the reproductive outcomes, the meta-analysis had shown that the risk of the recurrence is about 14% in endometrial hyperplasia and 25% in grade 1 carcinoma during 39 months of the periods. And 36% of these patients had achieved pregnancy. And out of these 114, I mean, say all of the number of the live births were about slightly more. This is because of the twin pregnancies. So these data are also actually encouraging, but with the proper selection of these patients, this is what is important. Another important thing for the endometrial cancer patients is that we should not lose time. Once it is recommended that there is reversal of the histology, then these patients must be put on the assisted reproductive technology, using this assisted reproductive technology so that these patients can conceive early and they can have their pregnancy, live pregnancy, and then the definitive treatment can be done.
But we are running short of time. Could you please sum it up in the next few seconds?
Yes.
Thank you.
So I think, so with this, since there is no time, so I'm just, in ovarian cancer is another one. I think we all know about the ovarian cancer, non-epithelial ovarian cancers, borderline, and here the germ cell tumors, these are important, but even the fertility preserving surgery, we have to go for the proper surgical staging. And these surgical stagings are important and they are to be done. We can conserve the uterus as well as the opposite ovary, and retroperitoneal lymph node dissection, omentectomy, and the staging is done in the similar way. Whether it should be the unilateral or the bilateral, that remains the things to be debated, but the standard protocol is that we should do the complete surgical staging. And the meta-analysis, so far as the oncological outcomes are concerned, that has also shown that there is 11.4% recurrences with the median observation time of the 6 years, where we are going for the fertility preserving surgery. And it is important for us that these patients should be actually going for the completion surgery for after the reproductive outcome. And this reproductive outcome had been quite encouraging. Of course, many of the studies have included the patients more than that of the stage 1. So to summarize, the fertility preserving strategies in gynecological cancers, the ovarian reserve, we should really be assessing initially, and depending upon the age of the patient and the type of the cancer, we have to define and then give them the proper fertility sparing surgery. With this, I conclude and I thank you all.
Thank you so much, ma'am. It was a great talk. Chairpersons, I request you to please give the closing remarks and also invite our next speaker, Dr. Renita, who's waiting for us.
Yes, it was an excellent talk. And Dr. Janatul, do you want to comment on Dr. Rama Joshi's?
Yes, thank you so much. Actually, first of all, I'd like to give thanks to Dr. Harshad and to his organizing team for inviting me. And I think beautifully he has covered all the topics from benign to malignant, and all speakers, they also covered everything, especially Dr. Professor Sarika Pan. Beautifully, she has delivered a holistic concept in management of borderline tumor. And regarding Dr. Rama Joshi, actually she's a very good friend of Bangladeshi gynaecologist, and always she speaks very well, and she has also covered all aspects of fertility sparing surgery, and she stated that the results are promising, but it is very important to select the patient. So thank you all the speakers for your nice deliberation. Thank you.
Now, can we have Dr. Anita Borges from Mumbai to please start her screen sharing?
Can you see my screen?
Yes.
Yes, we're just going to be coming live, and yes, we can see it. Put it in presentation mode, ma'am, and we can hear you.
I've done that. Yes, can you see it now?
Yes, ma'am. Thank you.
Good evening, everybody. Thank you so much, Dr. Harshad, for having invited me over here. It's nice to see Rama after a very long time. Thank you so much, Rama, for that lovely little talk on, because the first time I ever heard the word trachelectomy was when you gave a talk years and years and years ago when I was at Tata Hospital. So thank you all of you for, and thank you the chairpersons also for that nice introduction. I also want to thank Nikhil, because I think I have been bothering him a little, you know, about whether I will come on and at what time I would come on to this session. So now that I've finished my little thanks, let me start with epithelial ovarian cancers. And essentially, I'm going to give you the perspective from a surgical pathologist, because that's what I've been doing all my life. Now, there are, everybody knows that epithelial ovarian cancers, you know, can be multiple. And I think Dr. Sarikapan actually referred to the new WHO classification of ovarian tumors, and you can get lost in the number of names that pathologists come up with, and they change from time to time. But let us say that I'm not going to do anything more than talk about the 4 common subtypes, because that's what we see in practice, and I no doubt you will also see in practice, and that is serous, endometrioid, clear cell, and mucinous. Now, what I wanted to really bring to the attention of gynaecologists, more to gynecologists in general, is that these are not all of these tumors cannot be treated in the same way, not by pathologists and not by gynecologists, because more and more we are understanding what is happening at the molecular level. And it is now well established that there are 2 pathways of tumor development for epithelial ovarian cancers, and that these 2 pathways are more or less mutually exclusive. And if we understand that, I think we will understand why these tumors respond differently to treatment. And I think Dr. Sarikapan talked about borderline tumors, which was very, I think, important, because borderline tumors belong on the type 1 pathway. And we'll see what this really means. You know, when I was a young person, it's very difficult for me even to understand that I was young once upon a time. There were just 2 kinds of tumors, benign and malignant, and there were no borderline tumors. In fact, my bosses used to tell me, there are only borderline pathologists. You don't know how to make up your mind whether something is benign or malignant, and therefore you want to put something into the borderline group. But it has become increasingly clear that there are indeed borderline pathologists. And this was very nicely covered by Dr. Sarikapan, where she, in the last part of her talk, she made it very clear that borderline tumors, even when they are stage 3 and 4, show you, which means that the peritoneum is seeded with the tumor. These tumors still have close to between 80 and 90% 5-year survivals. Now that is completely at odds with a malignant tumor with seeding of the peritoneum. So if you have a malignant tumor which has got a stage 3 and 4 disease, you certainly do not expect close to 90% 5-year survival. And hence it became obvious that there was a group of tumors that were borderline. I don't want to spend time on borderline, but when there was this malignant tumors, we used to call them well differentiated, moderately differentiated, and poorly differentiated. Today, we know that we don't, with the malignant tumors, we just call them low grade and high grade, and I'll talk about that in a minute. Borderline tumors are very much there, and when you take benign, borderline, and low grade malignant, they form a group which pathogenetically follow what is called the type 1 pathway. On the other hand, you have high-grade malignant tumors, and really there is only one real tumor that sits in this high-grade malignant group in the type 2 pathway, and that is a high-grade serous carcinoma of the ovary. So let's understand that there is a type 1 pathway and there is a type 2 pathway. And really, what is the difference between the type 1 and the type 2 pathway? The type 1 tumors have a low proliferation index. They have some recognized precursors. And the recognized precursors are usually borderline tumors and or endometriosis. They have a better prognosis, as we just said, even in stage 3 and 4. These tumors, including the low-grade carcinomas, are, have a long-term prognosis that is very good. And despite the fact that they are relatively less chemosensitive. And when we talk about chemosensitivity, I know that I'm talking to oncologists and gynecologists. We talk about standard chemotherapy, which is platinum-based and taxane-based chemotherapy. These tumors do not respond well to those kinds of chemotherapy, even if they are disseminated within the peritoneum. And if you will note what I've said there in red, they have frequent BRAF and KRAS mutations. And I know that this is not very palatable to people who are not pathologists and don't recognize molecular pathology, but it's as well to note this, because if you look on the other side, and that is the type 2 tumor, they are high grade, they have they are associated with a lot of P53 that is present, and everybody knows that many high-grade tumors have got P53 that is mutated. But the interesting thing was that this P53 signature was found also in the femoral end of the fallopian tube, and I will come to that in a while. These had a poor prognosis despite the fact that they are highly chemosensitive. So you give them platinum and taxanes, and the tumors melt, but they come back and they don't stay down. But the interesting thing about the molecular, which you will then be able to compare with what's on the left-hand side, is that there is loss of BRCA function. And this loss of BRCA function may be in the germline, so inherited from the parents. It may be because of loss of heterozygosity. There are many ways in which BRCA function can be lost, but it is lost in both sporadic as well as in germline mutated tumors. Now here is a little diagram which, if you look at it very quickly, and I'll explain it literally very quickly, the two, I would say, iconic tumors which exemplify type 1 and type 2 tumors are the high-grade serous carcinoma and the low-grade serous carcinoma. So the low-grade serous carcinoma belongs in the type 1 group, and the high-grade serous carcinoma belongs in the type 2 group. And if you look at it really carefully, you will see that the most common tumor that we encounter as an ovarian carcinoma is the high-grade serous carcinoma. And you see that it forms more than 70%. Some would say, it depends on your practice, 80% of all ovarian carcinomas. There is a precursor lesion, and I told you that is serous intraepithelial carcinoma of the tube, which is known as STIC, and I'll talk about it in a minute. There are some inherited syndromes in which you get this type 2 tumor, and that is, we all know the BRCA syndromes, in which you get breast and ovarian carcinomas. That's the main syndrome. Then you have these molecular anomalies, which I just talked about. There is, apart from BRCA abrogation, you have a lot of T53 in that, and that's why these tumors are chromosomally unstable. And if you're going to want to use, apart from chemotherapy, if you want to use targeted therapy, then these tumors are very sensitive to PARP inhibitors, which was actually something that the breast cancer people had been using for some time. And now the ovarian cancer people, because of the BRCA relationship are now being used, and immune checkpoint inhibitors. On the other hand, the epitome of a type 1 tumor is the low-grade serous carcinoma. It's not a common tumor. It's less than 5% of tumors. Its precursor lesion is the serous borderline tumor, and the precursor of a serous borderline tumor is a serous cyst adenoma. So that's all in that one type 1 pathway. We really don't know what, if it is associated with any inherited syndromes, but you notice here, there's nothing to do with BRCA. There is KRAS and BRAF, which is what we call the MAP kinase pathway. I don't think you need to know about this. So the MAP kinase pathway can be targeted if you want to use targeted therapy. So let us go now to show you what this type 1 serous tumors look like. And I've just recapitulated what I said when I was looking at that table. See, this is what we call a serous borderline tumor. And over here is the invasive, when there is an invasive component to what is essentially a borderline tumor, we call it a low-grade serous carcinoma. So this is the precursor lesion. And as I said, low-grade serous carcinomas, in 60% of these will show you a borderline tumor. Now, you already heard, so I don't want to repeat it, but remember that a borderline tumor can also have peritoneal implants. So it is not just carcinomas that implant the peritoneum or go to the peritoneum. Borderline tumors do. And these borderline tumors, funnily enough, can relapse in the peritoneum as low-grade invasive implants, which are low-grade invasive carcinomas, just telling you that benign, borderline, and low-grade carcinomas are all part of a continuum. And again, to tell you, response to chemotherapy is poor, but the tumor just happens to be indolent. So that is the paradox and the contradiction in these tumors. And if you look at the type 2 serous tumor, this is a high-grade serous tumor. You can see the histology of there. We've already said it forms 85% in many cases, but certainly more than 70% of all ovarian carcinomas, and 90% of advanced cancers have this kind of histology. The funny thing about them is they may not show any ovarian involvement. And we know, as pathologists, so often we make a diagnosis of metastatic ovarian carcinoma, serous carcinoma in the omentum, and the gynecologist will come back and say, but there is nothing in the ovary. It's quite possible that there's nothing in the ovary, because these tumors can arise wherever there is the pelvic peritoneum is. So many people, and I'm one of them, who regard these serous, high-grade serous tumors as being high-grade pelvic serous carcinomas, because the ovary may not be involved, but certainly you will find disease in the pelvic peritoneum, which then spreads to the rest of the omentum. Now, they are chemosensitive, yet incurable when they are at high stage. Now, what does all of this mean? I'm not going to this again, because I've already told you about BRCA1 and P53 mutations. I just want to re-emphasize once again that a low-grade serous carcinoma is not a precursor to a high-grade serous carcinoma. These are entirely two different molecular pathways. And on the other hand, high-grade serous carcinoma is not a progressed low-grade serous carcinoma. It does not happen. Of course, I don't like to say never in medicine, but if you have to think about it, it does not happen, because their molecular genetic pathogenetic pathways are entirely different, and I showed you those. And this has implications for therapy and prognosis, and also for early diagnosis. All right, if you want to do early diagnosis of ovarian cancers, you want to use ultrasound or you want to use other diagnostic methods, this has got implications. I'll just show you this, just a quick cartoon. You see, you have here the ovarian surface epithelium, which gives rise to a low-grade, or in this case, you would probably call it a benign serous cystadenoma, low-grade papillary borderline tumor. This is the more complex borderline tumor. All of this was shown to you by the previous speaker, and this is the low-grade carcinoma of serous type. And look at this, there are no precursors. You have the fimbrial end of the fallopian tube, which has got what we call a stick, that is serous tubal intraepithelial carcinoma. And the next thing that you get is a high-grade serous carcinoma with no in-between stages. Now, what is this stick? Well, it has now been discovered that this is what we call a P53 signature, that there is an in situ carcinoma in the fallopian tube. And this was discovered when, people did bilateral salpingo oophorectomies in patients who had these high-grade serous carcinomas, and lo and behold, they found that there was actually something abnormal at the fimbrial end of the fallopian tube. Okay, so what are the implications for the new concepts? One of them is for prevention. All right, when you do screening, you detect low-grade and borderline tumors, and this does not improve the death rates from ovarian carcinoma due to high-grade serous carcinomas. So, is it possible that you will be able to prevent ovarian carcinoma by doing salpingectomies in patients, maybe even fimbriectomies? And would this be sufficient for prophylaxis in familial ovarian carcinoma? I don't think it is sufficient for prophylaxis for familial ovarian carcinoma because, as you know, the entire pelvic peritoneum is at risk. And so oophorectomies have been done prophylactically, but a certain proportion of patients have come back with carcinomas in the pelvic peritoneum. And I don't mean this lightly, because now your own ovarian the American College of Obstetrics and Gynecologists has recommended opportunistic salpingectomy. Here it is in 2019. This is an AGOC committee opinion that says that opportunistic salpingectomy, based on the current understanding of this pathogenesis of high-grade serous carcinomas from stick, is a very viable alternative. Okay, the other thing is therapeutic implications. High-grade tumors can be treated with platinum taxane-based chemotherapy. They will respond, but very few of them will continue to respond, and therefore comes targeted therapy. You have PARP inhibitors, which are now being used, and also checkpoint inhibitor therapy. Low-grade carcinomas do not respond to platinum. So if they are at stage 3 and stage 4, some other kind of targeted therapy perhaps, or even ER and estrogen receptor therapy can be given. All right. Well,
time. Could you please sum it up in the next 20
fine.
seconds?
I'm going to I'm not going to talk about endometriosis and clear cell carcinomas because I think that's fine. We don't need to do this. I just wanted you to understand the story of the type 1 and type 2. So I'll summarize this, and that is that you must think of tumors of the ovary as belonging to either type 1 or to type 2 pathways. Type 1 pathway is not just serous. Endometrial carcinoma and clear cell carcinoma also belong in this type 1 category, because endometriosis and borderline tumors that arise in endometriotic patches, they can also arise in the ovary, and therefore these tumors are not going to respond to taxanes or anything that you normally would use for this really common type of endometrial carcinoma, and that is, taxanes now and PARP inhibitors. And I'm just throwing this out for your for consideration, because a lot of people are now talking about prophylactic salpingectomy, or as it is called, opportunistic salpingectomy, as a preventive strategy for ovarian carcinomas. So thank you once again. Thank you, Nikhil. Thank you, Dr. Harshad, and of course, Dr. Anita Singh and Dr. Firdaus.
Thank you so much, ma'am.
Anita, for such an excellent presentation and making type 1 and type 2 or borderline and high-grade serous ovarian carcinoma so clear to everyone, whoever is listening to your talk. And it was an excellent talk, and you have delivered it in such a short time so clearly. Thank you very much.
Thank you very much, ma'am.
Yes, thank you so much. Thank you so much, Dr. Anita, for your nice, beautiful description regarding the dual pathogenesis of ovarian cancer. Beautifully, you have explained. So thank you all.
I now request the chairpersons for our plenary session to please switch on their camera and also unmute themselves, starting with Dr. Parag Biniwale, sir, who is the organizing co-chairperson. I also request Dr. Ashwini Kale, who is the organizing secretary, and Dr. Parikshit Tank, who is the joint treasurer, FOGSI.
Thank you, Nikhil. And at this point of time, let me welcome President FOGSI, Dr. Alpesh Gandhi, who just joined. We are starting with a plenary session, which has two excellent speakers who are going to talk to us about different aspects of ovarian cancer. The first is, of course, our own President, Dr. Harshad Parasnis. Harshad, may I request you to start sharing your screen?
Yeah.
Dr. Harshad Parasnis is currently President of POGS and is the organizing chairperson of this conference. He's a gynae oncologist practicing at his own hospital and also at Bharati Vidyapith Medical College and Sassoon General Hospitals and BJ Medical College. He was formerly chairperson of Oncology Committee of FOGSI, and he is author of first textbook on gynae oncology in our country, which was released about 25 years ago. And now, Harshad, we are looking at the second edition of the same book. We are looking forward to it eagerly. Over to you, Harshad.
Thank you.
Harshad sir, we can see the slide. Good to go.
Thank you, Parag, for that kind words. I bring greetings from Pune Society. At the outset, let me welcome you all for today's conference, Just Tumors. And my topic today is surgery for early stage ovarian cancer, standard of care. Early ovarian cancer is always been a clinical dilemma for a gynecologist. Either we face with an apparently benign looking ovarian tumor where ovariotomy is done, and then we find that the histopathology shows malignancy, or we have a young female desirous of future fertility who comes with a suspicious ovarian mass, and in this case, there is the question, what should be the optimal surgery? In both these situations, we are in a dilemma situation whether to go in and do a conservative surgery or go in and do more extrapolative or radical surgery. In this case, the dilemma continues. And here, explorative laparotomy is the only answer, or surgery is only answer that is going to tell us about the ovarian masses. One of my colleagues at Tata Memorial Hospital always used to say, ovarian masses are like Pandora's box, and you won't know about them unless you open them and get them out. So surgery for disease apparently confined to ovary or pelvis is comprehensive surgical staging. And the goal for comprehensive surgical staging is to remove all the cancer tissue and evaluate the extent of the disease that is there inside, because based on that our decisions are going to rely on this comprehensive surgical staging, whether this patient needs further treatment or not. So there are certain questions that need to be answered when we are actually doing a surgical staging. That itself will explain to most of my gynec colleagues why, how, when, which route, whether fertility spotting needs to be done, and by whom. All these questions, if when answered, I think a lot of things would be cleared about how surgical staging for early stage ovarian cancer. So let's come to the first question. Why do we have to do? If you look at the independent predictor for survival, it is basically the residual disease or the adequacy of the surgery that actually is going to decide about the prognosis. And residual disease will actually have an impact on the disease-free and overall survival. So this is a very important point which has to be kept in mind when you are actually doing the surgery. The second point is that whenever we do an inadequate surgery, it leads to understaging, and understaging leads to undertreatment, and therefore there is going to be a poor prognosis. A study which was done early on by MS Piver also showed the same things, that poor inadequate surgery led to poor prognosis. So surgical staging in the first place, if it is properly done, would give rise to upgradation of the stage of the disease. That means we will come to know that it was not a stage 1 disease, but rather it was a stage 3 disease in 1/3 of the patients who were apparently stage 1 tumors. Secondly, when we do a early stage ovarian cancer surgery, we assign a risk to this patient after the surgery is done, either a low risk or the high risk. And based on that, our decision of whether to give her an adjuvant chemotherapy will be based on that. And as has been shown by many trials, that adjuvant therapy is necessary for high-risk patients to have a good outcome. Now, how do we do this surgery? Well, this is again a well-documented and well-prescribed method. We must take a vertical incision. Peritoneal fluid or lavage should be sent for cytology. Thorough examination of serosa and all visceral structures should be done. Biopsy of any suspicious area should be taken. If not, random peritoneal biopsy should be taken. The commonest, now here, the commonest sites sometimes which are missed are in between in the small bowel mesentery. That is where you must also look at whether there are any further deposits or not. Also, if she has completed her childbearing, then bilateral salpingo-oophorectomy and hysterectomy should be done. Now here again, effort should be done to remove the tumor intact. Unilateral salpingo-oophorectomy can be done in select patients where we are trying to preserve the fertility. Omentectomy should be done because omental metastasis would be the first thing that would be seen in these patients. Para-aortic and pelvic lymph node dissection should be done, and frozen section will help in pathological evaluation in case you are not sure whether these patients are actually cases of malignancy or not. Then come to the third question, when should we do it? Now this is a very important question, because we need to actually assess preoperatively, and we must try to see whether this is a suspicious tumor or not. If it is a suspicious tumor clinically, or if it is on a CT or a ultrasound based characteristics of tumor characteristics, or by size, or by tumor markers like CA125, alpha ketone, beta HCG. Now these are all the markers that were there, but the typical markers that we usually use is CA125. Now on CT or ultrasound, the features that would suggest are very well documented by the IOTA simple rules. And if again here, these rules, if followed, we would be able to actually identify those subset of patients who do need
to be, in which we need to be careful. And in the other group of patients who actually are low in score, these patients can be actually gone ahead and just done a conservative surgery. Coming to tumor markers in assessing whether this tumor is malignant or not, or suspicious tumors, we must remember few points. Just by having a CA-125 which is raised doesn't mean that these patients are going to have a diagnosis of ovarian cancer. Mind you, there are also certain physiological conditions in which CA-125 is going to be raised. At the same time, if the levels are less than 200, then endometriosis, tuberculosis, even these must be kept in mind. I think most of the gynecological oncologists must have had her case in their lifetimes when they have opened it and found that it was a case of tuberculosis rather than a case of ovarian malignancy. Another point that needs to be kept in mind is CA-125 is highly associated to serous tumors, but not to other histotypes. And that this is a very important point. Many times you can have a cancer in evolution, and you could have other types like mucinous would be present, and that has to be kept in mind. And the last thing is that CA-125 is raised in only 50% of the FIGO stage 1. So in the rest of the patients, the tumor expression may take time, or you are catching this tumor in a very earlier stage, wherein the rise in CA-125 is not that much. And so you have a false sense of security that you are dealing with a benign tumor. Now, in order to allay this problem of having physiological increase in CA-125, HE4 has been used rather well, and we have had a lot of scoring system that can help us to identify and get us out of this situation. But the bottom line remains that we must individualize every case and evaluate and then proceed. Few important points that I must share with you when we are doing a sonography is, whenever you have a sonographical picture of a simple cyst, many times ultrasound sonologists do tend to actually do a fine needle aspiration or take a biopsy. Please avoid that. Please do not upgrade the disease. There is no role for neoadjuvant chemotherapy in early stage ovarian cancer. So even just by the look of it, if it looks like malignant, don't give neoadjuvant chemotherapy. And this is a very important statement that all of us must remember. Tissue diagnosis is must prior to comprehensive surgical staging or prior to initiation of chemotherapy for any stage of cancer. I think in this today's world of medical legality, this is very important, that we must be pretty sure that this is malignancy before we do take any radical steps in either surgically or by giving her any chemo or radiation or any other therapy. Here, frozen section can come to our rescue. When you are having a tumor which you feel that appears to be suspicious, go ahead, do a frozen section. It will confirm malignancy, though your pathologist may not always be able to tell you about the type or the grade of the tumor, but at least for sure he can tell you whether this is malignancy or not. Next is, which route do we follow? Now, here either should we follow an abdominal, which is an established route, or the newer routes that have now coming up fast, a laparoscopic or robotic. Now, in laparoscopic, the role is as it is very much increasing nowadays. But the learning curve is most centers is still not complete. You need to be actually very good at your surgical skills if you are doing a laparoscopic surgery for ovarian cancer. And as of now, it is not recommended as a standard of care. It can be used in few centers. I know there are a few centers in Italy who are still using it very effectively, but it cannot be there as a routine, as a standard of care. I went to find in the Cochrane review about laparoscopy versus laparotomy for FIGO stage 1 ovarian cancer. And here the conclusion of the study showed that there was no good quality evidence to quantify the risk and benefits of laparoscopy for management of early stage ovarian cancer as routine clinical practice. That means we still need more studies to substantiate the use of laparoscopy. When we are doing laparoscopy, there is cosmesis, yes, but cosmesis at what cost?
Are we actually spreading the disease? Yes. Vergot et al. Clearly showed this, that rupture during surgery will lead to decreased disease-free survival in a multivariate analysis, which was done in a multi-institutional study, and therefore rupture should be avoided during primary surgery of ovarian cancer confined to the ovaries. Next is, can we do fertility sparing? Yes, we can do surgery only as a fertility sparing method, where either it is a unilateral malignant germ cell tumor like a dysgerminoma or immature teratoma stage 1A that is confined to one ovary, or unilateral sex cord stromal tumors, or unilateral borderline tumors, or stage 1A grade 1 epithelial tumors. Unilateral salpingo-oophorectomy may be performed, but mind you, when we are doing this fertility sparing surgery, comprehensive surgical staging must be done to identify this small subset of patients. When you do this comprehensive surgical staging, you will find that in 1/3 of the patients, you still are dealing with a higher stage disease. After doing conservative surgery for early stage disease, we must follow these patients with tumor markers and ultrasonography for the remaining residual retained ovary till her childbearing is complete. And after her childbearing is complete, then the uterus and the remaining ovary should be removed at completion surgery. The reason for that is there is a 9% chance of recurrence in these patients. And lastly, who should be doing this surgery? Again here, an independent predictor of survival is actually the performance of the surgeon. That means the knowledge, skill, and the training of the surgeon is very essential when he or she is trying to do these type of surgeries. Everything requires training in medicine. Early exposure in the curriculum is essential. I think there is a lot of lacunae on this count, and I think the training which is now being imparted in most of the institutions is actually overcoming this lacunae. On training issues, a study was done to understand whether specialist gynecologist or somebody who's trained in gynae-oncology surgery, what is the outcomes when the patient is done, operated or treated by a surgeon, a general gynecologist, and a specialist. It was found that a specialist, that is the person who is trained in gynae-oncology, will have a much better outcomes. That means the patient's survival data will have much better progression-free and overall survivals. This was a study which is a Scottish national study. And here again, the relative risk will be much less with a gynae-oncologist treating the patient. In short, someone who's trained in gynec cancer surgery, rather than a general surgeon whose risk would be 1.33. So, to summarize, for a better outcome, guidelines for comprehensive surgical staging must be followed. Frozen section needs to confirm malignancy before proceeding to staging laparotomy in cases of dilemma. Fertility sparing surgery can be performed in select cases, and surgical training in gynecologic oncology is essential for a better outcome. Thank you all for a patient hearing.
Thank you very much, Harshad. It was indeed a comprehensive presentation. Thank you. May I request Dr. Parikshit to introduce Professor Kazunori Ochiai?
Thank you, Dr. Benivale. It's indeed a pleasure to be introducing Professor Kazunori Ochiai. He is the president of the Asia-Oceania Federation of Obstetrics and Gynaecology, and he's a professor at the Department of Obstetrics and Gynaecology at the Jiki University School of Medicine, Tokyo. He's what one would associate with the word world authority when it comes to gynecological oncology and especially ovarian cancers. So it's indeed our pleasure and a privilege to be hearing from Professor Ochiai today at this conference on just tumors. Professor, please.
Parikshit,
thank you very much. I would like to, yes, and I'm okay. Can you see my screen?
Yes, sir. Good to go.
And
Yes.
can you hear my talk?
Perfect, sir.
Yes.
All right. Good evening, esteemed members and distinguished guests. Ladies and gentlemen, I am honored to be invited to deliver a plenary lecture today. Today, I would like to discuss some primary debulking surgery in advanced ovarian cancer patients. As you are aware, the primary debulking surgery is the most important part of the treatment of advanced ovarian cancer. I have nothing to disclose on this lecture. Here is the content of my lecture. Ovarian cancer is the most common death among female genital malignancies. Advanced stage is considered an important prognostic factor, and the prognosis of patients with stage 3 and 4 is very poor. In addition, the ovary is an organ in the pelvis. Even if a tumor develops, subjective symptoms are rare at an early stage, and about 40 to 50% of cases are stage 3 and 4 at the time of diagnosis. In other words, improvement of treatment results for advanced stage patients is an incidence and mortality, and it's in other words, improvement of treatment results of advanced stage patient is at most the urgent issues for as an gynecological oncologist. And the incidence and the mortality of ovarian cancer in the world are reported as 6.6 and 3.9 respectively. Looking at the ovarian cancer morbidity and mortality rate in the world, you can see that it varies from country to country. Furthermore, looking at the trend in the incidence, it can be seen that UK and Japan is on an upward trend, but the France or the USA are clearly on a downward trend. The number of ovarian cancer cases in Japan is on the rise, as shown in previous slide. And it was reported as 10,438 cases, and the incidence rate is 11.7 in 2015. The number of deaths from ovarian cancer is also increasing, with 4,745 cases, and the mortality rate is 2.9 in 2017. Ovarian cancer treatment is an utmost issue in gynecological oncology in Japan. Since the development of and approval of cisplatin was in 1978, and the survival rate for the 5-year survival rate for ovarian cancer has not been improved significantly, despite the development of breakthrough drugs such as paclitaxel, bevacizumab, and PARP inhibitors. 5-year survival rate was reported to be 47% in 2015. Therefore, it is clear that the surgery still plays a crucial role, especially in the treatment of ovarian cancer. The primary surgery is the first step of ovarian cancer treatment, and it ensures accurate diagnosis and ensures tumor tissue for additional testing. The other purpose of the operation is to perform surgical staging and reduce tumor burden. Next, I'd like to consider the significance of site reduction. Disease-related symptoms, such as abdominal pain, increased abdominal growth, abdominal discomfortness, dyspnea, and satiety are related to tumor burden. Removal of bulky disease rapidly improves symptoms and quality of life. Ovarian neoplasms produce multiple cytokines, at least some of which are immunosuppressive. Interleukin-10, vascular endothelial growth factors. Thus, removal of tumor bulk may improve or restore host immune competencies. The degree of completion of surgery is a particular important prognostic factor. The volume of residual tumor remaining after cytoreductive surgery correlates inversely with survival. And the important impact of cytoreduction of survival has been reported repeatedly. Thus, the goal of surgery is to remove all macroscopic disease. This is level 1 and grade A evidence. So why does cytoreduction improve prognosis? The mechanism for the survival benefit with cytoreduction is that the chemotherapeutic drugs exert their maximum effects on small tumors that are well perfused and therefore mitotically active. While large-sized tumor is associated with polar perfusion and a greater chance of sublethal cellular damage, as well as the emergence of multi-drug resistant clones. Optimal response to post-operative systemic chemotherapy is achieved in the setting of minimal disease burden. Prior to an attempt at debulking, predicting which patients will be able to have at least an optimal site reduction can be useful, given the importance of an optimal cytoreductive effort on outcome and the potential morbidity associated with performance of major abdominal surgery. Clinical evaluation is taking into account the general condition and nutritional status of patient. PET is not recommended as part of the standard workup for stage 3, but it is optional for some cases of stage 4. There is a limit to examining resectability in diagnostic imaging and laboratory examinations. Thus, it should be considered surgical staging, surgical evaluation. There are two keystone reports. One is Sugar-Baker's peritoneal cancer index, and the other one is laparoscopic evaluation by Fagotti score. For Sugar-Baker peritoneal cancer index, 12 parts of abdominal organs will be checked through median laparotomy and scored by the size of the lesion from 0 to 3. Peritoneal cancer index scores above 17 should not offer aggressive surgery because they do not provide any survival benefit to those patients. This is level 2 grade A evidence. And Fagotti laparoscopic scores that evaluate abdominal organs laparoscopically at the site for omental cake, peritoneal carcinomatosis, diaphragmatic carcinomatosis, mesenteric retraction, bowel infiltration, stomach infiltration, and liver metastasis. Each parameter is attributed a score of 0 to 2. Site reduction is incomplete in 100% of patients with a score above 8. This is also level 2 and grade A evidence. The laparoscopy is the better way of assessing initial resectability because it is less invasive than open surgery. This is level 2 grade A. And primary debulking surgery must include at least complete hysterectomy with bilateral salpingo-oophorectomy, infragastric omentectomy, appendicectomy, pelvic and aortic lymphadenectomy, and debulking tumor tissues. You may perform lower anterior resection of the rectum, splenectomy, partial hepatectomy, diaphragma resection, and peritoneal resection if those organs are involved. And many methods have been reported for para-aortic lymph node dissection procedure. I start from the treating the right ovarian vein. And while following the right ovarian vein, check the inflow to the inferior vena cava and ligate and cut. Then remove lymphatic tissues or parainferior vena cava. Next, the renal vein on both sides are exposed and lymphatic vessels are ligated at the upper edge, which will be the upper limit of lymph node dissection. Hereafter, the lymph node tissues is systemically cleared in this order. However, in the dissection of aortic lymph node, special attention should be paid to congenital malformations of blood vessels. Perhaps many of the audience has experienced twice or 3 times of these anomalies. Particular attention should be paid to the persistent left inferior vena cava and horseshoe kidney. Now, assessment of lymph node metastasis is crucial to define stage of disease. Therefore, lymph node sampling or lymph nodectomy is essential for diagnostic purpose. However, its therapeutic role has been controversial. Many studies to date have shown that the frequency of lymph node metastasis increases as the disease progresses. Lymph node metastases are observed in more than 60% of patient P23. Our study found that lymph node dissection had a better prognosis than those who did not. but this was a retrospective study. My dear friend Benedetti Panici of Italy conducted a prospective randomized study to see the significance of systematic lymphadenectomy on survival of advanced ovarian cancer patients. What he found was that there was a significant difference in progression-free survival, but not in overall survival. He interpreted that post-progression treatment dilute the difference in two groups. This is also our study. Although there was no difference in overall survival between with or without lymphadenectomy, the difference of survival became significantly if you look at drug-resistant cases. These results suggest that surgical removal of possible metastatic site will contribute to improve prognosis in drug-resistant cases. However, it also suggests if sensitive and strong drugs are developed, aggressive surgery may not be needed in future. This is a famous Lion study. A total of 647 advanced ovarian cancer patients randomized to with or without lymphadenectomy group. The median number of removed nodes was 35 from pelvic area and 22 from para-aortic area. And 57 nodes are removed in total. And survival and complication were compared in two groups. This illustrates survival curves of lymphadenectomy group and no-lymphadenectomy group. Those are almost identical, and overall survival and progression-free survival are not statistically different. However, post-operative complications such as incidence of repeat laparotomy and mortality within 60 days after surgery was much higher in lymphadenectomy group. In patients with advanced ovarian cancer who underwent complete surgery intra-abdominally and had normal lymph nodes, systematic pelvic and para-aortic lymphadenectomy did not prolong survival, but it was associated with a higher incidence of post-operative complications. Therefore, they did not recommend systematic lymphadenectomy to advanced ovarian cancer patients as a routine practice. Thus, the systematic pelvic and para-aortic lymphadenectomy is a part of debulking surgery. So we have to remove enlarged ovary, enlarged lymph nodes. But what about normal looking lymph node? How can we distinguish abnormal lymph node from normal lymph nodes? By MRI, PET scan, or just palpation? New measure is expected. In order to improve overall prognosis of advanced ovarian cancer patients, the quality of gynecological oncologists should be improved. The trained gynecologist is in qualified center and qualified teachers is essential. This is an example of board certification of gynecological oncology in Japan. In conclusion, site reduction is the only but significant prognostic factor you as a surgeon can contribute. But it should be performed by a well-trained gynecologist, since achieving optimal site reduction depends on the judgment, experience, skill, aggressiveness, and passion of the surgeon. Since advanced ovarian cancer involves most of all the abdominal organs, surgical team should be prepared to undertake potentially extensive surgery, such as splenectomy, bowel resection, partial hepatectomy, and diaphragmatic resection to achieve an optimal procedure. Such extensive surgery should be utilized only in a setting where optimal site reduction is determined feasible. So I would like to stress again, training gynecological oncologists is an urgent need. And you as a teacher so and encounter difficult cases and unusual cases. But you could handle it, and it is more important than anything else that teacher sweats with the trainees. And you learn by teaching, and trainee will learn from the case and from your attitude. I would like to extend my acknowledgement to Dr. Harshad Parasnis, POGS President, and Dr. Alpesh Gandhi, FOGSI President, and for organizing committee of FOGSI POGS International Virtual Conference, Just Tumors, and also to my fellows and colleagues. And last but not least, I would like to dedicate my talk to patients suffering from ovarian cancer. Thank you very much for your kind attention.
Thank you very much, Professor. It was an enlightening talk, and I'm sure this enriching knowledge and insight is something which will be of value to each and every delegate who has logged in today.
Thank you very much.
Thank you, Professor Ochai. And let me tell everybody that today we have an attendance of about 2,400. So I'm happy that the deliberations which took place in last 45 minutes are being watched by 2,400 people. And the take-home messages that you gave are so relevant and so very important in these days. And I think President Alpesh will also agree that gynaecology is something which we, the FOGSI has to take up as a subspecialty and maybe give our contribution in developing it. Thank you very much, Professor. Thank you, Harshad. And we move on to the inauguration. We have our president who's right here.
For the inaugural ceremony, we have a very talented MOC who has a wonderful smile as well. We've got Dr. Ashwini Kale, who is the General Secretary at POGS as well. I request Dr. Ashwini Kale ma'am to get started, and I would also like to just update. We had a word with Dr. C.N. Purandare, and sir is just going to be joining in about a minute. He's just switching on his computer.
Good evening, everybody. On behalf of Pune OBGYN Society, it's indeed my privilege to invite you all for this inauguration. And as Parag sir already mentioned, I would like to place it on record that we have a total of 6,000 registrations for this conference and about 120 oral papers and more than 300 posters. To begin with the inauguration, please change the slide. You can play the slide. A very warm welcome to Dr. Alpesh Gandhi, sir, President FOGSI, for the inauguration. Dr. Harshad Parasnis, sir, President POGS. Dr. CN Purandare, sir. I also welcome Dr. Robert Coleman, President, International Gynaecological Cancer Society. I would like our FOGSI office bearers to join us for this inauguration. Dr. Shanta Kumari, President-elect, Dr. Nandita Parshetkar, immediate past president, and our 5 vice presidents, Dr. Anita Singh, Dr. Atul Ganatra, Dr. Ramani Devi, Dr. Archana Baser, and Dr. Ragini Agrawal. I also would like Dr. Jaideep Tang, Secretary General, Madhuri Patel, Deputy Secretary General, Dr. Sunil Shah, Joint Secretary, Dr. Suvarna Khadilkar, Treasurer, and Dr. Parikshit Tang, Joint Treasurer, to join us for this inauguration. I hope Dr. CN Purandare, sir, has also joined us.
Dr. Robert Coleman is also joining.
Yeah, could you please change?
Nirav, can you check if he's in the waiting room?
No, Purandare sir is still
I'm
not
also
joined.
Okay, we'll wait for sir to join. In the meanwhile, I would also like to place on record our academic partners, Professor Ochiai, President AOFOG, Dr. Alpesh Gandhi, President ICOG, Dr. Vijay Ahuja Agoy, and Dr. Sanjeev Mishra, who's the President ISO, who have been partners in this conference on just tumor. The conference is endorsed by our partners, SAFOG, Professor Firdausi Begum, who's the President of SAFOG, Professor Dr. Somshekhar SP, the Secretary of ISPSM, Dr. Parag Benivale sir, President Pune Menopause Society, Dr. Govind Babu, President ISMPO, and Dr. Nandita Parshetkar, President AMOGS. Could you change the slide, please?
Just one second. Dr. CN Purandare sir is in the waiting room. Nirav, could you please take him in?
I would now invite Dr. Harshad Parasnis, President POGS and the organizing chairperson for this international conference, Just Tumors, to give his presidential address.
Is my screen seen?
Yes, sir.
Yes, sir.
Can you hear me, Ashwini?
Yes, Purandare sir.
Okay.
Very warm welcome to you.
Thank you.
Yes, sir. We can hear you loud and clear.
Good evening, distinguished guests, friends, colleagues, and delegates. On behalf of Pune Obstetrics and Gynaecological Society, I welcome you all to the FOGSI POGS International Virtual Conference, Just Tumors. Just Tumors, Benign to Malignant, is a dream come true for me. Way back in early 90s, when I was at Tata Memorial Hospital for my gynaecology training, gynaecological oncology did not have an independent existence as a branch. Over the years, it has developed by leaps and bounds to be recognized now as a separate entity and a much sought after super specialty. Throughout my clinical practice, it became evident to me that patients' outcome could be significantly improved by enabling all gynecologists to detect tumors early and provide quality care. This conference does just that. It unites all organizations to help share their knowledge and expertise with us, and thus brings with us one step closer to visualizing our ultimate goal of quality care. To this effect, Team POGS had planned Just Tumors conference in July 2020. But the global pandemic foiled all the meticulous planning done for this conference. The conference could no longer be held in the physical format. It was as if someone had changed the exam format the night prior. My team felt dejected, and that is when we realized you never know how strong you are until being strong is the only choice you have. We decided to face it and take it as a challenge. After successfully organizing the first virtual conference by any Gynec Society of FOGSI in July 2020, we decided to undertake the Herculean and the mammoth task of organizing the FOGSI POGS International Conference on a virtual platform. Here, I must acknowledge our academic partners, AOFOG, SAFOG, AMOGS, AGOI, ISPMO, ICOG, ISPSM, and PMS for believing in us. The unique feature of this conference are the 5 scientific halls which run simultaneously with 3D virtual lobby, interactive 3D pharma lounge, separate oral presentations halls, and e-poster halls. We wish to give you a wonderful experience that could be unique and would leave you enriched with knowledge. I'm happy to share that we have 5 simultaneous virtual halls running, 4 workshops and 1 IOTA 5 workshop, 22 foreign faculties, 256 national faculties, 7 orations, 46 lectures, 8 panel discussions, 121 oral papers, and 218 e-poster, which was itself a humongous task, performed by 56 esteemed judges. We received 5 MMC credit points, 14 ICOG points, and more so, we had 6,000 registered delegates for a super specialty conference, and these delegates were from 47 countries. My special thanks to Dr. Alpesh Gandhi, our FOGSI president, Dr. Jaideep Tang, Secretary General FOGSI, and office bearers of FOGSI for giving us this opportunity. Team POGS 2020 has relentlessly worked to ensure that you enjoy this scientific bonanza in the comfort of your home. Special mention must be made of my team members, Dr. Ashwini Kaye, Dr. Chaitanya Ganpule, Dr. Prakash Kothave, and my dear friends Parag and Kiran, who have worked day and night to make this surreal concept into reality. My dear friends, Dr. Yogesh Kulkarni, Dr. Chetan Deshmukh, Dr. Bhagyalakshmi Naik have been a great help too. And of course, my past presidents, your support and guidance has been profound. All this has been possible thanks to our industry partners who have been a huge help to us. We hope you have a memorable conference and experience in this academic feast. It has been a pleasure. Thank you.
Thank you so much, sir. We now move to the e-inauguration. I now request Dr. Alpesh Gandhi, sir, to e-inaugurate this conference. Nirav, can you share the screen, please? Thank you, sir. I now request our President FOGSI, Dr. Alpesh Gandhi, sir, to give his presidential address.
Thank you, Dr. Ashwini. Professor Dr. Kazunori Ochiai, President AOFOG. Professor Dr. Fardowsi Begum, President SAFOG. Today's guest, Dr. C.N. Purandare sir, patron of FOGSI and past President FIGO. And today's guest, Dr. Robert Coleman, President of International Gynaecological Society. Esteemed faculties, international and national. All the office bearers of FOGSI and ICOG, presidents and secretaries of 258 FOGSI societies, all the dear delegates, dear friends, very good evening to all of you. I extend a warm welcome to all of you on behalf of FOGSI. And I am thankful to my friend, Dr. Harshad Parasnis, President POGS, Organizing Chairperson, Dr. Parag Biniwale, Organizing Vice Co-Chairperson, Dr. Kiran Kurkoti and Dr. Ashwini, Organizing Secretaries, Dr. Chaitanya, Scientific Chair, and Dr. Prakash, Treasurer, and Team POGS for inviting me to inaugurate the FOGSI POGS International Virtual Conference on Just Tumor, Benign and Malignant, with a special focus on Gynaecological oncology. My sincere regards to all the patrons and advisors of this organizing team. We are happy to see so many academic partners, as Dr. Harshad has mentioned, AOFOG, SAFOG, Association of Gynaecological Oncologists of India, Indian Society of Oncology, Indian Society of Medical and Pediatric Oncology, ICOG, AMOX, and others. FOGSI believes in respectful, strong, impactful partnership. It is delighted to know that we have 600 delegates who have registered from 47 countries, and we have more than 120 papers and more than 250 posters. This itself speaks about the hard work done by Team POGS and about the success of the conference. We have 7 orations with FOGSI, ICOG, Dr. Usha Saraiya oration. We have so many talks. The conference will appraise practicing gynecologists of the latest and best practices in various important tumors of women's reproductive tract. It will provide an excellent opportunity to interact and network with the expert faculties and leaders across the world. It is also delighted to see that this conference has been awarded 5 MMC credit points and 14 ICOG credit points. I hope the delegates will definitely take benefit of it. I am happy to see today the dream of my friend Dr. Harshad is coming true. Since long we were discussing about this conference, and as he has mentioned, this year all the plans we have to change the platform because of the COVID-19 pandemic. But I am happy to see that he has taken this challenge, and his team has done excellent work. And today we can see the results of their hard work. I am sure this CME will update the knowledge of our members, which will be useful to them in their routine practice. It's a great teamwork. Congratulations to Team POGS. And many times I usually tell them that many times I feel that I am a part of Team POGS, like it is my second society, and like I am an honorary member of Team POGS. I salute you all for doing great work for the upliftment of women's healthcare in India and continuing the great work even in this difficult and unprecedented time of COVID-19. I wish grand success to this webinar. I wish happy learning to all the delegates and safety to all of you. Once again, congratulations to Team POGS, and we are thankful to all the international, national faculties and all the partners. Thank you very much for the patient hearing. Thank you.
Thank you so much, Alpesh sir. Your words of appreciation really mean a lot to us. Now we would play the clips of our partners. We have Professor Ochiai, President AOFOG, Dr. Mandakini Meg, Chairperson ICOG. Dr. Could you just please play the slide? Yeah, Dr. Rupinder Shekhon, who's the Honorary Secretary General of AGOI, Dr. Dhairyashil Sawant, who's the Secretary of ISO, Dr. Govind Babu, President ISMPO, Dr. Nandita Parshetkar, President AMOGS, Dr. Somshekhar SP, who's the Secretary of ISPSM, and Dr. Parag Benivale, President Pune Menopause Society, and Professor Firdausi Begum, President SAFOG. Could you please play the clip?
Good evening, distinguished members and esteemed guests, ladies and gentlemen. I am Professor Kazunori Ochiai, the President of Asia Oceania Federation of Obstetrics and Gynaecology. On behalf of AOFOG, I must congratulate Dr. Harshad Parasnis, President of POGS, and Dr. Alpesh Gandhi, President of FOGSI, to organize international virtual conference, Just Tumors. I dare to say that we are still in the pandemic of COVID-19. Of course, it is natural to prioritize severely ill patients with COVID-19. But we have gynecological cancer patients waiting for the treatment. We are concerned that delayed treatment of these patients will have a negative impact on the prognosis. It is our mission to learn the front lines of current screening, diagnosis, and treatment, and give it back to our patients. I would like to extend my greetings in the hope that these 2 days will be a fruitful meeting. Thank you very much.
Good afternoon, everyone. I am Dr. Mandakini Meg, Chairperson of ICOG. It's a great pleasure to welcome you all to this very prestigious conference on oncology, that is Just Tumors. At the outset, I'd like to thank Dr. Harshad Parasnis and his entire team to draw such a wonderful program for the benefits of the delegates. A large number of delegates, around 5,000, have registered from 40 countries all over the world. It's also an honor that we are having around 125 international faculty for the scientific deliberations. It's a great pleasure that ICOG has credited this conference with the 14 ICOG credit points. I wish to thank Dr. Harshad Parasnis, President of POGS, to invite me to chair a very prestigious Usha Sarai oration in this conference. I wish this conference a great success. All the best. Thank you very much.
Dear friends and dignitaries, this is Dr. Rupinder Sekhon, Honorary General Secretary of the Association of Gynaecologists of India. It gives me great pleasure to deliver this inaugural speech from the Association of Gynaecologists of India on behalf of the President, Dr. Vijay Ahuja. The word just tumors, though sounding benign, very nicely encompasses most of gynaecology. And I'm grateful to Dr. Harshad Parsanis and his team for bringing something so important to the forefront in this amazing conference, which has, I believe, more than 1,500 registrations already. I wish you the best for all the academic deliberations from which I am sure we shall be enriched in knowledge and gain a tremendous virtual experience while getting a whole new perspective on tumors, their diagnosis and treatment. Wish you all the very best for the conference. Thank you so much.
Hi everyone, I am Dr. Dhairashil Sawant. I am the Secretary of the Indian Society of Oncology and I am very pleased to be with you here. The Indian Society of Oncology is an academic partner to this meeting. The FOGSI POGS Just Tumors meeting from benign to malignant, I know is going to be a huge success. It's been organized by my good friend Dr. Harshad Parasnis in this new virtual format, as is the sign of the times. And I think this niche meeting will definitely help in addressing the demands of people who are working in this particular field, whether it be surgical oncology, whether it be gynaecologists, whether it be gynecologists who are seeing these type of patients. I know all you members who are attending this meeting are going to be here for a huge, big feast, and I wish the conference all the best. Thank you very much.
Hi, good morning. I'm Dr. Govind Babu. I'm the president of ISMPO, which is one of the endorsing societies. So I'm very happy to endorse this meeting, which is all tumors. And I'm glad to see that you have covered interesting topics starting from the benign to the malignant. And this is going to be on 11 to 13 December. This is the FOGSI POGS International Virtual Conference. I'm very thankful for you people to organize this, and specifically I must thank Dr. Harshad Parsanis, President POGS and Organizing Chairman, Dr. Alpesh Gandhi, President FOGSI, and the Organizing Secretaries, Dr. Kiran Kurtakoti and Dr. Ashwini Kale. I see that you put up a wonderful program. I'm hoping that it will be a great success and everybody who is going to attend will be benefited. It's very important that we educate the members of the society, because most women with these malignancies first meet the gynecologist, and therefore we need to see that they're able to diagnose those early, because ultimately that reflects on the outcome for these patients. So with that, wish you all the very best. Hope you have a successful meeting. Thank you.
WHO, via its SDGs aimed at NCDs, actually highlights that cancer in women still continues to remain a significant challenge in spite of all the therapeutic advances. Hence, the key to better outcome is undoubtedly preventive strategies like universal screening and early diagnosis. Of course, cancer awareness in the community will maximize the effectiveness of healthcare providers. Indeed, this focused conference, aptly named Just Tumors, organized by Dr. Harshad Parasnis, who's a highly competent and a passionate gynecologist, will be an invaluable platform to discuss, deliberate, and decipher key issues in our quest to conquer, control, and possibly cure cancer, and will certainly benefit all the attendees. My best wishes and congratulations to Team POGS and FOGSI.
Dear friends, colleagues, senior, students, fellows across the India, I am Professor Dr. Somshekar. On behalf of ISPSM, Indian Society of Peritoneal Surface Malignancy, we are extremely happy to partner with FOGSI POGS International Virtual Conference 11th and 13th December under able leadership of Dr. Alpesh Gandhi and Dr. Harshad. This is a very great event. Had this COVID pandemic not been there, it was supposed to be a very mega event in person with a lot of international faculty. Nevertheless, the same hard work has carried on here and fantastic work has been done, and there is an array of very high quality international national faculty and a beautiful program, video sessions, lot of original talks, recent advances, also representation to students, young scientists, best paper awards. So it's a pleasure to be part on behalf of ISPSM, Indian Society of Pattern Surface Malignancy, to partner with this just tumor, benign to malignant. I extend a warm welcome to all of you on this inauguration day and wish a great success for everybody. There is something for everybody to take care, senior most to junior most to students. So I thank the entire team and then Dr. Alpesh Gandhi and Dr. Harshad on behalf of ISPSM. Welcome all of you to Just Tumor, Benign to Malignant for this extra bonanza of the academic event. Thank you very much.
Namaskar. I'm Dr. Parag Biniwale, President of Menopause Society, Pune. It gives me immense pleasure to join hands with Pune OBGYN Society in organizing conference Just Tumors, from benign to malignant. This conference is organized under the aegis of FOGSI, and I'm also happy that this conference has received 14 ICOG credit points. I'm sure the delegates will be enriched by knowledge not only in malignant tumors but also in benign tumors during this conference. Thank you and welcome to Pune.
Respected dignitaries, colleagues and friends, I'd like to convey my greetings to all of you. As President of South Asian Federation of Obstetrics and Gynaecology and President-elect of Obstetrical and Gynaecological Society of Bangladesh, I congratulate FOGSI and Pune Obstetrical and Gynaecological Society for organizing the Just Tumor Conference. As we know, that SAFOG comprises of Afghanistan, Bhutan, Bangladesh, India, Nepal, Maldives, Pakistan, and Sri Lanka. I am glad to say that today 4 of these countries are participating in this occasion. Tumors, be it benign or malignant, has to be taken seriously as both are important for patients and clinical perspective. I like to see this conference from 5 different angles. First, it has pooled the resource person and facilities available for the management of tumors in the region and globally. Second, it has brought the opportunity to share and learn most updated clinical practices, facilities, and protocols. Number 3, it will highlight the programs for prevention, screening, and treatment of various cancers and tumors of female genital tract. Number 4, it will showcase the progress of elimination of cervical cancer, which causes deaths of thousands of women. And finally, it will bring the opportunity for sharing the research experiences, which not only will generate data, but also will build evidences. I thank the organizers and resource persons from core of my heart and express my gratitude for inviting me. I convey just best wishes for the Just Tumor Conference. May Almighty keep everyone safe.
Thank you so much to all our academic partners for endorsing this conference and being with us. I think Meg Madam has just joined. I welcome Dr. Mandakini Meg, Chairperson ICOG, and Dr. Shanta Kumari Madam, President-elect FOGSI. I now request our guest of honor, Professor C.N. Purandare, to give his blessings. Over to you, sir. Sir, you have to unmute yourself.
I'm indeed very happy to be here today, even though a virtual Congress, but happening from Pune, which is the city of knowledge as far as India is concerned. Happy to see many of my friends there. I see Ochai, I see Firdausi Begum, I see Rob Coleman, and many of people there on my screen attending this inauguration as well as participating in this Congress. I bring you greetings from FIGO, and you are well aware that many of these things, the oncology, the FIGO's staging has taken a place for a long time as far as support from FIGO is concerned. I remember the time when in 1983 when I returned to India and having worked a lot on oncology and came back here and started in JJ group of hospitals and doing private practice. Very little was done by gynecologists on their own as far as oncology was concerned, and the oncologists were more or less doing most of the work. At Tata Cancer, we have been insisting for a long time that, and as Harshad mentioned, it was urology and gynecology, which was oncology was together. And the urologist was the head of the department of gynaecology. And we kept on pushing and pushing that, saying that it's time that the gynecologist should be heading the gynecology oncology. And we're happy eventually to have a separation between the urologist and the gynecologist, to have gynecology as the gynecology oncology as the separate wing in Tata Cancer. And since then, we have seen a lot of changes. As far as FOGSI is concerned, we have done a lot of innovations as regards the committees, from oncology committee, then even a separate breast committee during my tenure as the Secretary General, so that we would have more and more involvement of the gynecologists in early diagnosis and treatment and the post-treatment availability of all the facilities. I was fortunate enough then, from being a FOGSI president, to go over to FIGO as FIGO president, and I'm very happy to tell you that India has contributed a lot in the representation on the oncology committee of FIGO, and even chair of the oncology of FIGO, which Nirja Batla held during my tenure as the president of FIGO. And a lot of things have happened, and I still remember the time when we went to the WHO meeting in May, and we had a full session from FIGO there, which was attended by Tedros as well as all the other officials of FIGO, and which has culminated now in the 2030 eradication of cancer cervix, which I think is a great progress as far as early detection, now that we know that the vaccines are available, and so on and so forth. When I look at the entire program which Harshad had put up, I think it's a phenomenal program. We have 6,000 delegates with so many 125 foreign faculties. And believe me, in the last 1 year, due to the COVID era, the number of meetings that I've held, Alpesh has been the really key person as far as the FOGSI's virtual congresses are concerned. But the attendance has been enormous, because people who could not attend otherwise have been attending on virtual platform, and which has really made a lot of difference as far as the attendance and knowledge receiving as far as all the delegates are concerned. I wish Harshad and the entire team a great success, and I'm sure there is a lot of learning there will be in all the lectures that are going to be held. A great tribute to a great gynaecologist as far as we are concerned, by naming one of the orations as Usha Saraya oration, which Harshad, I compliment you for. She has put in so much work in cytology and cervical cancer management that I'm very happy to see the recognition being given in this international congress by having an oration in her name. And it's a great pleasure to be with all of you, and I'm sure it will be a grand success. I wish you all the best.
Thank you so much, Purandare sir.
Thank you.
I would request Dr. Robert Coleman, President of IGCS, to give his blessings. Over to you, Robert sir.
Thank you so much. I am incredibly honored to be part of this society. When I was first invited and saw the engagement of so many academic centers and endorsement by so many other societies, it was really humbling to see. It's humbling, and even more so because of the importance it is that there is international collaboration to tackle a problem that affects us all. And that's how we care for patients with gynecologic disease. So I'm so honored to be here. And as has been mentioned, it is so nice to see the faces of my friends. Even if it's just this big, I still enjoy seeing my friends, and I miss you dearly. This kind of rescue of a meeting that's so important to disseminate information is a great undertaking. As many of you know, we had to do a similar scramble at the last minute for the International Gynaecological Cancer Society meeting this past September. I know the work that was involved to pull this off. I am incredibly impressed with what you've been able to put together in this in this current environment. I pray that that all of you are healthy and safe in this current environment, and look for a quick resolution to the pandemic. But I just want to congratulate the leaders of all these academic societies and other conferences for coming together to develop this common mission to provide a venue for dissemination of important information at all levels of need, and to do so in such a friendly environment. So thank you so much for having me. It's my honor to be with you today. And I really look forward to these sessions. Thank you so much.
Thank you so much. It's indeed a pleasure to have all such galaxy of speakers here and so many societies together. I now request Dr. Kiran Kurtakoti, Organizing Secretary of Just Tumors, to propose the vote of thanks.
Yeah. Thank you, Dr. Ashwini. May I be allowed now to share the screen?
So you can share your screen now.
Yes, I am sharing my screen. Just give me a minute. Well, on behalf of the organizing committee of the Just Tumors conference, I welcome you all for this final round of remarks, that is vote of thanks. One second, just give me a...
Kiran sir, make it full screen.
Yeah, I am trying to make it full screen. Just 1 second. Anyway, chalo. We'll begin. This is the organizing committee. On behalf of the organizing committee, I would like to thank all of you for being with us, standing solidly behind the Pune OBGY Society. The FOGSI office bearers, Dr. Alpesh Gandhi and his entire team of FOGSI for endorsing this conference and being an academic partner with us. The ICOG office bearers, Dr. Mandakini Meg, Dr. Parul, and my friend Parag Biniwale for being again associated with this conference, giving us ICOG credit points and being with us to guide us for the scientific content and the academic content of this program. We also would like to thank all the FOGSI committee chairpersons, Dr. Bhagyalakshmi Laik, who has played a major role in this conference, Dr. Kundan, Meenu, Manish Mache, Vaishali Chauhan, and Sneha Bhuya for their contribution and association in this conference. Well, coming to the academic partners, now, friends, as you all know, this is for the first time probably in the history of the Pune Society that we have been associated with so many academic partners and being endorsed by about 5 other international bodies. So special thanks to Professor Ochiai, of the president of POGS and his team. Special thanks to Alpesh Gandhi, president of ICOG. Thank you, Dr. Vijay Ahuja, president of AGOI, Dr. Sanjeev Mishra, president of the Indian Society of Oncology. We also would like to thank those who have endorsed this conference, international bodies, Professor Firdausi Begum of CEPOC, Dr. Govind Babu of ISMPO, Professor Somashekar, the Secretary of ISPSM, Dr. Parag Beniwale, the President of the Indian Menopause Society, and of course our close friend, Dr. Nandita Palshetkar, ex-President FOGSI, current President of the POGS. We also would like to thank our international faculty because they have added a lot to this particular conference, and I acknowledge the presence of Dr. Robert Kolban as one of our international faculties. So thank you very much, and of course Dr. Firdausi Begum, thank you very much for being with us. We have national faculties, over 300 national faculties, so thank you again very much for being with us. As you know, this conference had a huge number of free papers and posters with over 123 papers and about 80 to 100 free posters. So it is very difficult for us to manage, but thank you all the judges. We had more than 50 judges and 75 people who judged the free papers and posters. So thank you for thank you for giving your valuable time and energy and your inputs in judging the free papers and posters. Now, any conference cannot be successful without the support of the partners. So we would like to thank our partners, Zuventus, Sun, Periwinkle, Acumentis, Zydus, and MQR for being there with us in this difficult COVID times. A very much big thank you to MICE, who were MICE Ideas, who are responsible for doing this conference live, on a virtual platform. Their cooperation till today has been great, and we expect them to cooperate in the future also. Thank you so much. Now coming to the delegates. As we all know, we have over 600 registrations, 6,000 registrations, and delegates from over 53 countries have taken part in this conference. So very big thank you to all the delegates. Now, friends, we all know that these 53 countries have got different languages, although the Queen's language is united to us all. But I have gone to a bit more extent to say gracious thank you, shukran in Afghani, Saha in Algerian, Messi in Antiguan, and various language, Medici in Ghana. So these are all the countries whose delegates are a part of our conference. Dhanyawad in Nepalese, and SOC in Nigerian, Salamat in Filipino, Shukran again in UAE, and so on and so forth. So we have taken a great effort to thank you all in your native languages. Hope those grammatically are correct. So thank you so much, dear delegates, for being with us. I think, yeah. And thank you so much, all of you, for being with us in this inaugural function. And I request that all of you be logged in today and tomorrow also to enjoy the academic feast. Thank you.
Thank you, Kiran sir. Thank you all the dignitaries on the dais for attending this inauguration. Over to you, Nikhil. We would begin with the plenary session.
Ashwini ma'am, Nikhil is not there. Might be he has logged out.
Okay. So can we begin the Wetheim?
Yes, sure, definitely, yes.
Yeah. I would request our chairpersons, Dr. Firdausi Begum from Bangladesh, Dr. Shanta Kumari Madam, President-elect FOGSI from Hyderabad, Dr. Krishnendu Gupta from Kolkata, and Dr. Milind Dugad sir from Pune to chair the next session.
Thank you very much. And this is Krishnendu Gupta. At the outset, let me place on record my grateful thanks to the Pune Obstetric and Gynaecological Society, my dear friend Dr. Harshad Parasnis, whom I know for a very long time, Parag, Kiran, of course Ashwini, and whole host of my dear friends from Pune. Thank you for this wonderful opportunity to chair this very, very prestigious session. And we have none other than our, I think he's become omnipresent now, Alpesh. Dr. Alpesh Gandhi is everywhere. And you kind of, I don't know how he manages, what he's eating, when he has time to even have a glass of water. I mean, I think introducing him is going to, take away more time than what is kind of really, required. Although it's customary to do so, but as our President Fogsy, he has made this pandemic, the COVID pandemic, into a humongous opportunity to really galvanize webinars and education throughout throughout the length and breadth of this country. So thank you, Alpesh. Really grateful for all your efforts. You've been ably supported by by the entire team of Fogsy. I must, hats off to them as well. But it's your dynamic vision, and you've just shown the capabilities of a true leader, Alpesh, and we are extremely proud of you. And you're going to speak on something which is dear to my heart, although I'm not a gynec oncologist, but prevention of cervical cancer is my passion, and you're aware of it, how much we are doing it, not on a personal basis, but also through Rotary and stuff like that. So I think I would request you to kindly speak on Fogsy's vision for elimination of cervical cancer. Dr. Alpesh Gandhi, please, President Fogsy.
Please let me allow screen sharing.
You can allow to share the screen. You can do it, sir.
Okay.
Yeah.
Thank you very much, Dr. Krishnendu, for the kind words, for the appreciation, for the support, and for the generous introduction. I'm going to speak on a topic which is, I'm not going to speak on a scientific aspects of how we can prevent, what we should do when patient is having cervical cancer. I'm going to speak on a topic regarding Fogsy's vision for cervical cancer prevention and elimination. I think we have eminent faculties who are doing exclusive work of cervical cancer, and I wish they all will cover the scientific aspects of this talk. The latest figures from the International Agency for Research on Cancer, IARC, show that an estimated 570,000 new cases of cervical cancer were diagnosed worldwide in 2018. It is the fourth most common cancer in women globally. Every year, more than 310,000 women die from this preventable disease. About 90% of these deaths occur in low and middle income countries. And the estimated new cases of cervical cancer, India stands second to China with a huge number of 96,922 new cases, accounting to 17% in Asia with 68,000 deaths in 2017. And that is why it touches us a lot and our responsibility increases a lot. Unless preventive measures are implemented promptly, the burden of cervical cancer is expected to increase to almost 460,000 deaths per year by 2040, an increase of nearly 50% over the estimated number of deaths in 2018. And the greatest relative increase will occur again in lower middle income countries. In lower middle income countries, challenges in implementing vaccination programs and efficient screening and control policies are major hurdles to the decline of the disease. Cervical cancer affects seriously, it has a serious impact on the women's health. Cervical cancer affects women of reproductive age who are also caretakers in the family. The disability and death due to the disease causes enormous emotional and financial trauma to the family. cervical cancer remains one of the major causes of death and disability. And the percentage of women dying from cervical cancer is much higher at 61.9% compared to breast cancer at 53.6%. If we look at the estimated number of new cases in 2018 in India, among all cancers in female at all ages, cervical cancer is at number 2 after breast cancer. But the good side is that it is a preventable cancer. And it is a sad part that if any woman is dying from a preventable disease, when we believe that when it is detected and managed at the very earliest stage, it has over a 93% cure rate. And FOGSI believes to work to achieve SDG goal for India. And SDG goal 3 is ensure healthy lives and promote well-being for all at all ages. And target of SDG goal 3.4 is by 2030 reduce by 1/3 premature mortality from non-communicable diseases through prevention and treatment and promote mental health and well-being, which covers cervical cancer also. Once American past President Barack Obama declared that we did not come to fear the future, we came here to save it. And FOGSI believes to save the health of women of India. FOGSI is the Federation of Obstetric and Gynaecological Societies of India. It is the professional organization representing practitioners of obstetrics and gynecologists in India. With 258 member societies and over 38,000 individual members spread over the length and breadth of the country, FOGSI is probably one of the largest membership-based organizations of specialized professionals. FOGSI came into existence in Madras on January 6, 1950, before our first Republic Day. And FOGSI takes care of 50% of population of India, female, from the adolescent health to teenage health to reproductive health to menopausal age to geriatric age. And the theme for this year of FOGSI is safety first for Indian women and FOGSians. And we cannot achieve safety of Indian women if we cannot save our women from preventable diseases. So this is must to work for all of us to save our women from the preventable diseases. FOGSI believes that it is our responsibility. Reduction of cervical cancer rate lies within our hands. And FOGSI supports the WHO call to eliminate cervical cancer as a public health problem. And FOGSI also supports Government of India for the elimination of cervical cancer, all its programs and projects. The vision for the elimination is a world without cervical cancer. And the goal is below 4 cases of cervical cancer per 1 lakh women per year. And we believe that 90% of girls, if fully vaccinated with HPV vaccine by 15 years of age, we also support the vision of 70% of women screened with an HPV test at 35 and 45 years of age. And if they all manage appropriately, then we can achieve the target, we can achieve the goal, we can achieve reduction in mortality from cervical cancer. Like SDG, FOGSI has its own mission, but like SDG, we should also have our targets, we should also have our plans for the next 3 years, for the next 5 years, and we should make our own targets, own plans, and own strategy for improvement in like MMR, NMR, mortality due to breast and cervical cancer, and other NCDs in India. And we will try to prepare roadmap for the next 5 years with the support and help and cooperation from incoming presidents, Dr. Santa Kumari, Dr. Rishikesh Pai, and others. Yearly targets can be decided and planning can be done accordingly. FOGSI will execute the project during 2020 through Oncology Committee and Public Awareness Committee of FOGSI. It will be achieved by working collaboratively with cancer institutes in the country, Government of India, NMC, WHO, NITI Aayog, ISCCP, NGOs, and other organizations, and ICMR, and with media. FOGSI believes to work for advocacy at different levels and authorities. We wish to publish our position and vision statement. We have our own GCPR. We want to make it more accessible and popular. We want to organize more and more awareness and educational CMEs on preventive and screening modalities for our FOGSians. We want to, FOGSI this year is popular for its community connect programs for spreading public awareness. We wish to organize, and we have organized many screening camps for mass screening even in this difficult time of COVID-19. And we wish to publish a list of referral centers to be sent for further management. And we wish to work collaboratively with other organizations who are working for the elimination of cervical cancer. For advocacy, we would like to advocate at government level to make HPV vaccine a part of immunization, central immunization program, and will continue for the persuasion for it. We wish to advocate for making HPV test easily accessible and affordable in India. We wish to advocate, we will advocate at NMC level to make at least breast and cervical cancer screening clinic and facility mandatory for a permission to start or to run any medical college in India, because we may be wrong, but it is our observation that still in 40% of the places or 50% of the places, this facility is not available. And to start specialized fellowship courses for or DNB courses in gynaecology. And we would also like to work to do advocacy in media by organizing press conferences. We want to identify the challenges for cervical cancer elimination in India, and biggest challenge is lack of awareness. Another challenge is the stigma associated with visit for a gynecologist for the purpose, and there is always a fear of being asked uncomfortable questions regarding sexual practice. And there is a lack of healthcare infrastructure for screening programs still at many some of the parts of India. And another biggest problem is availability of vaccines and cost of HPV test and vaccines. Of course, inadequate trained personnel, poorly developed and accessible cancer diagnosis and treatment facilities at some of the parts of India, and enough budgeting is also a problem. So these are the challenges, and wherever possible, we would like to work from FOGSI. We have our own GCPR prepared in 2018. It is nicely prepared. It is covered all the aspects from urban population and to the rural population, how we can manage for cervical cancer. It is nicely covered all the aspects, and we want to make it more accessible, more popular, and more our members are using. We want to see that more and more our members using this GCPR, very useful GCPR. We wish to publish a position and a vision statement. Federation of Obstetrical and Gynaecological Societies of India reiterates its commitment to fight the disease of cervical cancer and unequivocally confirms the role of HPV vaccine, the role of its screening for prevention of cervical cancer for women of India, irrespective of any caste, any religion, any economical status, and any educational status. We will discuss this in incoming managing committee meeting. We'll refine the statement if required and pass it in the managing committee, and then we will publish it, and we'll also like to send it to Government of India and all the state governments. We want to promote a pragmatic approach for elimination of cervical cancer in India. We want to see that vaccinate girls aged between 10 to 13 years with 2 doses of HPV vaccine at 6 months apart. We want to provide a single HPV screen or a VIA screen at ages 35 to 40 years. repeat HPV screen at 7 to 10 years interval, or repeat VI test screens at every 5 years may be considered depending on the availability of the resources and setting. And early diagnose cervical cancer in stage 1 disease among symptomatic women and treat them adequately to reduce mortality. Of course, we would like to do lots of mass awareness programs to make the common people aware about the risk factors for cervical cancers, and we also would like to make them aware about its signs and symptoms, and we would also like to make them aware about that this is a preventable disease and this is a curable disease. We want to make them aware about the vaccines, so many aspects. We want to make them aware that when there is a multiple sexual partner, when there is unprotected sex, when there is having sexual relation before the age of 18, or when there is a history of habit of smoking, or when there is a history of family history of cervical cancer, these are the high risk, and these are the average. These are the women may develop cervical cancer. And we also would like to inform them about the symptoms like postcoital bleeding, postmenopausal bleeding, foul smelling discharge, weakened immune system. So if they have any such complaints, they can contact their gynecologist. And we want like this in a simple way. Cervical cancer is caused by a virus that is spread sexually. Having many sexual partners is a risk factor for cervical cancer. Like this, we would like to make them aware by a simple measure, simple take-home messages. And we also would like to have public awareness programs to spread the message that it's a preventable. If awareness increases, more and more women will come for vaccination and screening, and small videos will be prepared which can be demonstrated in our waiting room for public awareness. And to increase number of girls coming for vaccination and women for vaccination and screening, we may need something very effective like TV ads with clear message. In adolescent health education, POGS is doing lots of activity, lots of work in adolescent health education, and we have already incorporated and added information of risk factors for cervical cancer and role of vaccination in prevention. Training of FOGSI members in preventive oncology will be the one priority, as we believe that all gynecologists are preventive oncologists, though they may not be a oncologist, they are not the surgeon, but they all are the preventive oncologists. We can counsel, we can screen, we can give vaccine, we can identify patient, we can we can do suspicious, we can refer the patient. So we all are the preventive oncologists, and because of our heavy work in routine OPD, just this is forgotten. We want to sensitize all of them, and we want to update them with the latest development, and we want to see that they all work as the preventive oncologist. We will plan CME's workshop for our FOGSians to update the knowledge of our FOGSI members. We have prepared scientific modules of 3 to 4 hours with proposed faculty banks, and we also would like to have TOT for all our faculties, zone-wise, and we can organize it collaboratively with the other associations also. And once we have suspicious, or as when we are working as the preventive oncologists, and if we come across any patient when we are suspecting cervical cancer, we need to refer them. So we also would like to have a list of such referral centers. We may be published on our, it may be published on our website for the benefit of FOGSians and Indian women, especially focus on diagnostic referral and facilities available in the country. It can be done with the support of state governments, medical colleges, public hospitals, volunteer private setups ready for free or low cost care. All regional cancer centers can be referral centers. And the most important thing is our commitment. All FOGSians should resolve to counsel their own patients, to screen their patients, to vaccinate and to screen based on resources as per the FOGSI GCPR, to have uniformity all over country. And this is also, we will like to request all our FOGSI affiliated 250 societies to adapt one PHC or one wellness center near to their area to counsel, to screen and to refer women for cancer of breast and cervix once in each month for the next 3 to 5 years just like many Foxians are providing their free services for antenatal care under Pradhan Mantri Matrusha Suraksha Yojana once a month on 9th. Similarly, we can also add up few centers, at least one center per society. If we can add up, then also we would be able to add up 258 centers where we can provide this facility. And FOGSI is already doing a lot of activities. I'm happy to share that we had organized first time in India cervical screening on wheels in trains, and the name was given to the train was Lifeline Express. We have set up all the infrastructure for the screening in the train, and we had decided with Impact India Foundation, FOGSI has done this program last year, and we selected a centers, remote centers where facilities are not available. Through this train, we decided to reach to Jharkhand, Chhattisgarh, Bihar, Assam, West Bengal, Bihar, Odisha, Arunachal Pradesh, Tripura, and some of the centers already are covered, and we provided services for the screening and reaching this. The intention is to reaching to unreached places by train. Places covered: Sahibganj, Korba, then Forbisganj, Dhubri, Itanagar, and here we can see a Chief Minister inaugurating Lifeline Express at Korba. And similarly, on 8th March this year, 2020, on International Women's Day, we had organized a screening camp for the females working in police department and in CRPF families. And though it was a beginning period of COVID-19, we were able to screen more than 40,000 women in police and CRPF families. We have received a great support from police department and received a great support from all our Foxians, all FOGSI members. More than 210 societies participated in this program, and there was a great enthusiasm. And here we can see this. Here we can see Dr. C.N. Purandare Sir's clinic and all our FOGSI members, office bearers, and member from the police department who were there during the camp. These are few photos, these are few memories, these are the support which we have received across India. You can see a great support, great enthusiasm, and great encouragement. So many we have received. So many photos and so many compliments for this program. And at the end, we believe that FOGSI can use its vast number of resources by accumulating information about gynec cancer in our country. Like it's kind of a registry which in itself be a huge contribution to cancer data of our country. This year we have started a COVID-19 registry, national registry for the COVID-19 with pregnancy. And I'm again happy to share that we have received nearly 2,600 data from across India. And of course, this looks a very difficult task, but we may try for this studies and to collect this data. And at the end, I would like to mention that we want to start a pilot project to prevent and eliminate cervical cancer in the 8 north states of Northeast with our partners. And we are in discussion with WHO for this. In India, the incidence is highest in Northeast states, and so we selected these states for the pilot project. And we wish to conduct the pilot project under the able leadership of our dynamic Vice President, Dr. Anita Singh, who has conducted this mega screening camp on 8th March, World International Day, Women's International Day for Women's, and Dr. Bhagya Lakshmi, Chairperson, Gynaecological Committee, FOGSI, and Dr. Nirja Batla, who is the FIGO Oncology Committee Chairperson and member, and convener Dr. Gokul Das for the Northeast area. We have selected one coordinator for each of the 8 states, and we have started to work on it, and we are going to call a meeting of all the coordinators in next week. So women are not dying because of a disease we cannot treat. They are dying because societies have yet to make the decision that their lives are worth saving. This was declared by the then president in 1997 during the World Congress of FIGO, and still this is true, unfortunately, for some of the parts and some of the countries. Let us work together to eliminate cervical cancer, which is preventable cancer. So in conclusion, cervical cancer is preventable. The onus of cervical cancer prevention lies on us, the gynecologist, as we may the only health personnel the women may contact in her lifetime for this purpose. Let us sincerely make a roadmap for the next 5 years and then for the another 5 years, and to commit to all the call for elimination of cervical cancer by the WHO, by screening women and vaccinate girls every day in our clinics. Our prompt action is required. Cervical cancer elimination strategy offers a major opportunity for FOGSI to champion this in India, to show that our champions can do this, FOGSI can do this, and this is a doable. We can develop a roadmap for elimination of cervical cancer, a mass awareness community connect programs by organizing mass awareness programs, by advocacy and support for HPV vaccination, by doing advocacy for HPV based screening, and then treatment for pre-cancers, diagnosis and optimal treatment of invasive cancer. Palliative care are components that FOGSI can advance. A digital solution can be considered to support the screening programs, as outcome monitoring is critical. A big section of society in our country is still unreached and underprivileged, deprived of benefits of life-saving infrastructure and technology. Let us work together to eliminate the preventable cervical cancer from India. Thank you very much for the patient hearing, and thank you for giving me this opportunity. Thank you.
Thank you very much, Dr. Alpesh Gandhi, for this wonderful, wonderful presentation. Very comprehensive, and it's amazing to see that your vision, FOGSI's vision, is in line with WHO to have a world free of cervical cancer, just like we would want an India free cervical cancer. So I think, since we are running a bit late, I would request our esteemed chairperson, Professor Firdausi Begum, to kindly introduce the next speaker and go ahead with the session. Dr. Harshad, would you like to say a few words?
Thank you.
I think with paucity of time, let us move ahead. I think that will be much better. Thank you.
Okay.
Professor Firdausi.
Thank you. Wonderful, Dr. Alpesh. I salute you. It's wonderful. But let's move on. Dr. Robert Coleman, President, International Gynaecological Cancer Societies, Chief Scientific Officer, U.S. Oncology Research, Texas, USA. It's a man with immense experience. So I invite Dr. Coleman to present his presentation on changing paradigm in managing recurrent ovarian cancer. Over to Dr. Robert Coleman.
Thank you so much. I will share my screen here. Okay. Thank you. Let me just start by saying I want to congratulate Alpesh and your efforts across the FOGSI unity as you approach cervix cancer. The last time I was in India, I had the pleasure to visit many sites, and I've always been impressed, and really have directed people to monitor how India has responded to this crisis for cervix cancer, both for prevention and for early identification. So thank you for your efforts. You really are providing a roadmap for the rest of the world. And I applaud you on your efforts by engaging the health ministry. And I know how much they've been involved in this, in tackling this from a central. So thank you, congratulations. It's really terrific to see. So I'm going to talk on a different venue. Another, what we see as a crisis in our country is ovarian cancer, recurrent disease, because this is something that we're having quite a bit of difficulty in getting out of what feels like a ultimate decline. in the patient. We are, it is an area where there's been a lot of development, and there continues to be a lot of development, and much of that development is spurred by our increasing knowledge about the biology of this disease. And so I'm going to talk about recurrent ovarian cancer, not just second line, but also some other, further downstream interventions. These are my disclosures. So what I'd like to do today is talk a little bit about what recurrent ovarian cancer is and how it's being redefined. So many people are familiar with the terms platinum sensitive and platinum resistant. I'm going to talk to you a little bit about how we're starting to relook at that terminology, and then to show you how the options for care have continued to migrate and what our future interventions will ultimately turn out to be. This is a slide I use frequently, and that kind of can outline in a timeline, essentially, what the natural history of ovarian cancer is. So as many of you know, ovarian cancer starts with symptomatology, which unfortunately for most women antedates the diagnosis by 6 months to a year, even in the presence of good and accessed medical care. It's not usually a top of mind cancer for most general practitioners. And until patients come in with symptoms of metastatic disease, is it actually interrogated further to find the primary diagnosis. But once that diagnosis is made, then our decision is then switched to our primary tools, which are surgery and adjuvant therapy, which is largely defined by chemotherapy. You can see there are a number of different nuances along the way in the frontline setting, including whether or not there's a role for surgery in this process, how neoadjuvant chemotherapy is being used across the country, the idea of primary maintenance. And then there's this spring in here before when most patients go through their primary treatment and get a response to the time that the tumor progresses. And then there's this progressive utilization of chemotherapy for multiple lines. Recently, there's been some information about surgery, which I'll talk about briefly in this discussion. But one of the things that's been very interesting to monitor since I've been doing this business, which has been 25 or 20 or so years, is that it used to be that the most gain that we saw in a woman who was diagnosed with ovarian cancer was attained in their primary progression-free survivorship, and that what happened after the patients recurred was very short. But what's happening now is that over the last, maybe 10 years, post-progression survivorship in women with ovarian cancer has started to increase. And this will drive a statistic that many people aren't really all that familiar with, which I'll share with you in just a couple slides. But what we're seeing is that it's at least as long as what we see in the primary for women who've recurred. The duration of time from progression to death is about the same or better than it was from initial diagnosis to first recurrence. And that's really an impressive statistic when you think about the patients that present here are chemo naive. So we don't even know that they're what they have in terms of induced drug resistance, but the patients here have all progressed. So they've been at least educated. Their tumors have been educated against chemotherapy at this point. And so that is actually quite impressive. Now, one of the things that has come to change our approach to this and why this is occurring has to deal with not only the identification of better agents that fall into these chemo boxes, but really it's been about the role of maintenance and concomitant therapy. So the drugs I think most people need to remember that paclitaxel was the newest chemotherapy drug to enter into the ovarian cancer space in 1996. And to this day, it still retains its role as a primary drug to give with platinum in patients with primary disease and in patients who have platinum amenable or platinum sensitive recurrent disease. Okay, so the only gains that we've made here have been in adding something to this drug, which is biologically based. One of which which I'll talk about, is bevacizumab, or the anti-VEGF based strategies, and the other is the use of PARP inhibitors. And you can see now the role and the benefit of these agents across our treatment paradigms has started to become even more prolific. And so as we start to utilize these agents more often and in several different settings, what we find is that we're actually increasing the value. So the main kind of two drivers for this has been the identification of how angiogenesis is important to ovarian cancer cell survival, and how PARP inhibitors can be utilized under restricted conditions for which tumors are vulnerable. And I'll talk about that a little bit. Now, as I mentioned, in the United States, this is still considered a rare disease because it doesn't affect that many women as an incident tumor. And remember, incidence is the number of new cases of a disease that occur over over a time frame. So the annual incidence of this per 100,000 women has actually decreased slightly over time. And you can see the mortality from ovarian cancer in the United States has also decreased slightly over time. Now, this represents nearly, almost 2 decades worth of observation. So it's not something that's changing very quickly, but it is changing. And you can see that the proportion of women who are diagnosed with this, the proportion of women who ultimately die from this disease that are actually diagnosed, that fraction has been basically the same all along. So we really have not made a tremendous amount of gains in the expectations of mortality. But what we have made a huge gain in is a statistic that most people don't talk about, and that's prevalence. So prevalence is the number of women at any one time that actually have the diagnosis. So this is a very interesting statistic, because if you think about this, these are the number of people that enter the pool of new cases, right? So every year you have another, let's say 20,000 women that enter the pool. At that same time, you have about 16,000 or so of them that exit the pool. But even though those numbers are continuing, what's happening is that the women that are diagnosed, let's say in 2008, instead of expecting to die in 2011, they're actually dying in 2013. And so what's happening is that you're having this kind of like accumulation of patients that are surviving longer. And so the way that you check that is to monitor how many people actually have the diagnosis at any one time. And if you monitor prevalence, you can see it's been slowly increasing, and then something happened in 2014. Something happened in 2014. First of all, it was a big change in the rate of this acceleration of prevalence. But secondly, we crossed this 200,000 total prevalent line, which in the United States is very important, because that's a line that designates whether or not a tumor is considered orphan, meaning it's rare. So in 2014, ovarian cancer's prevalence got it out of the quote unquote rare category, and it's continued to accelerate. So the question is, what happened in 2014? So one of the major things that came up during this process, as many of you know, was the development of the PARP inhibitors and the approval of the anti-angiogenesis inhibitors. And those have essentially been very important because they have played a role not only in the concomitant administration of drugs, but also in the maintenance. So today's focus is really on second line, recurrence, and predominantly in second line, because that's where this all starts. And so one of the questions that comes up, as I mentioned early on, was how do you classify these patients? And while it seems very easy, because people will say, well, we've used this terminology in the past, and somehow 6 months emerged as the discriminator. And the thought was that if a patient, presented with disease less than 6 months from their previous treatment completion, and that being platinum, then they were considered either platinum resistant or refractory, and they got non-platinum based therapy. And if they had magically, 6 months or longer, they were considered platinum sensitive, and then they were treated with platinum. So I always tell the story that I had a patient who came in on a Thursday when my clinic was, and she was about 3 days shy of her 6 month window, and we had a protocol that was open for her because she was platinum resistant. And as part of the screening criteria, she was required to have a CAT scan, but I couldn't get the CAT scan scheduled until Monday. So when she came in Monday to document that, yes, indeed, she had recurrent disease, she was now 6 months and a day, and she magically became platinum sensitive. So Obviously, that's not how it works, but it is the problem that we have with trying to use these hard endpoints as to describe the patients that we're trying to deal with. The problem is that this particular line in the sand is like how people create treatment algorithms in their head, and I want to try to break that down because I think it's clear that when we think about what the opportunity to respond to platinum again is, it is actually more of a continuum. And this is a graphic I've used for years that shows in these gray bars the anticipated response rate due to treatment and the progression-free survival in red and the overall survival in yellow. And so you can see that when you use the categories as they were originally described back in 1989, you can see that there's actually a relatively linear relationship between the time of away from platinum and the anticipated response to any therapy. So this variable is not about 6 months. It's really about what is the best treatment based on the treatment for interval and their most prior exposure to platinum. And just to put this into some more context, this is a study that was published a couple of years ago that actually shows that in patients who would be considered platinum resistant, so less than 3 months or 3 to 6 months, the best drug, if you're considering platinum or non-platinum, looks like it might be platinum. So just let me share with how this looks. So these graphics are unfortunate. This is right out of the manuscript, so it's kind of not the best way to present the data. But let me just share with you. These blue bars reflect response rate, and these are patients who were given platinum, and this is their platinum for interval. So you can see in patients that are less than 3 or 3 to 6 months, the likelihood of responding to platinum when it was given again, somewhere around 40%. And the likelihood of responding to a non-platinum in that same type of interval was about 25%. So at least in this kind of scenario, it looks like platinum may be an actually good drug to give in platinum-resistant patients. So again, I just caution you to think about the characteristics of the patient you're thinking about treating based on these metrics that don't clearly define who is platinum resistant and platinum sensitive. And over here, you can see basically for that 3 to 6 month cohort, this group of patients, this is the PFS curve for patients who got platinum after platinum. And this is the group of patients who got a non-platinum after platinum. So just an interesting observation. So a couple of years ago, we decided to write about this, and we thought that maybe instead of using the platinum-free interval as the main discriminator for patients with recurrent disease, is that we ought to take into account histology, their molecular signature, particularly the BRCA status, the treatment-free interval. We went back to the traditional allocation, which was actually first purported by Blackledge in 1989, and the number of prior treatment regimens, so 3 or less or greater than 3. These seem to be very strong predictors for our anticipated response to the next line of therapy. Now, these are made on easily attainable factors. Probably the most restricted would be understanding molecular signature, but now there's concerted global effort to understand the BRCA at least the germline BRCA status of our ovarian cancer patients. And in most of the guidelines where the testing is available, it's recommended that that knowledge be known. But this is continuing to morph, as you can imagine, as more and more science emerges. We've learned a lot more about ovarian cancers that all look the same. So if you take a patient, for instance, that has a high-grade serous ovarian cancer and you start looking at ways that the tumors are different, you can see there's at least and there's several of these out there, but there's at least this 4-term classification based on different genotyping that shows these other categories which have prognostic value. So we're not quite there yet to be able to do this kind of subdivision, but it's already happening in endometrial cancer. So I can tell you that as the world gets more complicated, this will change. And the other thing I would like to just kind of highlight when you're thinking about patients with recurrent disease is that in addition to the factors that I mentioned already, there is a strong potential impact of what's available in the line just previous. So this would be the frontline setting. And the question is, how do these decisions impact these decisions? And one of the things that we've learned in this process is that maybe if these patients had access to PARP inhibitor, we should add that as a fifth category. So in addition to histology, their BRCA status, the treatment-free interval, and the number of lines of prior therapy, if one of those lines was a PARP inhibitor, it has a dramatic effect on what our anticipated response to treatment would be. So again, I just wanted to highlight that the idea of platinum sensitive and platinum resistance is very difficult. And at the regulatory level, in other words, at the FDA level, it's very difficult for us to make a convincing argument that a patient is either platinum sensitive or platinum resistant unless the immediate line of therapy was platinum. So this is becoming a very real part of our daily lives. Now, for patients that are considered I'll say platinum not amenable. So this would be patients who had been treated with platinum and progressed on it in the recurrent setting. This is the space where most of the single agents that are available to you have been studied. And I've just listed here the numerous phase 3 trials that have been done in this setting, including those that have FDA approval for this, and that's weekly, topotecan and pegylated liposomal doxorubicin, which were approved by these big phase 3 trials, which actually didn't show any benefit. They were for a time to progression overall survival. There was no actual survivorship benefit. There are 2 positive trials in this setting. Both of them involve drugs like treosulfan and canfosmide. And both of these trials are essentially positive for the control arm. So the novel drug versus the control arm, these were negative trials. So that's why I highlight them. But otherwise, you can see that all of these drugs essentially have performed the same when put head to head. So when you look at the NCCN guidelines, what you see is a laundry list of drugs that are acceptable. It doesn't mean they're great options, but they are definitely acceptable because they've all been interrogated in these head-to-head competitions, of which we've not seen any distinction between the two. So the next thought was, well, we've got these fancy new biologics that were emerging, and we thought, okay, well, maybe we can either combine drugs together or we can add a biologic. And you can see here that the biologics have appeared to provide some benefit. Trebananib and bevacizumab both were studied and found to have at least some benefit on progression-free survival. But the one I think that's gained the most traction has been bevacizumab, and this was approved in many places around the world on the basis of this trial, the Aurelia trial, which was taking a physician's choice chemotherapy that was non-platinum based and taking that same chemotherapy with bevacizumab. Relatively small trial, given the number of drugs. So you could use weekly paclitaxel, one of 2 schedules of topotecan or liposomal doxorubicin, and you threw in bevacizumab to that, either yes or no. And basically what it showed was that the overall objective response rate was dramatically increased if you added bevacizumab. And if you gave, and if you looked at the PFS, you can see there was a big difference in the progression-free survival, essentially doubling at the median, with no real difference in overall survival. But you can see the treatment benefit, the treatment arm for the combination here. And you can imagine the crossover that was seen in this type of trial. But I think what was really caught a lot of people's attention was the subgroup of patients who actually got paclitaxel given weekly. Now this was brought a lot of attention, not only because you can see there's a big effect in both progression-free survival and overall survival, but when paclitaxel is administered in this weekly format, it has a different kind of anti-angiogenesis effect. And because of that, we have essentially 2 anti-angiogenesis drugs being administered at the same time, as well as a cytotoxic agent, paclitaxel. So this was obviously of great interest, and it's been a reference point for most of the trials that we've been doing. And because of that, in 2014 in the United States, this was FDA approved. So in platinum non-amenable or platinum resistant patients, we have, like as I mentioned, we have a laundry list of drugs that can be good. None of them are great. There's at least under the restrictions of bevacizumab, it's bevacizumab's approval, which is 1 or 2 prior therapies. It seems to augment chemotherapy response. What about the other group of patients, the platinum amenable patients, let's say, that, or the platinum sensitive patients? So the first question that should be entering your mind is whether or not this is a group of patients that have that are good candidates for surgery. This has been obviously something that we've been debating for quite a long time. At this year, last year at this time, we published GOG 213, which is this curve here, which showed that there was no benefit to surgery in patients who were platinum sensitive and were randomized to surgery versus no surgery. At ASCO this year, we saw this trial, Desktop 3, and this trial, SOC1, and you can see they came to different conclusions. In Desktop 3, we saw a benefit to surgery versus no surgery. And in the SOC1, we saw no benefit to surgery versus no surgery. So it's very much debatable. One point I'll highlight here, though, is that if you look at the median survival for overall surgery, you can see that these numbers are very close to each other. And if you actually align the curves on top of each other, they look very close to the same. So more to come about that. We don't have time today to debate that topic, but I'm happy to. In terms of adjuvant therapy, the first kind of maneuver we made in this setting was to add something to platinum as a backbone. So you can see these 4 trials we're looking at, or 3 trials, we're looking at something added to a platinum. We had a non-platinum doublet here that was also positive. And then we had the Calypso trial, which was looking at 2 platinum doublets compared to each other. And overall, what you saw is that all of these trials showed a benefit to giving a platinum doublet. Now, a question that comes in is like, if you have a platinum sensitive patient, can you make them more platinum sensitive by giving something else? So this was an idea that was been around for a long, long time. I can tell you, we talked about this by trying to take platinum resistant patients and give them something to make them a longer than 6-month platinum-free interval. And this is a study that was just published about 2-3 years ago that looked at this in a prospective trial. And they basically showed that if a patient was given platinum first, followed by non-platinum, versus non-platinum followed by platinum, the patients who got platinum first did better for both their overall survival and for their secondary exposure to platinum. So, so if you have a platinum amenable patient, give them platinum. Now, as I mentioned in the frontline setting, there had been a lot of work done in adding these novel therapies to chemotherapy backbones. And bevacizumab was the first of these to be evaluated as well in the platinum sensitive setting. As I just showed you, it was positive in the platinum resistant setting. So the idea here was to do this same experiment using multiple different chemotherapy backbones. There's a long history of that. They're all listed here. But I want you to just look at the red. So all of these trials essentially showed that there was a benefit to adding bevacizumab to chemotherapy in platinum-sensitive patients. And these are big numbers, right? These are pretty strong hazard ratios. And then in 2 of these trials, we actually saw that there was an improvement in overall survival. So a very important effect. And in 2016, so 2 years after the last approval for bevacizumab, this was approved in recurrent platinum-sensitive disease. But the big story here is really about PARP. PARP inhibitors are drugs that we use in patients who have deficiency at the molecular level in a process of DNA damage repair called homologous recombination. These trials were started out initially as therapeutics. So they were actually given as treatment in patients that were defined by genomic, first by genomic BRCA mutations, and then secondly, by genomic instability, we call homologous recombination deficiency. And the trials that proved their value were in that maintenance setting, where patients who had been platinum sensitive, had a response to platinum, and then they were randomized to a PARP inhibitor, and there's 3 of them, rucaparib, niraparib, and olaparib, versus placebo. And you can see that these hazard ratios are very impressive, in numbers that we've never seen before in this setting, all of them highly statistically significant. And with this one trial here down at the bottom, Solo 2, there is a hint that there may even be an overall survival advantage to the use of these drugs in recurrent disease. So this is a big, big win. And of course, in the United States, all 3 of these drugs are approved for treatment in platinum-sensitive patients. So the current FDA approvals for this important role of maintenance are bevacizumab is approved for platinum-sensitive, and for platinum resistant disease to give with chemotherapy without restriction on the patient population, but there is restriction on the potential adverse events from bevacizumab, and that needs to be accounted for. The PARP inhibitors are also approved with no restriction on the patient population, but in my opinion, they should not be used in patients who've been previously exposed. While I can say to that about PARP inhibitors, it doesn't seem to be true about bevacizumab. So MITO16B was a study that was specifically designed to evaluate the effect of bevacizumab in patients who had bevacizumab in the previous line of therapy. And in this trial, what they used was gemcitabine and carboplatin, and they required everybody to have been exposed to bevacizumab with platinum in the frontline setting. And when they gave it to them in the recurrent setting, you can see that bevacizumab versus no bevacizumab has basically the exact same outcome that was observed in the OCEANS trial, which was in Bev-naive patients. So there doesn't seem to be a detriment to the reuse of bevacizumab. And this is not only for ovarian cancer, this has also been seen in colon and lung and many other tumor types. That's not the case for PARP. If a patient has been given PARP and they progress on PARP, giving the PARP to them again shows no effect. So, so in my opinion, it should not be used in patients who've progressed on PARP. The question about whether or not a patient actually progressed in patients who didn't progress on PARP in the frontline setting is actually the subject of an ongoing trial called OREO. And this trial will look at these patients who've been previously exposed to PARP inhibitor, have responded to platinum again, and then they're randomizing them again to a PARP versus no PARP. So we'll have some information about the PARP after PARP question, knowing that that Bev after Bev is okay to do. All right, and so just before I close, I just want to just highlight, where this field is going. As we learn about the different processes of what drives cancer, we are developing more and more innovative ways to interrogate and disrupt these processes. And I've just listed kind of those just general classifications here on this dial, but I can tell you that they're becoming even more and more complicated as we understand, for instance, what is responsible for invasion and metastasis. This is an exploding field right now, as is immunotherapy. So, in terms of what we do in the recurrent setting, the first thing is to try to provide a very good description of what it is that we're expecting to see from the patient. In terms of their classification. So patients who fall into this platinum amenable setting, we tend to want to give platinum. If they don't have a contraindication of bevacizumab and they're considered to be homologous recombination proficient, we tend to re-challenge those patients with platinum and give them Bev. If we know about the tumor's homologous recombination deficiency status, then we will frequently treat with them with platinum here and then give them a PARP inhibitor as a maintenance strategy. There is a trial that's ongoing right now called the Bouquet trial, which is also I just wanted to show it to you because this is kind of a phase 2 trial, and you can see the histologies that are listed here. These are all the ones that are generally excluded from the previous trials that I told you. But the importance I wanted to highlight here is that the arm assignment for this trial is all based on molecular characterization. So it gives you a good sense of how we're starting to dig into these tumors and even subclassify them even more. So instead of just having platinum sensitive and platinum resistant, we've got all of these other categories now that we're starting to explore into. And with that, I want to congratulate the society. Thank you for your invitation. Thank you for what you're doing. And thanks for your attention during this talk.
Thank you, Dr. Coleman. It was a very informative talk. I think a lot of new vistas, new directions that are opening up in recurrent ovarian cancer, and I think you really touched them in the right way. And I think it has been a really excellent talk, very comprehensive on the subject. Thank you.
Thank you. Thank you. Appreciate it. Thanks for having me.
I would now like to proceed further since we are running a little behind schedule. Can I immediately call upon the chairperson for the next session, I request Dr. R.S. Pardesi, who's from Aurangabad, to please unmute himself and also switch on the camera. Thank you so much, sir. I also request Dr. Jyoti Unni to please unmute herself. And I also request Dr. Manjari Valsankar ma'am to please switch on her camera as well and also unmute herself. We also have our first speaker, Dr. Rishikesh Pai from Mumbai. And I kindly request Dr. Rishikesh sir to please start his screen sharing so we could get his talk started. Dr. Pai, if you could put it in the presentation mode, that would be wonderful. Dr. Manjari, can we get started? We just need your go ahead since you're the chairperson.
Dr. Rajendra and Dr. Jyoti, can you unmute yourself and start the session, please?
Dr. Pardesi sir, please start the session.
Yes. Hello, good evening, everybody. To start with this session, I would like to request Dr. Pai sir to give his talk on ART in women with gynec cancers. Dr. Pai, I don't think any introduction to Dr. Pai. He is president-elect of FOGSI. After serving 12 years actively in FOGSI, I joined treasurer, deputy secretary general, and secretary general. Now he is president-elect of FOGSI. I think it's a biodata. He is instrumental for the amendments in PCPNDT Act, ART bill, surrogacy bill, and other medico-legal hassles, and hence he is always FOGSI friendly. He is great academicians. If you hear his talk on any talk on ART, then you will come to know. Over to Dr. Pai sir.
Before Rishikesh, before you start the proceedings, we thank Dr. Robert Coleman for joining this session. I think it is in a very odd time at his place where even then he has made it a point to be there for us. Thank you from behalf of Pune Society as well as on behalf of FOGSI. Thank you for joining us. Dr. Pai, you may start. Thank you.
Can you hear me? Yes, Dr. Rishikesh, you can start.
Thank you for inviting me for this talk. I'm really privileged and obliged.
Dr. Pai, sorry to interrupt. Can you put it in a slide? Yeah. Okay. Perfect. Yeah.
So if you look at the ART in women with cancers, there may be two areas. One is preventive, that is fertility preservation, and second is therapeutic, that is ART in post-cancer therapy women. So I'll first take the latter first, and there's this, I was just looking at the papers and there's no difference. This is a paper where they looked at pregnancies following breast cancer using assisted reproduction and its effect on long-term outcome. And they found that there was no difference in the outcome in both the groups, one which tried for natural pregnancy and in one where they tried ART for the pregnancy. If you look at the other common cancer, that is Hodgkin's lymphoma, there are two protocols that are currently used. One is the ABVD protocol and another is the BCOP protocol, which is more toxic. And if you use the ABVD protocol, they have shown that there is two studies have confirmed the safety of ABVD with a birth rate comparable to that of the general population, regardless of patient age and the number of treatment courses. So if you look at the anti-neoplastic therapy, it really damages the fertility, chemotherapy, radiation. You can sometimes have a Wetheim's, bilateral oophorectomy, sometimes prophylactic oophorectomy in BRCA 1 and 2 positive patients. And this is a beautiful reference chart. So this is from the archives of Gynaecology and Obstetrics 2018, where the risk factors are based on high risk, intermediate risk, low risk, and very low risk. So permanent amenorrhea, that is permanent ovarian damage in high risk group, is 80%, And you can see that the BCOP therapy comes under intermediate risk where 40 to 60% ovary can get damaged, while the ABBD therapy has a very low risk. So this is an important reference chart. Whenever you are looking at patients who have taken various cancer therapies, you can refer to this chart and find out what is the damage that they have caused. This is another very good chart where you can see that the risk of ovarian insufficiency goes to nearly 60% when between 2 to 5 guys of radiation therapy is there. And this is called ESD, that is the effective sterilizing dose. And as the age advances, the effective sterilizing dose goes down. If you look at the fertility sparing techniques, there are different ones, such as you can do LEAP, tracheography, uterine conservation, cystectomy, you can do ovarian transposition, you can try with low dose chemotherapy, low dose radiation, GnRH agonists can be given, and you can of course do fertility preservation. Ovarian transposition is very good treatment, and you know, many people are advocating a unilateral transposition. So you take out one ovary, and after the radiation therapy is done, you can put the ovary back. But even the one which you didn't take out, it may also function and give rise to a natural pregnancy. GnRH analog is another medicine which has been tried very effectively, and they have shown that there is a 94% return after chemotherapy, return to menses 3 to 8 months after cessation of treatment. As compared to that, it doesn't protect against radiation therapy. And there are 3 new products that are in the market now: Sphingosine 1-phosphate, SIP, and AS101, and imatinib, which protect against radiation and cytotoxic therapies by suppressing apoptosis pathways in the germ cells. If you look at the fertility preservation, we have the standard embryo freezing method, the egg freezing, which you can do mature or immature egg freezing, ovarian tissue freezing. You can isolate and preserve the primordial follicles. You can isolate and preserve the ovarian stem cells, and you can also preserve other stem cells. And if you look at the protocol in ovarian freezing, we stimulate the ovary with gonadotropins and antagonists, give a ovulation trigger, do the egg retrieval. After 2 to 3 hours, we do the dissection. So you can, after the, you can see this is the ovarian freezing part and the embryo freezing. These are combined, and this is the open and the closed system which I am demonstrating to you, in which this is a solution of DMSO and ethylene glycol, 7.5% weight by volume. So if you drop the oocytes, we dissect the oocytes and drop them into this for about 5 to 15 minutes. They initially shrink and then they re-expand. So once they re-expand, we know that the cryoprotectant has perfused into the oocyte cytoplasm. And see, you can see them shrinking, and then they re-expand. Once they re-expand, this is the closed system where we have double protection. So you have a carrier system, and there's a sleeve which goes over the carrier system. So we take out we keep it ready, and as soon as the 15 minutes are over, or as soon as the oocyte re-expands, we put them through 15% weight by volume solution of ethylene glycol and DMSO, which is very viscous. You have to do it within 40 seconds. You have to go through 4 droplets in 40 seconds, put them on the carrier system in a very small droplet of 10 microliters, you can see here, and immediately put the cover on. So that is how it becomes a closed system. You put the cover on, seal it, and then drop it in liquid nitrogen. So the rate of fall of temperature is around 12,000 degrees centigrade a minute. So with this rate of fall of temperature, the water in the cytoplasm forgets to create ice crystal formation. It vitrifies, and that's why there is no damage to the oocyte. So you can see you directly drop it in the liquid nitrogen, and then you put it there and store it. Similarly, you can also do embryo freezing. So many, in cancer patients, some of them are married. So in that case, their partner or husband can, you can fertilize the oocytes and then create embryos and freeze them. But many women who are unmarried, you freeze the oocyte. So this is a carrier system. This is an open system. You put the embryos. It's just like the closed system. Only thing is, after you put the drop, you directly dip it in liquid nitrogen. There is no sleeve. Because of that, what happens is the rate of fall of temperature is 24,000 degrees centigrade a minute. So it is more efficient. So the closed system is not as efficient as the open system, but it is more safer because there is no direct contact with liquid nitrogen. When you want to thaw it, on the other hand, this is, you open the external sleeve and you have to quickly take it out. This is a very important. It's like Abhimanyu. This is the most important step of thawing. This distance is very important, very short distance. And you can see that as soon as you dip it in the thawing media, the oocyte will pop out. And this is a fantastic, I call it Jadoo, because when I started doing this system in 2007, I got trained in Tokyo and I came back. I got hundreds of who said full recovery, more than 90% recovery. Of course, we were the pioneers there. Of course, a lot of people started doing this, but we have had a huge amount of experience in the oocyte freezing. So how many number of oocytes you need to have a good chance of fertility in the future? So as the age advances, you need more oocytes. So at around 38, 40, I would not go for 7 oocytes. This is a paper of 2018. I want more oocytes, at least 12 to 14 oocytes is my target. So if the patient has, but in a cancer patient, you can't do the second cycle. This is very bad. So the other technique is the ovarian tissue freezing. So when patients have got no time, chemotherapy has to be started or radiation has to be started, immediately you need to but the problem with ovarian tissue freezing is that you may re-implant the tissue. Suppose there are malignant cells in the ovary at a microscopic level, you may freeze the ovary, and when you, after 5 years, when you are re-implanting the ovary, you may re-implant the malignancy. And these are the various low risk, medium risk, and high risk. So in this patient, breast cancer stage 1 and 2, and infiltrating ductal types, squamous cell carcinoma, these are Hodgkin lymphoma. These are more safer as compared to leukemias, neuroblastoma, Burkitt lymphoma. You should avoid doing ovarian tissue freezing in them. So this is how we do the ovarian tissue. We take the ovary out by laparoscope, and my cancer colleagues, they send me the ovaries. So when we dissect the medulla out, the medulla doesn't have the follicle. It is only the cortex, and you have to totally dissect it out. You have to make it threadbare. And after it is made threadbare, the total medulla is removed. So that small, thin, 1 millimeter thick cortex, and you will be surprised that one of the most thickest, most strongest tissue in the body is the ovarian cortex. You can't pull it. It has got tremendous tensile strength, and then you pass it through vitrification media, for nearly 50 minutes you put it, and then you put it on a carrier system. You can see this is a carrier system, and then you dip it in liquid nitrogen and then put it in the NUNC vials, and then you freeze the tissue. Once you want to put it back, you thaw all the tissue slices, and then you stitch them up together in 8-0-proline, and you put them back into the ovarian fossa. So Dr. Kurtuk Okte, who is the pioneer of this, he looked at from 1999 to 2016, 309 ovarian tissues were frozen, and that resulted in 84 births and 8 pregnancies that lasted beyond the first trimester. So it's still experimental, but it's now coming into actual, and this is a new study where they have shown systemic review in 2018, where they have shown 360 ovarian tissue transplant procedures in 318 women, 9 women diagnosed with cancer. There is no evidence to suggest that OTT causes reseeding of the original cancer. Renewed ovarian endocrine function was reported in 95% of women, 87 live births in 69 women, total of 93 children were born. So the other area of OTA, ovarian tissue freezing, is in children. So if they have not reached menstrual landmark, then in these patients also you can remove the ovarian tissue and freeze it. And this is a study where they did ovarian tissue freezing in 64 patients. Median age was 12 years old, and laparoscopic unilateral oophorectomy was performed in 84% patients. And they concluded that laparoscopic unilateral oophorectomy with ovarian tissue freezing can be performed safely in combination with other ancillary procedures as an outpatient procedure without delaying medical therapy for children facing fertility-threatening diagnosis or treatment. So, it is very important to look at the patient age, cancer type of treatment, patient preference. They may prefer doing, donor sperm. They may prefer going for egg donation in the future. So you must tell them that when you're counseling that there are 3 options available to them, that fertility preservation, or they can also go for egg oocyte donation or go for adoption in the future. So, and you must look at also whether the cancer prognosis is good, whether there's a high risk of premature ovarian insufficiency, and look at the age as well. So this is a beautiful chart, which is a decision-making chart. So you look at you consult them, look at the prognosis, if the future pregnancy is compatible with patient's health. If it is, then you look for whether it is high risk for infertility. Yes, it is. Can fertility preservation be performed with low risk? So you look at the time frame. If you have got only 1 week before you need to start chemo radiation, you give a GnRH agonist. If you have got 2 weeks, you can do ovarian stimulation and oocyte freezing. If you have got 3 weeks, you can do double stimulation of the ovary. If there is low risk of ovarian metastasis and malignancy, and there is 1 week, then freezing of ovarian tissue, 2.5 weeks, freezing of tissue with stimulation and oocyte freezing. And if there is pelvic radiation therapy involved, you go for ovarian transposition. So this is a very important chart, and I follow it in my practice. So if you have got, you can have 3, when the patient comes to you, there is no time. So you may have, she may come in the early or mid follicular phase, and if the follicle is less than 12 millimeters, you start them on letrozole. If there is a estrogen receptor positive tumor, give them gonadotropin stimulation. And when leading follicle is more than 14, you start antagonist. This is the tricky situation. When they come in the middle of the cycle, you look for the follicle. If it is more than 14 millimeters, you create a rupture. So you give a trigger, rupture the follicle. After the follicle ruptures, you start the stimulation, just like in the luteal phase, you do the standard stimulation of gonadotropin. So anytime stimulation can be done to preserve. And this is a beautiful slide where you combine 3 techniques. So patient comes to you on the first day, you go in with a laparoscope. On the second day, take out 1 ovary out and do ovarian tissue preservation. Immediately start her on stimulation, gonadotropin, along with antagonist. And if there is estrogen receptor positive, you add letrozole to it. After 12 days, when you're about to give trigger, you give the GnRH depot as a trigger, because it will not only act as a trigger, but after the retrieval of the oocytes, you can immediately start the gonadotoxic therapy, and the agonist will protect the ovary from gonadotoxic therapy. So this was a case discussion. The 18-year-old unmarried came to me about just before the COVID, about 10 months back. They phoned me from the middle of India. Both the doctors were parents. He was a radiologist. She was a gynecologist. Daughter was 18-year-old unmarried medical student. They flew down the next day. I talked to them. They flew down. I did a scan. She was in mid follicular. Follicle was 16 millimeters. I gave a GnRH trigger to rupture the follicle. Started that gonadotropin stimulation. Started the antagonist. Gave the GnRH trigger, and it retrieved 21 oocytes. 17 oocytes I vitrified. We immediately suppressed her with antagonist. In 4 days' time, she started her chemotherapy. So this is between 2007 to 2010, this is one of the groups, the EV group, where you can see that the maximum patients who come for fertility preservation are breast cancer patients, followed by Hodgkin's lymphoma and non-Hodgkin's lymphoma. And this is the Fertility Protect Network, which you should subscribe to if you are going to go for chemotherapy. So they have concluded that in breast cancer patients, fertility preservation such as ovarian tissue or oocyte preservation is especially recommended in low stage cancer and in women less than 35 years of age. In Hodgkin's lymphoma, the indication is mainly based on chemotherapy regimes, as some therapies have very low and others very high gonadotoxic effect. In borderline ovarian tumors, preservation of fertility usually is achieved through fertility sparing surgeries. Ovarian stimulation may also be considered. And in other cancers, you need to do it by, I can go on and on. I got so much data on each cancer, but there is no time as such. There is something also called transplantable artificial ovary, because the biggest fear is to, when we put back the ovarian tissue, we may put back the cancer. So what we do is now, there is a lot of experiments going on where you dissect the primordial follicles and you create a new matrix and create an artificial ovary, implant the follicles in the matrix and put back the ovary. So this is a new research. As well, you can also do stem cell. So after the chemotherapy is over, you can take the ovarian biopsy, you can harvest the stem cells, and you can nudge these stem cells to undergo meiotic division and create oocytes and use them in the future. So this is one survey which was done by Dr. Ziv Shoham in 2019, and he surveyed nearly 321 IVF clinics, and they surveyed 299,800 IVF cycles, and nearly 86% perform fertility preservation, 37% clinics perform ovarian tissue cryopreservation, 52% consider the procedure experimental, and 76% agreed that fertility preservation was successful enough to make it an available option in the future. So the take-home messages are that fertility preservation is here to stay. It is applicable. It is applicable to in numerous areas. One can postpone fertility for lifestyle reasons. Life exists after cancer, and fertility insurance, aka life insurance, is very important. And this is a beautiful chart of how to create a fertility clinic for fertility preservation. There's a lot of things involved in this. We have got various groups, communication skills, oncofertility training, reproductive survivorship care needs, ethical considerations are needed. So many groups. So in fact, our group is very much keen. We have done a lot of preservation, and we are about to launch a nationwide fertility preservation group as a separate branch of the Bloom IVF group, which we run along with Nandita. And I'm really excited. I'm looking forward to a fantastic future in fertility, in the area of fertility preservation, especially in cancer patients. I would like to thank all of you for a very patient hearing. Thank you.
Thank you, Dr. Pai. As usual, it's an excellent talk on ART, but ART for women who are having gynec cancers, and he has explained very nicely the fertility preservation techniques, vitrification process, and ovarian success, ovarian freezing, ovarian tissues, and success of the transplantation of artificial ovary. And I think it will be success, as Dr. Pai, scientists like Dr. Pai.
I would like to tell that there's a beautiful workshop coming up from the Israel group on live workshop on fertility preservation. If anyone is interested, because I am going to attend that workshop. They are the largest series of fertility preservation in the world at present.
If this artificial ovary will be successful, then I think it's wonderful.
Yeah.
Thank you so much. Thank you, Dr. Pai.
Thank you.
Thank you. Can we now move to our next speaker? He's joining us all the way from US.
Thank you very much, Dr. Pai. And we move on to the next speaker, Professor Sharad Ghamande, who's the Director of Gynecology, Department of Obs and Gynae, Chief of Gynaecology at the Medical College of Georgia in the United States. And he is going to talk to us about the controversies in HRT in women with gynec cancers. So over to you, Professor Sharad.
Dr. Sharad, you need to unmute yourself, sir, and start screen sharing. Dr. Sharad?
Dr. Sharad, if you can hear us, can you hear us?
Yeah. Please share your screen, sir. Share your screen, sir.
Give me 1 minute, okay?
Yeah.
Should I say good morning, Sharad?
Yes, good morning.
Yeah, because it's a good morning out there. I think. What is the time there now?
It's about 9:30. It's not bad. Can you see the screen now, and can you hear me?
Yes, we can, and we can hear you also, Professor Sharad.
So it's an absolute pleasure to be here today. As you know, I did my medical school in Bombay and have the privilege of looking at—
Professor, put it full screen.
One second.
Yeah.
Let's see if I can do that.
The bottom.
The lower. Yeah. Do a slideshow.
There you go. Good?
Yeah.
All right. So again, you know, it's I did my residency in my medical school in Bombay, and I have the pleasure of looking at Rishikesh, who was my lecturer, Dr. Pai, and Harshad Parasnis, who was kind enough to invite me, who was my junior resident. So it's a full circle, and I'm absolutely delighted to be here. So I'm going to kind of move on with the presentation. I'm the chair of OBGYN department, but more importantly, I'm a gynecological oncologist and have been heavily involved in a lot of clinical trials. And I sit down at the National Cancer Institute for a variety of communities, especially for disparity research and in phase 1 in cervical cancer. With that, we're going to talk a little bit about hormone replacement therapy. This is my mandatory slide because I don't practice in New York or Chicago. I practice in Augusta. And so we got to brag about, we are the hope for the best golf tournament in the world, which is the Masters. So as we talk about hormone replacement therapy in gynecological cancers, just want to spend a couple of minutes talking about estrogen. Since its advent in early 1900s from Egypt, in 1942, Premarin was manufactured from horses, as you know, and that in mid-70s became the most prescribed drug in the world. And look at this little slide from Harper's Bazaar, which is a chic magazine. It apparently did everything, anything and everything a woman wanted. This was like this magical wonder drug. However, things got derailed with the Women's Health Initiative trial. And it's important to know the controversies in estrogen replacement therapy in non-cancer patients, as we talk a little bit about its role in cancer. So the WHI trial was an unbelievable trial. They were almost close to 160,000 participants. And essentially, they were looking at cardiovascular effects. But there were two groups: people who had a hysterectomy got estrogen alone, people who did not have a hysterectomy got estrogen. And unfortunately, they started the patients in mid 60s. So it was not a classical patient that you put on hormone replacement therapy. Long story short, they're busy slides. I'm going to just focus on one thing. The big news was, because there was a slightly higher incidence hazard ratio of 1.26 for breast cancer, and the fact that they were cardiovascular adverse events, this made a big dent. This was in CNN, New York Times. All of a sudden, the stock as well as the number of prescriptions for estrogen went dramatically down. What did not get as much publicity was the fact that the estrogen alone arm in patients who had a hysterectomy, which is very common for our patients with gynecological cancers, there was actually a reduced risk with a hazard ratio of 0.77, with 8 fewer cases for every 10,000 women. So at least we know that estrogen therapy by and large is pretty safe in that sense. And more importantly, when they did all the other stuff as time went by went away, but the impact on breast cancer with a long-term follow-up in 2011, this study started in 1991, still showed a persistent effect. So with that, we're going to go to gynecological cancers. As you know, as many of our patients, almost 40% of all patients we treat for gynecological cancers, as Rishikesh can attest to since he sees many of them, are pre or perimenopausal at the time of diagnosis. Along with that, if you look at people who are destined to get gynecological cancer, so BRCA positive or Lynch syndrome or any other of the newer genetic markers, we do recommend through various societies early risk-reducing surgery based on the mutation. So compared to a natural menopause, which is over a period of time and gradual, we have cold turkey cutting the estrogen supply. And now you have patients with significant vasomotor symptoms, sexual urinary dysfunction, premature bone loss, and significant adverse cardiovascular effects. Especially in this day and age, when we have more and more patients who are survivors and we make a lot of cancers chronic disease like ovarian cancer, it's really important that we look at survivorship and quality of life. And that's what makes estrogen or hormone replacement therapy an important part. Now, there are many other potential things you can do, but the fact is there is really nothing like the real thing, which is estrogen, which is whether it's vasomotor symptoms or genital atrophy and dryness, which affects their sexual functioning. So obviously, to do or not to do is the question. And we'll start with endometrial cancer. As you know, in the United States, cancer, however, worldwide, there are almost close to 400,000 new cases of endometrial cancer that we diagnose every year. As you know, there are two kinds of endometrial cancer. And type 1 are the ones which are associated with estrogen excess, have a precursor lesion which goes from hyperplasia to complex hyperplasia atypia, and it usually is associated with PTEN mutations. The key here is 25% of these patients will be premenopausal at diagnosis, and almost 8% are below the age of 45. So we do see a fair amount of patients who are young with endometrial cancer. So this was a really good trial which Rich Barakat did, and through the Gynaecological Oncology group. This was a prospective randomized trial where we looked at placebo control, where we looked at early stage endometrial cancer, stage 1 and stage 2, who were to be on hormonal therapy or placebo for 3 years with a total follow-up of an additional 2 years to make it 5. However, as this trial was enrolling, the WHI data we just talked about came out, and it became a little politically sticky, so that trial was terminated. But by the time the trial was terminated, we still had about 1,236 eligible patients, which is a pretty decent number. The average age, when the median age of diagnosis where they were assigned to estrogen replacement therapy, was 57 years. And at the end of 3 years, about 40% were still compliant by using estrogen. But if you look at the disease recurrence between the two groups, there was very little difference, 2.3% in the hormonal arm with 1.9% in the placebo arm, with a obvious improvement in quality of life with vasomotor symptoms in patients who were getting estrogen. So this is a really good trial, which gives us a very good signal, at least for early stage endometrial cancers. Estrogen replacement therapy can be safe and potentially beneficial in terms of quality of life. There was another meta-analysis done which included this randomized trial and about 5 other observational trials to get bigger numbers. Essentially, it showed the same, no significant increase in the risk of recurrence in patients with endometrial cancers who used hormone replacement therapy. And that was stratified by a variety of things, including stage and cell type and disease and type of HRT. When we look at sarcomas, which are rare, less than 5% of all endometrial cancers which come from the uterus, there are some which do have estrogen receptors, and for example, endometrial stromal sarcomas, they can be uniquely sensitive to anti-estrogen or hormonal therapy. So I think in those patients, you just have to be a little careful because we really do not have any significant data in terms of safety, and there's a potential risk in giving them estrogen. But again, you have to always individualize those decisions. Ovarian cancer is probably the most lethal gynecological cancer. As you know, most of them unfortunately come and present at advanced stage. And there are still about 300,000 new cases that we diagnose every year. 4% of patients are below 40 years at diagnosis, and there's a significant number of patients we still get ovarian cancer in early 50s around menopause. So that's still a significant number of patients who do have menopausal symptoms. There have been 2 randomized clinical trials, although they are small. The first one was published in Cancer in 2000, where they started hormone replacement therapy within 8 weeks post-op from about 87 to 94. 130 patients randomized 1:1 with estrogen replacement therapy or no supplementation, about a 48-month follow-up. Essentially, there were no differences in disease-free interval or overall survival. Not necessarily a big number trial, but at least you have some information. And this was followed by another trial called the adjuvant hormone trial, which was a phase 3 randomized clinical trial, which was non-blinded. But this had 19 centers across United Kingdom and Spain, about 150 patients in 5-year span, which is not necessarily, frankly, great enrollment. But the cool part about this was the median follow-up, which was almost close to 19 years. And again, they did not have any significant difference in recurrence rates. In fact, for some reason, they had a slightly improved progression-free and overall survival in patients who actually were on hormonal therapy with a hazard ratio of 0.63, a 37% improvement. So by and large, for ovarian cancers, even advanced disease, especially for serous cancers, hormone replacement therapy in the right patient seems to be fairly safe. Cervical cancer, as you know, is biggest cancer worldwide. There are about close to 500,000 new patients with cervical cancer diagnosed all across the world, and about close to 300,000 die every year, which is still a tragedy despite advances in vaccination and Pap screening. This is one place where hormone replacement therapy is extremely poorly utilized because many of our patients are very young. There are obviously other things. Ovarian conservation is feasible. You can always preserve the ovaries and do an oophoropexy and potentially take them out of radiation field. And it's reasonably safe because ovarian mets overall for cervical cancer is extremely rare. And the thing to remember when you talk about cervical cancer and HRT, most of the patients which we see have advanced disease, and hence they retain the uterus as they undergo treatment. So we have to include some sort of a progestational compound with estrogen because there absolutely can be a secondary endometrial cancer over a period of time, although it's rare, despite being in the radiation field. Is there any data? And the answer is yes, not necessarily the greatest one. This is an old trial published in 1987 from Poland. About 120 patients from one single institution randomized 2:1 to hormonal therapy and placebo. They had two different hormonal preparations. They had a decent follow-up, and again, really did not see a difference in recurrences, but a better quality of life in younger patients who were on hormonal therapy for a variety of indices. So there is reasonable data, not the greatest, most of it is level 2 or less, that shows that hormone replacement therapy can be safe. And this is another paper which was in GYN Oncology in 2011. This was a Medline search looking at all gynecological cancer patients put together, which again did not show any significant differences in recurrence rates when people were on estrogen or hormone replacement therapy. So let's switching gears. What about patients who are destined to get cancer, like somebody with a BRCA1, BRCA2 mutation or a Lynch syndrome? And as we talked about earlier, we often get fertility sparing operations in this patient population. And again, there is a fair amount of data. This is published in JAMA Oncology in 2018. This was a really nice longitudinal cohort study with BRCA1 and BRCA2 mutations in 80 participating centers in 17 countries over a fair amount of time. So it's kind of sort of well representative of populations across the world. About 872 mutation carriers who had BRCA1 were followed for about 7.6 years. And they looked at hormone replacement therapy after oophorectomy in these patients, because when we do that to prevent ovarian cancer, one of the questions always comes up, would it cause breast cancer? Well, this really nicely showed that using HRT after an oophorectomy was not associated with increased risk of breast cancer at all. The only caveat here, the kind of hormonal therapy you gave made a difference. If it is estrogen alone, the cumulative incidence was 12%, but it was higher when we did estrogen and progesterone together, which is kind of consistent with the WHI trial that we talked about at the beginning of the talk, that progesterone seems to have a little bit more role to play than estrogen as we talk about breast cancer. Another study, which was a case control study, which was published in early 2008 in NCI, with 470 postmenopausal patients. And when they were on estrogen replacement therapy, actually it showed a reduced risk with a hazard ratio of 0.58, an inverse association of breast cancer risk in patients who took estrogen. Whichever way you look at, fundamentally in younger patients undergoing risk reduction surgery, there's, I think, reasonable data out there to support use of estrogen without too much hesitation in that patient population. Obviously, we are getting more and more caught up with Lynch syndrome and its role in colon cancer and endometrial cancer. And as you know, almost 12 to 13% of those patients also will get ovarian cancer. So this was another cohort study, which was done about 1,128 patients from a colon cancer family registry, which was across the United States, Australia, and Canada. And they looked at the incidence of endometrial cancer in these patients who when they were on hormone replacement therapy, and really no significant difference at all based on the length of usage, and no statistically significant association when they were looking at other things like the age at menopause or menarche, so that in patients who are potentially destined to get endometrial cancer, HRT really does not make much of a difference. So what are the alternative for vasomotor symptoms, since we are talking about this in our patient population? And there are probably the only drug which is actually non-hormonal therapy, which has been now FDA approved in United States, is an SSRI, an antidepressant, which is paroxetine, which is marketed as Brisdale. And there are two randomized double-blinded prospective trials with over 1,000 patients, which showed that it did help after 12 to 24 weeks in reducing the incidence of hot flashes. Other SSRIs, which is like the venlafaxine or citalopram, also do work, but there are some which we don't. For example, fluoxetine, which is Prozac, or sertraline, which is Zoloft, do not work well in terms of reducing hot flashes. So those are alternatives you can give to a patient if a patient is not eligible or not comfortable using estrogen replacement therapy. I'm not going to spend too much time on this slide. Most of it is fairly anecdotal with very little really good data, from gabapentin to clonidine to phytoestrogens, which are plant-based products, and tofu, to herbal treatments, especially black cohosh. Most of them are non-standardized, and they can also have adverse events. The next thing we talked about, apart from vasomotor symptoms, is the fact that many of the patients have vaginal dryness. And again, you can use estrogen vaginally. Last thing, as we talk about, is there are also drugs available for vaginal dryness, and a drug called osphine or ospemifene, which is in the same class of tamoxifen. It's a SERM. Unlike, however, tamoxifen, it's an estrogen agonist, and there have been 3 pivotal phase 3 studies with about 1,700 patients, which do make a difference in this patient populations. So apart from estrogen, you do have some options. And I'm going to really run quickly through this. You need to individualize care. It's a conversation that you need to have with a patient because each patient has a different level of anxiety as you talk to them. But in the select patients, quality of life can be a major issue, and there is no real good substitute for conventional estrogen replacement therapy, especially for vasomotor symptoms and vaginal dryness, and use it for the shortest possible duration, which seems reasonable. We do have a statement from the Society of Gynaecological Oncology and the North American Menopause Society, which came out very recently as a clinical practice statement, pretty much talking about what we just talked, the underutilization of hormone replacement therapy, and the fact that for the big cancers, the risk-benefit profile is favorable. And with that, I am going to end this and appreciate your the time and your attention to this talk. And again, thank you for inviting me to give this presentation.
Thank you very much, Dr. Sharad, for a really lucid presentation. And I hope all the delegates are now convinced that HRT is not all bad. And if you are not confident about prescribing hormone therapy, if women require it, please do refer them to people who are confident and able to improve their quality of life. Just want to make one point that if you're using paroxetine, please be careful with patients who are on tamoxifen, because the enzymes they use are the same, and so you might have a lower action potential of tamoxifen. So be a little cautious about that. Thank you very much, Dr. Sharad.
You're very welcome.
Yeah, excellent talk, Sharad.
Thank you, Harsh.
Dr. Jyoti or Dr. Rajendra, can you call the next speaker?
Nice hearing you after a long time, Sharad.
Likewise.
We'll be in touch.
Rishikesh, that's what he was saying, that you were his senior and I was his junior.
Yeah, I know. I remember the good old days.
Yeah.
Can we have Dr. Basab sir to please start his screen sharing?
I need you to drive me to the village.
Are you going to introduce Basab, Manjari?
Yes, I take this opportunity to introduce Dr. Basab Mukherjee. He's a renowned obstetrician and gynecologist from Columbia Isha Hospital, Kolkata, and a fertility consultant and an oncosurgeon as well. So over to you, Dr. Basab.
Dr. Basab, you need to unmute yourself and share screen.
No, I can't share my screen because the screen is being shared by somebody else.
Sir, but we...
yeah, now I can. Now I can.
Yeah.
Thank you. So thank you very much. I thank Dr. Harshad and his team and for making me a part of this Just Tumor International Conference, and congratulations to POGS, Pune OBS Society, and all its and all the members. What I'll be dealing in the next 10 to 15 minutes will be contraception in gynae cancer survivors. Excuse me the flash of colors, but I thought a little bit of colors in just tumors would be just about perfect. So the opening thoughts. Many women are affected by cancer early in the reproductive years. This is something which we know, and the efficacy of treatment has increased with many fertility preservation options. We've just had a wonderful talk on fertility preservation by Dr. Rishikesh Pai, and fertility preservation prior to chemotherapy and radiotherapy is generally gaining popularity, and now which is only limited to a few centers would soon become much more affordable and acceptable and be available all over the place. So dilemmas in contraception for gynae cancer survivors. Well, contraceptives may increase some health risks. The ones which we are concerned with is the VTE risk, so venous thromboembolism risk. If it's already increased because of the cancer, it may be further increased, especially giving hormonal contraception. Then the hormone dependency of the cancer needs to be taken into consideration. The estrogen receptor, the progesterone receptor, and how exactly that works. The age of the woman, her medical background are also vital in choosing the birth control method, especially if she's later in her reproductive age. She may have other contraindications or other concerns about some contraception, especially hormonal contraception. So just taking them one by one, let's go to the breast cancer survivors first. And that is one of the most interesting areas. The breast cancer risk with hormones. Well, that's something which we need to address before we go to the survivors. Well, we know that combined oral contraceptive pills has been associated with a modest increase in the risk of breast cancer for long-term users who have started using the pills before the age of 20 years of age. And this is the risk which lasts very temporarily and goes after the pills are stopped, but it is something which is there and we need to accept this. And this needs to be shared with if the patient wants to have some information on this. But again, long-term users, when we're talking about 10 years or more, which is very few people use contraceptives for that long. Hormone therapy, as we just heard a wonderful talk by Dr. Sharad, hormone therapy can promote the growth of pre-existing lesions into hormone-dependent cancers of low aggressivity, and that is something which we know, but we had a wonderful talk on the hormone therapy, how it plays a role. Both ER positive and ER negative breast cancers seem to be increased by exogenous hormones. So till now we were concerned more about the estrogen receptor positive breast cancers, but there is sufficient evidence for us to understand that estrogen receptor negative breast cancers too can be increased by exogenous hormones. The post-breast cancer fertility issues. Well, ideally, a woman should be waiting for 2 years after breast cancer treatment and possibly 5 years after a hormone treatment like tamoxifen, if she was using tamoxifen, which is commonly prescribed in ER positive breast cancer. In some cases with increased age and poor ovarian reserve, a woman may be allowed to try for a pregnancy earlier. So we're not talking about contraception now, we're talking about when she can become pregnant in a woman who's been treated for breast cancer. In young patients, we need to remember that amenorrhea or severe irregular periods after chemotherapy may not always indicate an ovarian failure, and she may still need contraception if fertility issues are not there. So contraception in breast cancer survivors, well, the ideal contraception would be a non-hormonal contraception with good efficacy and tolerability, and a copper IUD fits the bill and ticks many boxes. It does not interfere with the drugs, and the infection risk, which is one of the concerns after chemo and radiotherapy, remains generally low. So there were some worries that after a chemo and radiation, a woman may be prone to more infections with the copper IUD, but those have been largely unfounded. About unscheduled bleeding, well, yes, that is one concern which can overlap with the tamoxifen use bleeding, and that is something which would need to be taken care of. Coming to the WHO MEC criteria for breast cancer survivors, they categorically mention no hormonal contraception, either estrogen, progesterone, during breast cancer treatment. But more than 5 years from diagnosis, WHO MEC puts most of the hormonal contraception into category 3, where the risks outweigh the benefits. LNG IUS use, well, how is that placed? it is debatable because it's got hormones, of course, but there's dubious evidence on both sides of whether there is lack of strong evidence on the safety of use. And so whether we can use it is a question, but of course the IUDs are fine. Non-hormonal contraceptives can be used anytime, and they are okay for breast cancer survivors. Coming to endometrial cancer survivors, contraception and endometrial cancer risk. Like we know that combined hormonal contraception has a protection over the risk of endometrial cancer. And in women less than 40 years, there is a decreased risk, which is highly significant and remains protective for more than 15 years after stopping the pills. So the protection which is gained is persistent for a very long duration of time, and it's also likely to benefit women with the Lynch syndrome or hereditary cancer syndrome. Their contraception or combined hormonal contraception has shown to be of a benefit. Coming to the endometrial cancer, where do the patients play in the reproductive age of their lives? Well, 4.5% incidence is seen in women less than 40 years of age, women who would be mostly needing contraception, we could say, but most cases are sporadic. Obesity, PCO, hypertension, nullipara coexisting, and 10% are seen in the Lynch syndrome. Most women with hyperestrogenism have low-grade tumor and histology. Treatment depends on the same. So contraception in endometrial cancer survivors, which would be the best method of contraception if they do not want children and their fertility is preserved? Well, copper IUD protects. There is an inflammatory effect on the endometrium and stabilization of the endometrium, suppressing oncogene PTEN. But the breakthrough bleeding with IUDs is something which limits its use, and the breakthrough bleeding is something which limit in endometrial cancer survivors, because you will be wondering whether it's due to a recurrence of the disease or whether it's because of a side effect of the IUD. The risks with combined hormonal contraceptive are greater than the benefits, and so that's also something which with estrogen would be not recommended. But high dose progestogens and LNG-IUS often have a dual effect of both therapeutic and contraceptive and may be offered to these women. Barrier or natural methods have a low Pearl index, and though they are often okay to be used in many cancer survivors, but because they have a low efficacy rate, it's something which we need to be concerned, because these are women who do not want to be pregnant at any point. So cervical cancer survivors, what about them? What contraception works best for them? Just to have first the cervical cancer risk with contraception. Well, we know that hormonal contraception is considered a risk factor for CIN and cervical cancer when it is used for more than 5 years. And there is enough of evidence to suggest that the risk also extends from beyond squamous cell carcinoma to adenocarcinoma too. So the copper IUD use is debatable. There's some studies showing a protective against CIN risk and invasive CA, while others show a small increased CIN risk with LNG-IUS. So what are the contraception which is ideal in cervical cancer survivors? We know that the trachelectomy surgery and after conization, these are the ones which would preserve the fertility. Then they would be needing some method of contraception to prevent a pregnancy. Surgery or RT, on the other hand, would usually lead to infertility. So barriers to be used in conjunction with a highly effective method, an IUD or a hormonal contraception, is something which is ideal for cervical cancer. Barriers to, of course, to prevent the infections. The combined hormonal contraception use post-conization has not shown to affect future disease, and that is something which is useful. Coming to ovarian cancer survivors, well, we know about contraception and ovarian cancer risk. There is a decrease in the relative risk of invasive epithelial cancer, except for the mucinous differentiation and the borderline tumors with hormonal contraception. The protective effect of hormonal contraception also is there in women at high risk of CA ovary, like the BRCA mutation or the Lynch syndrome. And LNG-IUS also decreases the relative risk of ovarian cancer. The epidemiology, well, ovarian cancer extends throughout the reproductive life of women. You have women, very young women with ovarian tumors of low malignant potential, like borderline tumors, germ cell tumors, immature teratomas. And we also know that fertility preservation is allowed for stage 1A epithelial ovarian cancer. And then sometimes you would need a contraception if she doesn't want to be pregnant immediately. So contraception in ovarian cancer survivors, there's no contraindication of the copper iodine, that's fine. Combined hormonal contraceptives also reduce BRCA mutation reduces risk in BRCA mutation carriers, and may be a choice if there is not contraindicated because of venous thromboembolism risks. LNG-IUS uses debatable, benefits are more than risks, but CDC suggests the benign cyst concerns which may confuse a person with recurrence. Gestational trophoblastic disease survivors, where do they stand? Well, the contraception there, a copper IUD should not be used before HCG levels have been normal due to the fear of perforation. Because the uterus is very thinned and because the perforation chances anyway are high, there is some suggestion that you should hold on to a copper IUD before the levels are normal. Combined oral contraceptives is safe and effective, does not reactivate GTD. There was one time where we used to hold on to combined oral contraceptive pills immediately after evacuation and say that we'll wait for the beta HCG levels to come down normal, but that risk in the recent studies show it does not exist. WHO suggests to wait on intrauterine contraception till HCG normalizes, while CDC recommends unless HCG remains to be high. There's no studies on the use of emergency contraception in gynae cancer survivors, but there are also no contraindications, and the general thought is for emergency contraception can be used across the spectrum. So the take-home message is fertility conservation is an integral part of gynae cancers appearing early in the reproductive life, while the idea of fertility conservation, of course, is for getting pregnant and to get a pregnancy fast. But in many cases, that would not be an immediate goal, and a woman would be opting to delay her reproductive life, and intermittent birth control measures would need to be used. Then the idea is which one to use, which it doesn't affect the recurrence and doesn't affect, and that's what this discussion was about. So there are not many recommendations and studies are very few, and in this regard, and the best practice guidelines would be the best to follow. Thank you very much. Thank you very much for your time.
Thank you very much, Basab. I think Manjari is not here, so on behalf of all of us, thank you for very practical hints on what to do.
I'm there, Dr. I'm there, Dr. Jyoti Madam.
Dr. Manjari is here.
Yes, Manjari.
Yeah. Thank you, Dr. Thank you, Dr. Basab, for that comprehensive talk, and it encompasses the correct aspects of contraception in cancer survivors, and it was really good.
Thank you.
Thank you so much.
Thank you.
Thank you. Moving to the next, which is the last session. Without taking too much of time, which is a panel discussion, I request the moderators to please start their screen sharing and get started. I request Dr. Dhairashil Sawant and Dr. Sujata Dalvi to please join us. To save time, can I also introduce our panelists, and I request them to please unmute themselves and switch on their cameras. Dr. Charuchandra Joshi, Dr. Rakesh Neve, Dr. Amish Dalal, Dr. Vivek Joshi, Dr. Ravindra Sathe, and Dr. Lakshmikant Bele sir will not be joining in because he is in OPD. Do we also have Dr. Ganpat Sawant with us?
Hello, good evening, everybody.
Sawant sir, put it full screen, sir, slide show mode.
Yes, please.
There you go. Okay.
Great, good to go.
Fine. So we are the last session of today, and I would at the outset like to thank Harshad for having invited me to conduct this panel, which will be a slightly different type of a panel, as a combination of being what a gynecologist, gynaecologist, surgical oncologist, and a surgeon would be. So with me, I have my co-moderator is Dr. Sujata Dalvi, who is a senior gynecologist from Mumbai. I have on my panel Dr. Charuchandra Joshi, who is a gynecologist from Pune, Dr. Neve, who is a surgical oncologist like me from Pune, Amish Dalal, a close friend, surgical oncologist from Mumbai, Dr. Ganpat Sawant is a gynec lab and infertility specialist from Mumbai, Dr. Ravindra Sathe, who is a laparoscopic surgeon from Pune, and I believe Dr. Bele is not going to be joining us. Is that correct?
Yes, sir. He won't be able to join.
Fine. So without further ado, you guys need to tell us when to stop because we have got about 3 or 4 cases. Depending on how the time goes and how bored or interested you are, we can continue with that.
Okay, sir. Okay.
So the case number 1 is a 57-year-old lady, postmenopausal diabetic. She had a large abnormal signal intensity solid lesion within the left adnexa. The left ovary was not visualized. Fibroids findings might represent solid ovarian neoplasm rather than broad ligament fibroid. Lesion is compressing the ureter with resultant hydronephrosis and hydroureter. Okay, the pap smear endometrial was negative for malignancy. To cut a long story short, she underwent a total abdominal hysterectomy with bilateral salpingo-oophorectomy. Intraoperative findings both were normal, mass in the left broad ligament. The left ureter was accidentally injured, and there was a frank urine leak noticed. The histopath was leiomyoma. The question is, how does one proceed? And I would like to ask the question to Dr. Sawant as well as Dr. Sathe. Would the risk would have been more if performed laparoscopically?
Hello, can you hear me?
Yeah.
I can hear you, Dr. Sawant.
Yeah.
Yes.
First of all, this case, which was a post-menopausal diabetes, so fibroids growing at such a big speed and the post-menopausal itself is little dicey to my mind. But yeah, those reports were showing it's a histopathological, it's a fibroid only. But coming to the report, the question is laparoscopy or open? That depends upon the surgeon. But personally, if you ask me, I'm more comfortable with the abdominal hysterectomy for such a big lump, which is a diabetic and taking long time. So this is purely an individual decision for lap or open. The person with a big fibroid is his individual capacity to handle it. Personally, I'll go with the open hysterectomy, but I'll be able to do it much faster, shorter period in this morbid patient.
Dr. Sathe, what is your opinion on
that? Sir, my video is blocked. So can you just check on that?
Nirav, I think you can get his video on.
But he can still speak. You can start speaking
Okay, thank
till your
you.
video is on.
Thank you, madam. So in my opinion, I perfectly agree with Dr. Sawant sir that it is the choice of the operating surgeon to choose the route, whether he wants to go open or laparoscopy. Depending on your experience, you can definitely say that even if we would have done it laparoscopically, the risk may not have increased in the first place. So now it again depends on the operating surgeon. So if the operating surgeon is experienced,
doing laparoscopy will do damage to the ureter, or do the laparotomy would do more damage to the ureter? That is the question.
Why laparoscopic surgery should damage the ureter more? Because in laparoscopic surgery, we can operate on very close quarters nowadays we are using routinely 3D laparoscopy. So we could have taken as it is, we knew that the ureter is already having infliction and it is already obstructed. So I don't think that would cause, doing laparoscopy would put her to more risk.
Yeah, so this is what I wanted to bring forward, that the rate of ureteral injury in laparoscopy.
Sir, in fact, I would like to say laparoscopy will protect ureter more because it's easy to identify, it's easy to separate, it's easy to this thing. So it is not the damage which is caused by the technique itself, it is basically immaturity, I'll say, by the surgeon and not giving proper importance to the organ, or by whatever, inadvertently taking into your surgical field.
So,
may I add a point, sir?
Yeah.
May I either done laparoscopically or with the help of a laparotomy, a large adnexal mass already compressing the uterus. It is of course a retrospective thing that a DJ stent put preoperatively would prevent the ureteric injury.
I'll come to that question afterwards. So can somebody just enumerate the causes of ureteric injuries that we see? Dr. Joshi or Dr. Sawant, anybody?
Joshi, sir.
Yeah. Failure to identify the course of the ureter. When there is a big pelvic mass, we should first identify the course of the ureter and take every precaution to protect it. If there is a failure on that point, then there are chances of ureteric injury. Then in pelvis, ureter is like three precarious positions. We need to be extra careful while dissecting at that part. Use of cautery or little over-enthusiastic dissection can also cause damage to the ureters. And of course, including the ureters in the ligature.
Common site for injuring the ureter in its big masses is infundibulor pelvic ligament. That's one. Second, at the site of crossing over the ureter, uterine artery. These two important sites. Whereas in a laparoscopy, it is basically at the lateral fornices while opening the vagina. So it's if you see the open surgeries, most of the time when this tumor is widespread, occupying the whole of the pelvis, is the infundibular pelvic plays a very, very important role. In the ligature, most of the time it is been ligated. And in the lateral isthmic level or where the ureter is crossing the uterine, that time it's a common site. These two things.
Amish, you want to add anything more?
I just wanted to say, would you like to trace the ureter first before removing the adnexal mass? Because we generally try and trace the ureter first before you try to remove it. Dr. Amish would want to join and say something else.
Yeah, so my take on this is usually that whenever it's a very difficult case, when you have very severe grade 4 endometriosis, or you have a big tumor, or you have an ovarian cancer which is infiltrating the whole of the pelvis, you in such situations usually you will not see a ureteric injury because you're extra careful. Invariably in a more difficult case, you will trace the ureter all the way. It is in the easy cases that the likelihood of ureteric injuries increases, because you tend to take it very lightly and you think that, oh, this ureter cannot come anywhere close, this is a straightforward case. So the more difficult the case, the more likely it is that you won't damage the ureter. In such situations, when you damage the ureter, it's usually because of the ureter getting involved by the disease or by the course of the ureter sometimes is distorted because of the hydronephrosis or because of the fibrosis. So the more the difficult, less likelihood.
Correct. So what happens next? What if there is a ureteric injury which has not been diagnosed? What will happen next? Dr. Neve.
Yeah, it is ideal to really look for it intra-op only, because going in again is going to be a problem. And it depends on what level of what type of injury you are having. If there is a very big leak and we know that a lot of thing is coming in the drain, I would possibly try to quantify it by doing CT urography and in CT KUB and look at how big the leak.
I'll come to that, Rakesh.
I just wanted to add one more thing. If you are doing a laparoscopic surgery, sometimes you have a delayed necrosis of a ureter, especially when you are using energy source. So that is the time patient presents quite late. So that when patient comes to you, what all things would you like to do? Or what all investigations?
First of all, I'll just add in the beginning, we are discussing laparoscopy versus laparotomy. I have seen.
We are not discussing that at present, sir. We are just discussing how to take care of
the ureter. Yeah.
So I am saying I have seen cases from resident days till date in open as well as in laparoscopy. In open, whenever we suspect, like from oncosurgeon's point of view, they are very careful. For a general OBGYNs, we are not very comfortable in dissecting ureter in full length, and it plays sometimes a difficult task. So first of all, suspicion is very important at the time of laparotomy. When we are in a doubt, we must call a urosurgeon and trace it. We should not take it lightly, saying that kuch nahi hua rahega. And that suspicion is very important, because in one of the cases I have seen the part of the ureter was with the specimen. And that we realized just because fortunately we had a urosurgeon. In the next OT he came and then we traced it and we could locate it and then we diagnosed it. So whereas in a laparoscopy it is a delayed injury, so it's a cautery which manifests after a few couple of days. But in that case also, when you suspect, I think on the table itself we should put the stent.
That's right.
So the next question, as somebody raised it, Dr. Joshi, if you can answer, is it mandatory to have a urologist as part of the team in typical gynae cases?
Well, it is not mandatory, but it is advisable to have someone around, especially if you are dealing with difficult adnexal masses or adhesions. So not mandatory, but somebody should be available.
So would you advise the role of a pre-op stenting?
Certainly, yes. In case of big masses, when
This
already
particular case, yes.
Sorry?
Rakesh?
Sir, in this particular case, it would have been advisable to do it, but if I was to look at this imaging and all that, I would possibly think that it is a benign pathology, and I would be able to trace it, and I would not have stented if. But having said that, if it is being done by routine gynecologists, then they should do stenting. It would help them in protecting the ureter. It is easily identifiable.
So
how it would help us to? It would help us to identify it, feel it. If it is an illuminating stent, much better, we can see it. So the idea is to avoid injury, irrespective of whether the mass is benign or it is malignant.
Yeah. So the bottom line here is that one should not say that I'm the bravest and the bestest surgeon. If it is required, I think you should take the help of a urologist, do a stenting. If you think it's a very difficult surgery and the ureter may be damaged or could have potential to get damaged. How do you clinically diagnose this, Rakesh?
See, actually, it manifests depending on what kind of a thing it is. If it is a complete transaction during the surgery itself, or if it is a late presentation due to the energy device, so it will be coming in the drain. Usually it presents that something is the drain output has increased. That is the usual.
Would you put a drain in patients with a benign pathology like that? Would you put an intra-abdominal drain?
In this case, it would not have been there. Definitely, even I would have not have put a drain, especially in a benign simple hysterectomies, or if we know that this was a fibroid intra-op, then we would not have. In that case, it would have presented as fullness or lower pelvic pain. Or sometimes it does come in from the vault. The leak presents from the vault, that something has suddenly start coming out from the vault. So that also could be a presentation in cases of ureteric injury.
Dr. Sathe, have you got your line on? I think I can't see you here, but anyway.
No, he's there. He's seen.
So the idea is that if at the outset, if you can do a URS with help of a urologist, and then if you can pass the injury and put in a stent, at least the patient will be treated symptomatically. If it's a small leak, then maybe the ureter will heal. Otherwise, if it's a large leak, then you must go and repair the ureter immediately.
If I may just suggest something here, the commonest sign or symptom of a ureteric injury or a urinary leak is the suspicion from the surgeon. Most of the times we tend to brush it under the carpet and we don't suspect it. So any patient who doesn't seem to be settling down in the first 24-48 hours and is looking even slightly unwell, one should suspect that there could be a possibility of a ureteric or any kind of urinary injury.
Okay, fine. And we just covered what to do with surgical treatment. Either if it's a ligature, you remove the ligature, ureteric stenting, or a resection, transuretero-ureterostomy, or a ureteroneocystostomy using a flap or something like that. Yeah. Anything else you want to add, Dr. Sathe?
No, sir. I think I will go with the opinion of the census.
Okay.
I just wanted to say this is theoretical, everything is okay, but suspicion intraoperatively, patient not improving the way I want patient to improve, and then basically suddenly patient develops say fever with chills or 7-8 days, patient says there is sudden gush of fluid, definitely is important. And here I just want to say from my experiences, there is no point in doing stenting in this stage. We must be little more radical. And then I think CT urogram is the best investigation to diagnose and the leak rather than doing IVPs, and straight away take it for corrective surgery.
Yeah, that's true. But I don't think Dr. Sathe is saying that you put a stent for every patient. If it's a small leak,
no, that's just comment.
It's the first step. It's the first step. Yeah.
Yeah. So okay, fine. Now we come to case number 2. Dr. Darvi, you want to talk about it?
Yeah, 64-year-old postmenopausal women. She is a second para, both living issues. She has no comorbidities. Her BMI is 33. Now she complains of postmenopausal spotting since last 1 month. She got a blood investigations done. CA 125 is 20, which is normal. Transvaginal sonography on ultrasound. Endometrial thickness is 3 millimeters. There's no adnexal pathology. Uterus is normal in size. Still, in view of her symptoms, though endometrial thickness was 3 millimeters, DNC was done and the histopath report came as endometrial hyperplasia. And because of that, she underwent a laparoscopic subtotal hysterectomy. Cervix was still retained with bilateral salpingo-oophorectomy, and then her histopath report comes as endometrioid carcinoma grade 1, which involving less than half of the myometrium. There were no lymph vascular involvement as such. And post-operative MRI also showed no residual disease or no nodes as such. What should be the further plan? Whosoever did, he did a subtotal hysterectomy. Probably maybe it was not possible for him to access the cervix or whatever may be the reason. Cervix was still retained inside. The previous histopath report was endometrial hyperplasia. And then we sent the uterus for histopath report. It came as endometrioid carcinoma. Then what do we do? What about the cervix, the lymph nodes?
Rakesh, what would be the staging for this patient, given whatever you have?
Yeah, actually, it's whatever we have. We don't have nodal thing, but it is clearly stage 1. So again, grade 1 also.
Yeah.
So
and it is less than half of the myometrium is involved.
Exactly.
There is no lymphovascular involvement as such.
So one of the next question is, what is the incidence of unexplained malignancies that you see on a normal? So Dr. Joshi or Dr. Sawan, Dr. Joshi, can you answer that? What is the incidence of unexplained gynec malignancies when you do something for a benign procedure?
It is
How common or uncommon?
It varies. It is put as something like from 1 in 70 to 1 in 350 hysterectomies done for some other indication showing some kind of endometrial malignancy. So it can be really alarming type of incidence being discovered on post-operative histopathology.
Yes, Dr.
I,
Sawan.
I do not know the exact incidence, but again, from experience, I can say this patient postmenopausal for so many years, there is no point sticking to the theory of endometrium only 3 mm. Even though it's a 3-4 mm, it is a good endometrium to have a suspicion. Plus, she is symptomatic. So I would have taken out the cervix with the proper precautions, and this is one. Plus biopsy and a surgery, time duration is also important, because if you do a biopsy and we start operating patients after a couple of months, there could be disease which is progressing in between. And
so
there is...
How would it have made a difference if you had removed the cervix?
Cervix, that is the main thing. Whether should you remove or should you not remove the cervix? And when the histopath report comes like this, should you go ahead and please remove the cervix, or should you do some other therapy?
As of now, how does it difference? Because luckily it's an endometrial carcinoma. Or if it is something else, it comes out in the cervix after future, because I do not know for 64-year-old how much this cervix is useful and what is the Indian scenario. India, very few people must be retaining the cervix. So today it's very doubtful situation. So, otherwise, for treatment point of view, I think it is complete at the moment.
So Amish, what disposes to lymph node metastasis? You have a diagnosis like this. You don't know what is the status of, you have what the histopathological data is there in front of you. What do you think predisposes to lymph node metastasis?
So the first thing that I want to say that, when you showed the slide of incidence of cancer, when you don't, unexpected incidence of cancer. Now this is of course data, I think, from the West, where you will know that majority of these patients will be thoroughly investigated before they are operated. So if we were to also thoroughly investigate and then operate, then the chances of unexpected malignancy with the current set of investigation should be very low, probably as low as what these figures are showing. So 1% or less probably. But unfortunately, majority of the times in our country, we don't land up doing full investigations before they get operated. Now, as far as this patient is concerned, what I would really do is look at the uterus specimen, go to the pathologist, check with them how far is the cancer from the area of where it has been cut. Is the cancer coming down towards the cervix or the cervical endocervical canal area or not? If it is staying away, if the tumor is away from the endocervix area and it is maybe towards the fundus, in such a scenario, I would say that the treatment is adequate, mainly because it's a grade 1 tumor and it is not showing more than 50% myometrial invasion. So effectively, it gets put into the low risk category. When it is put into the low risk category, these patients are less likely to have nodal involvement. So the factors which go into lymph node metastasis is basically the grade of the tumor, presence of lymphovascular invasion, myometrial invasion more than 50%, and depending on the if it's a non-endometrioid type, then it is usually in the serous papillary type of tumors that are likely to show lymph node involvement. Clear cell tumors also can land up showing, but then for such tumors, usually they have to be also significant myometrial invasion has to be there. So basically, lymphovascular invasion, elevated CA-125 is really a surrogate marker for serous papillary tumors of the ovary, of the endometrium.
So if you are trying to leave her alone, how will you follow up this patient to figure out whether there are any chances of this thing having?
First thing is to counsel the patient, explain to them that basically you're in the low risk patient group. The challenge is going to be of follow-up. So in such a situation, I would probably do a clinical examination every 3 months and sonography, transvaginal sonography, maybe once every 6 months also, and a pap smear once every year. And in case there is any kind of doubt raised of any suspicious mass, then one should do a CT scan or a PET scan or whatever is required after that. But the first examination in 3 months to evaluate what is the post-surgical status, and thereafter once every 6 months should be adequate.
So you would not advise going down and removing the cervix if the cervix was free and if the cut margins were free?
So if there is an adequate area between the growth of the endometrial area and the endocervix
margin, yes.
Yeah. So if there is an adequate area, then I'm happy with leaving the cervix alone. The other option is, of course, to do a trachelectomy or do a transvaginal removal of the cervix. Some people might argue about doing lymph node, but in these situations, in this particular patient, probably lymph node dissection is not necessarily warranted.
So this is the NCCN guidelines, which say it is stage 1A with low grade, age less than 60 with no LVSI, you can safely observe. Is there any role of vaginal brachy, Amish?
I would hold back radiation as much as possible.
Yeah, so they say that only if it's a lymphovascular stage involvement, then you should go in for vaginal brachy. What happens if this was... Sorry?
May I answer the first part of your question? You had asked, does it really make a difference whether the cervix is removed or cervix is not removed? So I would try and answer that. If the cervix had been removed at the time of first surgery, we would have been far more comfortable that declaring that the treatment is complete and just observe her. Keeping the cervix behind makes us a little uneasy. That's it.
Okay. Suppose this was a sarcoma. Suppose histopath came as a sarcoma. Again, organ confined sarcoma. Rakesh?
Size, sir?
Yeah, same size, everything same. Instead of endometriotic carcinoma, it came as sarcoma.
No, again, if the margins are clean, organ confined, same size, I would observe. I don't think I would add radiation or anything.
I would ask, what is the grade of the sarcoma?
Yes,
if it's
so I think it all depends on the grade of the sarcoma.
Yeah.
And more important than that,
size.
Yes, if it's a size was smaller. Issue is how the treatment modalities available for sarcoma are much different than what is available for endometrial carcinoma. So would that change? Would you like to go in again? Would you want to do something about it, Dr. Joshi?
I don't
Would you
suppose so,
remove
but
the cervix and the lymph nodes and everything if it
well,
was turned out
not
to be a
really, but
sarcoma?
I would like to do a complete workup, including the PET scans, to see if there are any blood-borne metastases. Immediately afterwards,
So
then
all of that
periodically
is
later on.
negative. All that is negative.
Don't do anything.
Would you leave it
I would
alone
like
or
to
would you go
also
down?
No, I would not leave the patient alone, but keep her on a regular follow-up.
Amish?
I think that I would first check the grade of the sarcoma. What is the variety of sarcoma? If it's an endometrial stromal sarcoma, I would probably go back in and remove it, even if it is low grade. But if it is a high grade sarcoma, I think one needs to do a more complete surgical clearance.
Yeah, I think that is more important because so many times it happens.
Dr. Sawant? Hello?
Yeah.
Sir, sorry to interrupt. Dr. Lakshmikant is joining.
Yeah, okay. Dr. Bele, welcome. We are in the second case and we will take you along as the cases go by. Welcome, Dr. Bele. Okay. So, how important is lymphadenectomy in endometrial carcinomas? Is it mandatory in every case? Is it optional? Dr. Sawant.
Sir, I am not a proper person to answer this question.
Rakesh.
But my
I
knowledge
think
is
it's better
limited.
you ask some onco. We are not very
Rakesh.
comfortable with this.
Yes, yes.
Yeah. Actually, we do lymph node dissection in all patients with endometrial carcinomas because we do not know their grades and exact myometrial depth of invasion. We do good MRs, and MRs give you a fair idea of the depth of invasion. But still, we cannot totally rely on MRs, and therefore we go ahead with lymph node dissection with in all diagnosed cases of endometrial carcinomas.
Okay. So,
what does Dr. Amish want to say about lymphadenectomy in endometrial CA?
So my practice is generally that I try to get as much information of an endometrial cancer prior to the surgery is done. So if I have a patient who on the curating has got a grade 1 or a grade 2 endometrioid carcinoma, and on MRI the myometrial invasion seems to be less than 50%. The age of the patient is the other thing I take into account. So if I have a younger patient, the chances are that these patients are more likely to go into the low risk or a intermediate risk group. In such patients, the surgery that I would do is not a type 1 radical hysterectomy. What I would try to do is a type 2 radical hysterectomy, where I'm taking some amount of the parametrium, some amount of the at least a centimeter of the vaginal cuff. So not to stick to the uterus close, get an adequate vaginal cuff, and after that, if and do a lymphadenectomy, at least a pelvic lymphadenectomy. I'm presuming that the imaging findings of an MRI, abdomen and pelvis has not shown any obvious lymph nodes. If there are obvious lymph nodes, one has to of course do a full clearance. But if there isn't any obvious nodes, then at least a pelvic nodal dissection, which encompasses the internal iliac, obturator nodes, and maybe some superficial common iliac nodes. At least this much can be done. And this does not add to the morbidity. If you land up doing external iliac nodes also, then the morbidity is known to increase. And the retroperitoneal nodes, I will do it, pelvic and retroperitoneal nodes would be done definitely if it's a grade 3 endometrioid carcinoma. If it is a clear cell tumor or a serous papillary tumor, then 100% the full lymph node dissection should be done.
True. So the
Sir, with my limited knowledge and for my clarification, now when we say disease is less than 50% limited, there is no need of lymph node. And to find out the extent, somebody suggests do CT scan because CT scan will delineate lymph nodes better. Whereas the whole discussion just now we are doing about MRI. So which is a better investigation? Is it a CT scan or is it a MRI? Because
MRI.
for us it's a
MRI.
I think there is no doubt that the
Okay.
MRI is the investigation of choice. Not the
Anything to do with cervix or endometrium, one has to do an
MRI is
MRI.
better.
It's the better quality investigation. And of course, on table, you can section the uterus to check whether the myometrial invasion is 50% or more. An experienced surgeon will be able to tell you that, whether the myometrium has gone beyond 50% or not. And that can also determine whether you need to do a more extensive lymph node dissection. So if the myometrial invasion is more than 50%, by all means, do a more extensive nodal dissection.
So myometrial invasion by naked eyes, you mean to say?
Grossing on the table. Grossing on the table.
Taken as standard of care, as Amish is saying, somebody who's experienced and seeing this thing, if you can make out, then you should look at or send it for frozen and see what the report goes. So the take-home message would be, if it's an early disease, you can let it go and keep on the patient under very, very close observation, and that should be the answer, and not go in and operate or radiate any of these patients if it's a very early disease. Okay. So we come to case 3. She is a 23-year-old engineering student, unmarried, with no medical or surgical past history. Her images for adnexal cyst with thick septae, few mural nodules. MRI was very similar. CA125 is again 25, neither here nor there. She underwent a laparoscopic right ovarian cystectomy, and the HPR came as borderline serous ovarian tumor. Micropapillary area seen, no microinvasion. How does one go ahead with it? Dr. Joshi?
I think it completes the treatment. We keep the patient under observation.
Okay. Epidemiologically, it approximately 15 to 20% of all early ovarian cancers. And although there's a recent decreasing trend, the percentage of BOTs among ovarian cancers is actually increasing. So, Amish, would you like to comment on this? What would you like to do next? And if there's what difference is there between borderline ovarian tumors and invasive ovarian cancer? What would you look at as differences between the two?
So first thing to understand is that these borderline tumors are not the ones which progress to high-grade tumors. Borderline tumors are borderline right from the beginning. They do not change. So first thing is that this girl needs to have a proper oophorectomy on that side. You cannot do just a cystectomy. Otherwise, the risk of local recurrence is pretty high. So when you're doing that same side oophorectomy, one should give a complete wash because of the cyst having been ruptured. Maybe take some biopsies from that from the pelvic peritoneal area. But the chances are that you will probably see nothing on that. This girl can have a fertility preserving uterus.
I'll come to that. I'll come to that ahead.
Yeah, sorry. Okay, so I would probably just do a completion oophorectomy and do a washout with maybe some peritoneal biopsies.
So your imaging would you add any other tumor markers to it, or would your CA125 be enough to guide you on what?
CA120 for borderline, if the histopath has confirmed borderline, a 23-year-old, the tumor markers won't necessarily help.
And these are the basic differences between borderline and invasive. Average age is different. Survivals, we all know. I think there's been a lot of talk on borderline ovarian tumors, I think yesterday. And there is a difference in BRCA mutation in these patients also. So as Amish said, now what is the role of appendectomy in mucinous borderline ovarian tumor? Do you consider that, Rakesh? Would you like to do that, or what is your opinion on that?
Appendectomy for mucinous tumors is recommended, and it should be done. Only the question remains how will we get it diagnosed beforehand, whether a frozen is going to tell us or not. That's the problem. But in this case, if we are going back to do the oophorectomy as Amish sir suggested, then we should definitely go ahead with appendectomy in mucinous tumors.
What about lymphadenectomy?
Lymphadenectomy in this particular case can be avoided if we do not have any suspicious lymph nodes in this.
Dr. Behle, any opinion on this? What would you do? Dr. Behle?
You're talking to me?
Hello? Yeah. Yes, Dr. Behle.
Okay. Well, what we normally do is, in a case like this, is to take out that tube and ovary, obviously preserve uterus, other tube and ovary. In the past, people used to do wedge resection, but that does more harm. And if the ovary is grossly normal, we don't do any wedge resection or anything like that. If I'm the surgeon, I will do lymph node plucking, just take out the nodes that are enlarged, if at all, and do a partial omentectomy. But if everything
is that going to increase the survival, or
Yeah.
is it just staging?
Pardon me?
Dhairashil?
Yeah.
This is Dr. Shashikant Lele from USA who is joined in. It is not
Yes, sir. Good evening. Or good morning to you. Sorry.
Yeah.
Okay, all right.
Yeah, he is Dr. Shashikant Lele from Buffalo University.
Okay, good morning. I just wanted to ask, instead of wedge resection, would you take a biopsy if you're going in second time from the opposite ovary?
Second time? What do you mean second time?
What opposite ovary? What would you do?
Oh, for the opposite ovary, you said you don't take wedge resection. Would you
No.
at least take a biopsy from that opposite ovary?
You should not, because it alters fertility, causes more adhesion. So if the grossly normal ovary, you do not do anything. You just leave it alone.
Just leave it alone. Yeah.
Dr. Lele, your take on this?
Pardon me?
No, Dr. Lele.
Yeah, he is only the one who you're speaking to just now.
Okay.
Okay. I'm so sorry.
He's the one who
Okay,
answered.
fine.
Yeah.
Okay, so as you said, Amish also said that when only cystectomy is performed, relapse rates are high. Hence, idea is to go down and do an unilateral salping oophorectomy, whether it is serous or mucinous. But in mucinous, then you need to add an appendectomy. That would be
appendectomy, omentectomy.
In mucinous tumors, you don't need to do lymph nodes at all. It's the serous tumors that are likely to spread. Mucinous stage 1A, you make sure the appendix is normal, because a lot of times it is a spread from appendicular tumor too. So in mucinous tumors, we do appendectomy, but there is a two opinions. If appendix is normal, we may not do it, but a lot of people will do appendectomy to make sure there is no appendicular tumor, and this is a secondary.
Okay, Dr. Behele, what about fertility preservation?
Absolutely. You keep our other tube ovary and uterus intact.
The one thing that I want to add here is that the lymph nodes by definition are not likely to be involved. And even you get implants also, they are usually implants. So the overall prognosis in these borderline tumors is very good. So you can always go back in and do it a second time if it is required, if and when there is a relapse.
Even if lymph node come positive, we do not treat them.
Do not need to give chemotherapy.
There is no treatment, even if omentum or unless it's an invasive cancer, we do not treat them at all.
Yes. Dr. Joshi, your take on fertility drugs and risk, whether it increases, it remains, what do you do? What is
Before I answer that, I would like to add one more to your earlier part, that this girl must be kept under continuous surveillance periodically by ultrasound, because there is a chance of bilaterality, and then she may end up losing the other ovary also.
Yeah. Okay.
Dr. Sawant, about the last question which you asked, whether the infertility drugs increase the risk of ovarian CAs. Till date, we were believing that all the drugs which are used on the patient undergoing ART might have a high incidence, but the latest data shows no, there is no increase in ovarian CAs because of ART treatment, or she's been exposed to infertility agents.
I think Rishikesh also alluded to something of that sort.
Yeah, he spoke about fertility preservation.
So laparoscopy or laparotomy? Dr. Sathe and Dr. Sawan. May Dr. Sathe, Dr. Sathe to tell on this?
Laparoscopy or laparotomy, depending on your level of expertise, the size of the tumor, and what line of treatment that you want to take. So suppose it's a small swelling and the patient is ready for a small incision, then we can offer her laparoscopy. Otherwise, laparotomy should be the choice.
As of now, my choice is laparotomy because of the reasons are what we think may not be the findings intraoperatively, and that is the most tricky. That ovarian malignancy is one of the most tricky malignancies, from diaphragm till the pelvis. I mean, anywhere it can be there. Those scope can see, but with the palpation and with handling and with so many things, I still believe laparotomy. As of now, at least, I will prefer laparotomy.
So
I
the
would
only
agree with Dr. Ganpat. I would agree with Dr. Ganpat because of the fear of upstaging the disease. Any suspected ovarian tumor should be treated with laparotomy and not with laparoscopy.
Very good. Any adjuvant treatment? Amish? Yeah, Rakesh.
Not for a completely resected tumor, you won't require any adjuvant treatment in borderline ovarian tumors.
But even if it was incomplete, what you would have gone down and taken it out? It's still one. You don't want to add anything else or long term, any SERMs, anything else? Rakesh?
Yeah, if it's ER positive, then we can consider tamoxifen.
Okay. Okay. How do you follow up? Dr. Joshi, how do you follow up?
We follow up regularly with ultrasound scans and CA-125.
Okay. What is
CT-MRI for regular follow-up will not be required unless there is a finding on ultrasound. Ultrasound is readily available and inexpensive, so it would do very well for a regular follow-up. If it gives us suspicious findings, we can further use those imaging techniques.
So there is
how regular follow-up? Every 3 months, 6 months, 1 year? How regular follow-up?
If there are no symptoms, then I suppose every 3 months for the first year and less frequently later on will do.
So there is a lot of debate used to be there before that you allow her to complete her family and then you go down and remove the uterus, the ovary and complete the surgery. How relevant is that now? Dr. Amish or Dr. Lele, what would you like to say about it?
So I think that first thing to understand is that sometimes some of these women who are very young and who have a borderline ovarian tumor, one should also check their AMH levels. You might find that their ovary reserve is very, very low, and that there is a general ovarian failure in these patients at a very young age. So in that sense, in that sort of situation, to keep waiting for them to have children, and that is the reason for waiting, that is probably may not be correctly addressed. So I would think that do an AMH and give them a reasonable idea whether they are likely to be able to bear children or not. And after that, I think you can just keep them on a follow-up. There is no rush to going in for a second surgery to remove the other ovary and uterus. It's not that every patient is going to get a recurrence in the other ovary.
What if she relapses?
So if she relapses, she needs a proper laparotomy. At that point of time, one can do a complete clearance. And because it's basically borderline, one should be able to give them a good enough a survival just as good as what you would do even if you operated earlier.
You can still offer her fertility preservation?
It depends on the extent of the relapse.
Okay.
In case of patients of tamoxifen for a longer time and the uterus which is preserved, the endometrium thickness looks more on sonography, and which confuses us thinking that she has developed endometrial hyperplasia. But on biopsy, we may not be able to get the sufficient tissue, which otherwise non-tamoxifen patient will yield us more of a tissue. So that physiological change in the endometrium, we have to keep it in mind. This just, I thought I would mention that point.
This was a multivariate analysis which showed that higher stage, incomplete staging, tumor residuals and organ preservation could be independent prognostic factors. And neither microinvasion or micropapillary growth pattern showed any significant impact. So one needs to go down and take out that ovary, do a proper salpingoophorectomy on unilateral side. And then if you need, then you can observe. So in summary, for these type of patients, you need to have a good staging restaging if the abdominal cavity are not thoroughly examined during the first surgery. And one has to be very, very clear when you plan this restaging. Oophorectomy is more preferable. Fertility is possible in younger patients with stage 1. Laparoscopy can replace laparotomy. Adjuvant treatment are not recommended, and the treatment of recurrence, if the patient wants to preserve fertility, second facility, if required, should be performed. But as I said, this is a very individual call and needs to be discussed with the patient thoroughly before we go ahead with it. Okay, now that's what is the NCCN guidelines. Which states that if it's prior complete resection, no invasive implants observed. If it's invasive implant, we look at serous. We discussed all this, I think, in the future. We have time to go for the next case. Nirav, Harshad?
They have left already.
Yes, sir.
No, sir, we are very much here.
Very much here, sir.
25. So it's all up to you.
Okay,
Yeah.
you can go on. I have no problem. People don't want to have drinks, have dinner, then they can go on. Anyway,
maybe we can discuss this case. Yeah,
one case we can have and
yeah, then
So
okay.
we could have one case, because tomorrow also we've got a very long day of
No problem. So this is the last case we'll discuss it. Correct. This is the last case we'll discuss, and then we'll wind up.
Thank you so much, ma'am. Thank you.
Yeah. This is 52. Sorry.
Postmenopausal lady. Sorry, you go ahead, madam.
Yeah, this is 52 years old, postmenopause lady with no comorbidities. BMI is 24. Her main complaint is abdominal distension last 4 months, constipation last 3 months, and she gives history of loss of appetite last 3 months. Examination, there is generalized distension, moderate ascites, but there was no mass palpable per abdomen. PS, cervix, and vagina were atrophic, and there is no discharge. When you do per vaginal examination, cervix was normal, non-tender, but there was a hard fixed pelvic mass which was felt 12 by 12 extending from right adnexa all throughout, filling up the pouch of Douglas to the left. Uterus was not felt separately. Rectal mucosa was stretched over the mass, but it was mobile. There was no rectal growth on per rectal examination. Systemic examination was normal. CA were 1.27, but CA 125 was 2220. Next one. Then on CECT, there was a right adnexal solid mass which was there, left adnexal solid mass of 6 by 4 and right adnexal solid mass of 11 by 6. Multiple soft tissue deposits were seen on the mesenteric border of colon. Largest one was by 5 by 4. Multiple pre and para-aortic lymph nodes were also seen, and there were multiple lymph nodes forming conglomerate mass of 6 by 3 centimeters in anti-mesorectal fascia. Multiple mesenteric lymph nodes were seen. There was moderate ascites. Ascitic tapping was done, and ascitic fluid was sent for cytology, which showed a metastatic adenocarcinoma. So she underwent 3 cycles of neoadjuvant therapy. Post 3 cycles, a CA 125 came down to 75 units per ml. Again, repeat CECT showed a complete resolution of ascites. Adnexal masses is also reduced in size, and there was partial resolution in the size of the nodes as well as the soft tissue deposit.
So now I think
you take over.
Basically, she underwent surgery. Day 3, she developed a fever. Lab shown elevated WBC count with a high CRP and high PCT. Abdominal drain and a turbid color, 200 to 300 cc's per day. Dr. Sathe, you have a reference like this. How will you proceed?
Third post-op day, yeah.
Dr. Sathe.
Yeah. So definitely, if the patient has a turbid color, that means that there is some viscous injury, and that's the reason that she is presenting.
So how would she present? How would you think a presentation would be of for a classical perforation, which is now probably iatrogenic or surgical?
So one of the usual common causes when we do a omentectomy, if it's too close to the colon, that's one of the reason. Plus, we don't know exactly what surgery was being offered and being done. So I think that's the opinion. That's the only opinion we'll have to go in and re-explore.
The entire pouch of Douglas was frozen. You underwent a radical surgery, so there must have been some tear either there at the rectal or devascularization which caused it. How do you investigate these patients? Rakesh.
Yeah, we would have to look at our blood counts. We have to see if there is how much is the raised WBCs. Then straight away, I think I would go in for a CT with contrast to find out where the problem lies, whether it's the transverse colon as was being suggested, or whether it's a rectal injury. And with that information in hand, I think the re-laparotomy is the only option to go and repair that.
Dr. Sathe, when will you not operate? What are the
I
indications
think
for you not to go in? What are the things they look for in the patient?
if the patient has pedal edema, that would indicate that the patient has involvement of the vasculature, then and then only. Otherwise, going in and putting drains will definitely treat the patient well.
So is there any size seen on CT at the amount of output that you see? Amish, would you look at any of these signs, whether you want to say you don't want to go into these patients and do a conservative management? Surgery, we know, is probably the best answer to it.
Yeah.
So the first thing is, if you find a localized perforation and a localized collection on CT scan, one can put in a pigtail or a drainage tube into that under CT scan guidance, and then wait and watch whether the patient is improving or not. But if it is a documented GI perforation, then irrespective of whether it's localized or not, one would need to go, especially if the presentation is on the third day.
Yeah, I know. It's a fairly early present, and one of the things that we look out is if the patient is presenting. If it's a third day, that means it's a intraoperative perforation, and that really needs. And it's this 300, 200, 300 is an high output. When we call it something like a high output fistula, and then 100%, I think we need to go in. But if patients we may observe put in, as I said, if it's a localized one, coming in late. Maybe a 7th, 8th day, maybe one can do conservative. Surgery is anyway surgery. But again, laparoscopically or laparotomy?
There's no question about laparoscopy.
Good. I think that should be the reason I put that slide is that yes, you have to go down, do a laparotomy, because we have seen for even people who are diehard laparoscopic surgeon, if they find a leak, again they will want to do a laparoscopic surgery to try and seal it. But I think here in these patients, laparotomy would still be the best answer.
Yeah, I think we wind up, but I just wanted to ask one question. Here in this patient, would putting in a drain in the primary surgery when we did it for the first time, would it have helped rather than not putting in a drain?
The drain is already there, madam.
No, he said there was no drain.
So would you put a drain in an ovarian case, Rakesh?
Yes.
In this,
you are doing a massive surgery, yeah.
Yeah, I would, sir. With that lymphadenectomy and all that, because she had a lot of lymph nodes, so 100% I would put a drain.
Amish,
I always put a drain, because most of the times I would have resected the rectum at the same time.
Correct. So you have to be safe and sure and put in a drain, and that would. So I think we have exceeded our time, and I would like to thank all my panelists, Dr. Joshi, Dr. Neve, Amish, Dr. Ganpat Sawant, Dr. Ravinder Sathe, Dr. Lakshman Lele, and Dr. Sashikant Lele from the US for having had a very conducive discussion so late in the day. This is a conference that we are having 2022. We were going to have it in 2021, but the China virus has made us change our dates. So please remember this. If you all want to register, the registration link is there, and you can go down and register anytime. Again, like to thank Harshad and his team for having invited us here to be moderators. Thank you so much.
Thank you, sir. Thank you all.
Thank you for
excellent
moderation.
Everyone.
Thank you, everybody.
Thanks, Harshad. Thanks, Ashwini and
can we have
POGS.
Dr. Harshad sir kindly say a few words?
Yeah, Harshad.
No, I think I heard enough of us now. But excellent. I think Dhairyashil, this panel discussion was really going great guns. I didn't want to stop it. A lot of controversy. Initially, when Dhairyashil told me these are the 2-3 cases, I was skeptical whether how it would go, but it is really going great guns.
Thank you so much.
Also, there has been a lot of efforts that have been put in. Dr. Ashwini ma'am is also here. And there is one more day which is lined up. We've got a long day and we're going to start early at 9 o'clock. Dr. Ashwini, would you like to invite everybody to come tomorrow as well?
Yes, of course. I would like all of you to join tomorrow morning, 9 a.m.
Yeah, and more important today, I just want to pitch in. Even today, we had a very good attendance. What the sheets tell us is somewhere the attendance is somewhere around 2,800 is the attendance, which is very, very high as compared to what we expect for our oncology conferences. That shows the level of interest that it is generating. So I think for ICC, you must take a target of 25,000.
God willing. तुझ्या तोंडात गुळ टाक.
Harshad, Ashwini, excellent show. Congratulations.
Thank you, everybody. Good night.
Thank you. Bye, everyone. Thank you.
Thank you so much. On behalf of Team POGS, signing off. See you again tomorrow in the morning at 8:45. Thank you so much. Good night.
Thank you. Good night.
Thanks. Bye. Bye. Bye.